everyone. Can I ask you to take your seats? And just like that, a hush descends upon the crowd. Good morning, everyone, and a very warm welcome to the 2025 All-Ireland Conference on Integrated Care. It's a pleasure to open today's event here at University College Dublin and to welcome 300 colleagues from across the island for what promises to be an inspiring and energising day. It's lovely to look down in the audience and see some familiar faces, but also to see some new faces, and maybe someone's going to raise their hand and say, "You're first-timers here?" Yes, we definitely have some. Yeah, great. Well, you're very welcome. On what is a beautiful spring morning in Dublin. So spring has sprung and we are full of energy today and optimism, but also it is wonderful for all of us in our various roles to be able to take time out and reflect on what we are doing and reflect on how we might deliver change, or indeed we might work together and develop new relationships and new partnerships. We're also live streaming the conference and we will be joined by another 300 delegates online. So a big welcome to you if you're online, and thank you to our partners Sláintecare for supporting the live stream. I can't go on without mentioning Anya and Fiona, and I just want to acknowledge the work that goes into putting on a conference like this, and I think we should give them a warm round of applause for all their hard work. So I'm speaking to you today as the chairperson of IFIC Ireland, the regional hub of the International Foundation for Integrated Care. Our ambition is to advance integrated care policy and practice by connecting people, sharing knowledge, building capacity across professional, organisational and geographic boundaries. At the heart of that ambition is a belief that education is one of the most powerful enablers of change. To deliver a truly person-centred, compassionate and coordinated care, we need to invest in people and people who make that care possible. Clinicians, managers, carers, researchers, community leaders and people with lived experience. That's why IFIC Ireland is committed to supporting lifelong learning in integrated care. And we offer a range of learning opportunities to suit different needs and career stages, including an online certificate in integrated care, a postgraduate diploma in leading people-centred integrated care, and an accelerated learning programme. In the context of today's conference, focused on the future workforce, we want to emphasise how important, how vital ongoing professional development is to sustaining integrated care. Learning is not a one-off event. It's a continuous programme of reflection, collaboration and growth. Of course I would say that, wouldn't I, as I've been in the University of Ulster for over 30 years. But what I do know in that time is the idea of a job for life is gone. Our students are not interested in a job for life. They're interested in a lifetime of jobs. And we have to ensure that we have the workforce to deliver that for people. And they'll want to move around and change in a way that perhaps we would have found strange or unusual. But that's the world we live in. I think it's important, before I go on, to thank our supporters. So I want to take a moment to thank those who've made today possible. A sincere thank you to our supporters, which is the HSE, Sláintecare, Health Pathways, Streamliners and Value Care. Your partnership and commitment to integrated care is deeply valued. We also want to thank our exhibitors representing research projects, and I hope some of our impact projects from the north are here. I think they are. Patient organisations, charities and commercial partners. Please do take the time today to visit the exhibition area, meet our partners and look at the amazing work that's on display. Now, I have to go through, you'll come to expect this if you've been to a conference, housekeeping notes. Wi-Fi is available through UCD Wireless, and for those of you who are academics, you can find us on EduRoam, so I hope you're not using your 4G but are tuned into the wireless. Plenary sessions will take place here in the O'Reilly Hall. Breakout sessions will take place in the O'Reilly rooms B and C, which is essentially just at the back of the hall, the Cedar and Cypress rooms, which are upstairs, and the robing room, which you will have passed as you come in. The poster hall is in O'Reilly Halls B and C, and don't forget to go and have a look at those. And don't forget to use Slido throughout the day to take part in polls, answer questions at the start of each and the finish of each plenary session. All plenary sessions are recorded and will be shared on the IFIC Ireland website. And this is an important bit. We want you to join the conversation. So on the one hand, we're saying make sure your phones are on silent. But on the other hand, your challenge today is to ensure that our hashtag is trending. I was going to say trending on Twitter, but my children keep telling me that Twitter doesn't exist anymore. So we're going to be trending on X. And the hashtag is up, I think. It's hashtag AICIC25 and hashtag integrated care, and tag us at IFIC25. Using the recordings and the feedback throughout the day, we will prepare a conference report that will be shared with the delegates at the conference. But we would also really like your feedback, so if you wouldn't mind completing a post-conference survey to help us improve. If you hear a fire alarm, please exit calmly. We're not expecting a fire alarm, so hopefully it won't happen. And if you need help or you're not sure what session you're in, just visit the registration desk as you came in at the door and they'll be able to assist you. Unfortunately, the Minister of Health is no longer able to join us and we are disappointed. It was a personal issue at a short notice. It would be remiss of me, though, not to have some schadenfreude to note that it seems the politics of the South is equally dysfunctional to the politics of the North. I just couldn't resist it, sorry. However, we are delighted to welcome Bernard Gloucester, Chief Executive of the HSE, who will open the conference. And after Bernard's keynote, we'll begin our day of learning and discussion by looking at the expanding workforce. Who makes up the care workforce? In plenary 2, we'll focus on investing in people, our workforce, carers, communities and citizens. We'll then move to breakout sessions, hearing examples of integrated care throughout the island. You'll also have the chance to attend the Sláintecare session and hear about policy and practice innovations. And finally, we will all come together to explore how we can build an agile, resilient and future-focused workforce. We really hope that today sparks new ideas, builds new connections, renews new energy to advance integrated care in your own work. And for many of you sitting here thinking, haven't we heard this before? Haven't we been on this roundabout for quite a while? I think the message for the people here today who are the improvers, who are the people who want things to change, is in the words of that great philosopher Elvis Presley. A little less conversation and a little more action, please. Okay, so I'm going to now introduce you to Bernard. Bernard is the Chief Executive Officer of the Health Service Executive, the HSE. Bernard has more than 34 years of experience in health and social services. Before rejoining the HSE in 2023, he served as CEO of TUSLA and previously held senior roles, including Chief Officer of the HSE Midwest Community Healthcare. He brings a wealth of insight from both community and acute service delivery. So please join me in welcoming to the podium Bernard Gloucester.
Thanks, Deirdre. It's lovely to be here and at a health service conference. Can I just say, please forgive my voice. I'm coming at the tail end of the worst diagnosis possible in history called man flu. So just forgive the voice a little bit, but it is lovely to be here. It's lovely to be with you. And can I just this morning extend also again the good wishes of Minister Carol McNeill. She sent me a message bright and early this morning, very early in fact, to say she very much regretted that she just could not be here this morning, and it was genuinely unavoidable. And I've had the pleasure of working with her now in the short few months she's been in office, and I know her interest in the subject matter that you have today is genuine and sincere, and I have no doubt she'll get to connect with many of you in different ways and in different engagements over the coming months. But her good wishes genuinely come to you for your deliberations today. I'm also delighted that my colleagues, my Deputy CEO, Damien McCallion, some of our regional executive officers, Dr. Annie Phillips and Tony Canavan and others, are participating so actively today. They're the people with the real substance of knowledge of what we do and how we do it and what we're trying to do and what we struggle with. Finally, just before making some opening remarks then, I'm delighted particularly to be here at this conference with my very, very good colleague and long-time friend, Dr. Anya Carroll, who's always been such a positive promoter of everything to do with care, not just integrated care. And long before we were talking about integrated care and other things, she is just such a solid contributor to the improvement of healthcare delivery in this country for the very reason it matters, and that's the people we serve. And so it's lovely to be here with you, Anya, and with your colleagues. Today you will talk about many things, but I do want to perhaps touch on two aspects that are covered in the conference agenda for today. And forgive me, I don't tend to use PowerPoints or written scripts, so if you feel this has gone a little bit off the mark at any point in time, sure, that happens. But I do just want to emphasise a couple of points that I think are important today, because they are the points of what I call the real world. And very often when we engage in discourse, we can tend to detach ourselves from actually the reality of life and the life experience of the people who work with us and the people we serve. And because we want to consider things and we want to consider them properly and we want them to be better, we do sometimes need that removal, but we need to remind ourselves that what we might come up with when we talk, when we sometimes come up with a view and we say, isn't it simple? Sure, isn't it very simple if we did that? Well, actually, the one thing I have now come to know, and the bio is a bit old, so I'm 37 years now in the public service, but the one thing I've come to know is if it was simple, it would have been fixed long time ago. So simple is not a word that I generally tend to associate with concepts around care. But one of the themes you talk about today is workforce. And I often wonder how much do we reflect on the importance of workforce, the challenge for workforce, and the need to understand the reality of it. It's hard to believe that in the Health Service Executive and our Section 38, what we call public service partner bodies, we've over 148,000 full-time equivalents now. It's an enormous amount of people. We're the biggest employer in the state. But I keep reminding people, we don't employ people. We're not an employment agency. We don't employ people for the sake of it. We don't employ people for the crack. We employ people to do something. And we employ them to do something, and that something is part of a bigger picture of some things that come together, the sum of which is meant to be greater than any of the individual contribution. And what is it ultimately for? Well, it is ultimately for that thing that sounds simple but is not simple. And that's the delivery of seamless care. That's the delivery of what's called integrated care. That's the delivery of what's called a pathway that somebody can navigate, and to deliver that to an individual. And I get to talk every day about 5.5 million people because my responsibility is to 5.5 million people. But I have to essentialise that every day and remind myself that actually there's an individual in that 5.5 million people. And so when we talk about workforce, what do we really want to achieve with and through our workforce? And we have to create opportunities for the workforce, and Deirdre quite rightly said it, the day of a job for life is long and well gone, and perhaps that's not such a bad thing. But equally there's an importance of the job while it is being done, and while the person occupies that job. And so today, as you debate workforce, as you talk about integration, and as you talk about the workforce of the future, I would ask you to all the time essentialise it back down to what's the basic point we're trying to make? What's the basic point we're trying to... Is integration, I keep saying to people, is integration a structure or is it a behaviour? It's an interesting question. I haven't yet come up with the answer. When I was a much younger worker in frontline services, I kind of thought, well, nobody up there in management had any clue really what it was. When I became a senior manager a very long time ago, I thought it was all about structure. Sure, if you only had the solid lines right, and if that fellow would only report to him and shut up and do what he's told, wouldn't it be grand? But it isn't really. And then I've explored things like matrix structures. It's really important. And at the end of it all, yes, structures are important to administer certain processes or to fulfill requirements of governance. And Anya and I had a brief chat about the much misused word governance there before we started this morning. But integration goes way beyond that. It transcends all of that because it is about concepts. It is about behaviour. It is about where we position ourselves as professionals. When I want to be part of a service that's integrated, do I want to do that because I want to be excellent? Do I want to be seen as excellent at what I do? Or do I actually want to be part of it to allow all of the parts together to be excellent? Not for us, not for me as the professional, but for the people who are on the receiving end of that service. Does my understanding of integration relate to, and does it have meaning for the person who will this morning wait on a hospital trolley to be admitted to a ward to receive care for a particular issue in their lives? Does my definition of integration mean something to a person who is at home caring for a person who, for a whole variety of reasons, be it in a social care construct or a medical construct, has a level of dependency that requires support and help every day? Does my definition of integration mean something to them? And of course, we explore definitions of integration in the literature. There's some wonderful, wonderful literature, and it's wonderful that we have people who contribute to that body of knowledge all of the time. And whether we go to Canada, whether we go to Scotland, or whether here in Ireland now in the body of literature emerging, do we take all of those thought processes and all that we explore? Do we take the WHO definition, or do we take any other definition? Do we take the experience and insights from other countries? Yes, of course we must do that. Yes, of course we must do that. But then we do have to essentialize it back down to that which is not simple, but which must almost sound and appear simple. That which relates to the life of the person we serve. That which relates to making care better and to improving it. And so today, as you talk about the workforce for the future, can every part of our workforce feel that aspiration and that passion and that will to drive integration, not because it should make us feel good as individual professionals, but because it should improve what we do as we collaborate and work with others and disagree with each other. God help us that we wouldn't talk about the fact that we disagree as professionals. Sit around a case conference table any day of the week and you will see the views. You'll see the shared views, the collective views, but you will see the disagreement. There's nothing wrong with that, provided the disagreement doesn't become about us. And so again, I say, when we talk about integration, can we repeatedly say what integration means, what it means to us, but what it means for others? And I firmly believe if we keep the focus on that, we will perhaps come to the more mature understanding, as I certainly have attempted to do over recent years, that this is a continuous improvement. It's an ongoing process. It is all of the time defined as iterative. It is not something in a box we can say, tick, done. The day we say that is the day probably whatever we've achieved will start to slip again. The other thing you talk about today in one of the sessions, I guess, is very much related to that and related to the workforce. That's building relationships. Never have we been more challenged in the variety of professions and disciplines and subsets of our organisation. Every time rightly, there's an advocacy for us to specialise in a particular need. We must remember that every time we create specialism, we create the potential for disintegration. That is not to say we should not have specialist interest. We absolutely should have specialist interest. We need specialist interest. We would not be way outstripping the European average of life expectancy in Ireland if we didn't have specialist interest. We would not be as improved as we are in so many things if we did not have it. But it is then our responsibility to be ever more guarded that that specialist interest doesn't become a place of even potential selfishness. Because in the specialist interest, I want to pursue my own specialty. And I should do that. But I should always want to do it only for the benefit of the people it serves. And if we know from international evidence that the benefit of the people we serve is further advantaged by the behaviour of integration, by putting ourselves and our own interests second. We are public servants. We do come second. And I have to remind people every day, we come second to the public interest. Because the difference between us and the public is we aspire to and we're paid to be servants of those people. And so let's pursue specialism, but let's remind ourselves that it's not about us. Let's pursue integration in what we really understand that to mean. Let's pursue shared behaviour, collective behaviour, even in disagreement, in the public interest. Then perhaps we won't see integration as something off out there in the future. We'll see integration as something we have with all of its flaws, but with all of its possibilities that we can continue to pursue and continue to make better. Have a wonderful day. Thank you.
Thank you, Bernard, for giving us food for thought in your opening session. And of course, the food for thought is, what is integration? What does it actually mean? And our experience from the north when we have an integrated health and social care system is, it isn't a marriage of equals. There's a poor relation in that relationship, and that's how it's been since 1972. And that's nothing to do with structures. That's about culture. It's about expenditure. It's about, even though talking the talk of prevention, we seem to be firefighting, and I can only speak for the north, we have a love affair with hospitals, which I think we're going to have to address one day. But thank you very much. And throughout the day, we will think about integration and what that word actually means. But importantly, from this organisation, we will learn from other people and other experiences throughout the world as to how they've managed to address that whole issue of integration and make their health and social care systems work in a way that we want to see them working. So at this point, it gives me great pleasure to hand over to Damien McCallion and Anne Lawler, who are going to take over proceedings from this point on. Do you want to come up to the stage?
Good morning, everyone. Damien McCallion is my name, and my colleague here is
Anne Lawler.
So we're going to introduce the first two presentations, and then we move to a panel. So Anne will take you through just the people presenting in the first round here.
Okay, thank you, Damien. So we have Dr. Niamh Lennox-Shugiani and Breda Rafter.
Go to the bus for them, please.
Right. Good morning, everybody. I was just saying to Bernard that he has, of course, completely stolen my thunder. He said everything that I'm now about to say, but that is so encouraging to hear from the CEO of the HSC. So I'm going to talk this morning about some definitions around health and care workforce and what that means in the context of integrated care internationally and the challenges that you're not just facing in Ireland. Every health and care system in the world is facing, if not identical challenges, then very similar ones. So when I was preparing for this presentation, I was looking up some images of health and care workforce. And one of the first images that I came across was that of the health workforce. Yeah? No. Not moving. Moving now? Great. So, health workforce I put into my search, and then I put in care workforce. And what was fascinating to me is the very different images that came up. Health workforce, well, they all had white coats and stethoscopes and suits, because we all wear suits in healthcare. For the care workforce, they were dressed in civvies. They were dressed in ways that the people that they were caring for related to. Now, I know that not everybody in health dresses like that, but it's interesting that those are the images that come up when we talk about the different workforces. And that, I think, is a theme that Bernard touched on in terms of, or actually it was Deirdre touched on, in terms of culture. That actually we've got very different cultures in health and care, even though we talk about them as if they're the same thing. So that's sort of challenge number one that I put out there this morning. A quick reminder about what are we actually talking about in integrated care. Sorry, this is not working. Great. So the core features of integrated care are people-centered, community-centered. It's about coordination and continuity of care. That's what we're talking about when we're talking about integrated care. We're also talking about meeting the quadruple aim. And we often forget that one of the elements of the quadruple aim, on the next slide, is staff experience. And we too readily forget that actually that is really important to the delivery, not just of integrated care, but of high quality health and care as experienced by the person at the center of that care. So again, as part of my image search on the next slide, I looked up workforce, health and care workforce, and all of these images came up of these people madly multitasking. I have a couple of questions about why the same person seems to be both a nurse and a doctor. I also have questions about the rictus grin on that person's face, and I think that's something that probably many health and care professionals who are delivering really complex tasks on a daily basis probably have a sense of understanding about. But just going on to what do we actually mean by workforce? Workforce is a term that came into use back in the early 20th century. It's largely an economic term, and it was used to try and quantify labor and treats labor as a commodity to be traded. I have a set of skills, I sell them to you so that you can use them in turn to generate income for an organization. So I think it's worth also bearing in mind from a cultural perspective that that's the starting point of our use of the term workforce. And yes, it has become a shorthand for how we talk about a group of people in institutions, but I think it is really important to bear in mind that it's done in that context of a tradable commodity. And I think it's something that is worth reflecting on how appropriate that is in the context of something that is relational. And I'm going to talk about that a bit more in a minute. But just going on to the next slide, we're all aware of what we all talk about as the health and care workforce crisis. All this quote will be very, very familiar to all of you. We're all aware of where the deficits are in health and care today. And just going into more detail, a study recently looking at the challenges around our workforce crisis in all sectors identified a number of different factors. So one of the first factors that was identified was the lack of IT and digital skills. We could move on. Thank you. There are also a range of other factors. So there's a lack of analytical thinking and critical thinking across the workforce in general. There is, we could just keep moving, just keep clicking through. Lovely, thank you very much. There's a lack of interdisciplinary thinking, and I think that's something that we see in healthcare particularly. There's a lack of ability around decentralized decision making. I would say that actually this is not really about a lack of ability. This is about a centralized sense of control in a lot of systems, and certainly we see that in healthcare. There's also shortage of workforce with specific skills, but equally I would say that there is a shortage of workforce with a real sense of generalism, a real hold on what it is to be a high quality generalist. And another area is the unequal distribution of workforce. And this is common across all sectors. This is not unique to health and care. All sectors identify this, and all of these things are connected. But the other thing I would say about this is very much a deficits model. This is looking at the gaps and what's missing. It's not building on the strengths of the workforce in that widest sense of the word, paid and unpaid, that we have in the system. And I think that's the focus that we need to shift, is to that strengths-based approach. So just coming back for a moment to integrated care. This is a conceptualization of integrated care that's actually really helpful as a framework to think about what is important in building integrated care. So we have context over here, and if we overlay our workforce health workforce crisis onto that, that's the context supposedly we're looking at the moment. I think Bernard really helpfully talked about structures and our tendency to look at structures. And if we get the organogram right and the number of people we stick in numbers under that organogram, everything's going to be fine. Yes, it's really important. Enabling structures and formal processes are really, really important, but they are not sufficient. What is missing quite often from our thinking is that bit in the middle, the interpersonal bit, the relational, the social. And really fundamental to the delivery of integrated care is interdisciplinary working as a completely new way of working. And it is more than multidisciplinary team meetings. It is far more than that. It is about the creation of a whole new body of interdisciplinary knowledge that includes the person and their caregivers and the wider community. And I know the panelists are going to talk about that in a lot more detail in a minute. Process integration is about a shift to relational care. And Bernard touched on this. It's about relationships. That is what drives integration. It is the fundamental to it. And then where we land when we get it right, well, a better experience for the person at the center of care and a better experience for our health and care workforce. Everybody is happier, and we know that from the research. So the work of, if any of you have heard of Professor Alison Leary, she's a researcher on health workforce based at Queen Mary's University in London. And she's written a lot about some of the dangers of specialization and what she calls taskification in healthcare. Our focus on activities and tasks to get the job done and breaking up specialisms by task. Also breaking up competencies and skill mix by task. Now, her position, and I agree with this, is that actually what you end up doing when you do that is you value certain tasks that are at the top of the hierarchy as the most important tasks. Therefore, we pay people better, but not just that, we value their work more. And actually, it's the work we value at the bottom of that hierarchy that is, in many ways, the most important work that is done, because it's often the most relational. It's the work that means people don't fall through the gaps. It's the work that enables care to be experienced as coordinated, continuous, and seamless. It's the work of healthcare assistants, it's the work of care coordinators, it's the work of the voluntary sector in signposting people and helping them navigate their way around the system. And this is the work that we often value the least. And that is a shift that we really need to make in how we think about health and care. So if we look then at how we think differently, relational care is a concept that's been around in adult social care for a really long time. And I think it's something that we need to look at adopting within a healthcare setting as well. Because fundamentally, as I say, integration is experienced as a product of the relationship between the person at the centre of care, the caregiver, the community, and the health and care workforce. And we need to focus much more and give more time to the building of that relationship and value the building of that relationship and the time that it takes. So we need to stop designing out of our processes the time of building relationships. And that comes back again to my point about valuing people's time in a different way. So, a set of questions that I pose today as you go through the day. How do we help and support the health and care workforce to shift from that idea of work being a series of tasks to be completed during the day to being about relational care that reduces fragmentation as it's experienced by individuals? So who's in the health and care workforce? Back to my original question about that concept of workforce. If it's a tradable commodity, and I'd argue that actually probably it isn't, who's in and who's out? So are we including the voluntary sector in there? Are we including caregivers who are unpaid? Who's in and who's out, I think, is a really important question. What needs to be done in the short term to be retaining our experienced health and care workforce, because that is a huge challenge? How do we recognise the care that's provided by voluntary organisations and by caregivers, by people at home who do by far the bulk of providing care? And what support do we need to give to the health and care workforce to develop those relational skills? Because they're often being trained out of people, unfortunately, in undergraduate study and even in postgraduate study. So what are we doing to bring those back in to the way that we train, educate, and develop our health and care workforce? And how are we involving the people at the centre of care, communities, in this conversation? Because actually they will have a lot to say that's of value about the future direction of the health and care workforce. And just a final point to say that we have conducted over the last 18 months a review of education, training and development for integrated care internationally, and we'll be publishing that study in the next couple of months. So if you're interested in getting some information about that, do sign up to our newsletter and you'll get information about that. But I'm really looking forward to hearing from you all today about some of the solutions that you're coming up with to not just retain, but to develop and grow a new kind of health and care workforce that's going to deliver on the promise of integration. So thank you all very much for your time and have a great day.
Thanks very much. Some very thought-provoking there. Myself and Anne were saying we wouldn't have done the work and the questions for later if we'd known they were going to be in the slide before this. So just too late, there you go, in terms of planning. But thanks very much for that and lots of thoughts on it. So myself and Anne are here just going to introduce Breda Rafter from the Department of Health, and then we'll take a seat down and we'll be back up with our panel. And I think you'll see the connection between our panel and the two presenters. So over to you, Breda.
Good morning, everybody, and my name is Breathe Rafter. I am head of the Strategic Workforce Planning Unit in the Department of Health. It's workforce planning for the health sector, and I'm delighted to be here today to talk about the work we're doing in the department in relation to workforce planning. So really interesting presentations there ahead of mine. So we have the Strategic Workforce Planning Unit in the department leads on workforce planning for the health sector. So we have responsibility for health and social care workforce planning activities, and including working in collaboration with the higher education sector, the HSE, the regulators, the professional bodies to improve the availability of health professionals. So a recent OECD study highlighted our reliance on foreign educated workers. So 43% of our doctors and almost 52% of our nurses were foreign trained in 2023. So recent Coru data also shows that for physiotherapists, occupational therapists, radiographers, radiation therapists and dietitians, more than 50% of those registering in 2024 were newly qualified abroad. So building and growing our future student pipeline, as well as attracting and retaining a highly engaged workforce, is more important than ever. So this graph, the CSO graph, just shows the increases in the number of persons over the age of 65 under the CSO population projections for 2023 to 2057. So these projections are stark, really, in terms of their implications. So the CSO projects that the total Irish population will increase from 5.1 million in 2022 to between 5.7 million under the low migration assumption and 7 million under the high migration assumption. Under the medium migration scenario, the percentage of the population aged 65 years and older is projected to increase from 15% in 2022 to 29% by 2057. The total population aged 65 years and over is projected to increase by 1 million persons from under 800,000 in 2022 to 1.87 million by 2057. So these CSO projections have significant implications for future workforce demand and for future demand for health services. So in terms of the workforce, in 2023, Ireland had 3.9 practicing doctors per 1,000 of population. This was up from 3 in 2014. So this compares to 4.2 practicing doctors across the EU 27. In 2022, we had 13.3 professional nurses per 1,000 of population, and this compares to 7.5 professional nurses across the EU in 2022. In 2024, the number of practicing physicians stood at 20,961, and the number of practicing nurses was 76,558. So we have a good proportion of nurses. There were, as Bernard mentioned this earlier, there were 148,268 WTE employed in the health service at the end of December, and this is an increase of 23.7% on December 2019 figures. So there have been significant increases in the workforce in the last couple of years. So in terms of the composition of the HSE workforce, so nursing and midwifery represents the largest staff category at 32.2%, followed by patient care at 20.1% and management admin at 16.8%. So in terms of the work in the department in relation to workforce planning, so in 2022, we commenced a project to build capacity in workforce planning in the department and then to address the long-term workforce planning needs of the health sector. So the purpose of this project was to develop a scenario-based projections of health and social care workforce supply and demand to inform ongoing strategic health and social care workforce planning. A key deliverable of this project was the development of a health and social care workforce planning model. So this model offers an approach to projecting our long-term workforce planning needs for the health sector, both public and private. So this is a significant improvement on what we would have had in the past. So I suppose our preliminary analysis shows that the likely gap between future supply and demand of healthcare workers is significant. Our early modelling projections from the workforce planning model showed that we expect to have a shortfall across most of the health and social care staff categories over the coming decades unless there is significant increases in third-level student intake or continued large-scale immigration of foreign doctors and foreign educated doctors and nurses. The population demographics are the major driver of increased demand, and it's anticipated that the average annual growth in demand of professions modelled will range from between 1.3% to 2%. So the modelling framework is designed to provide medium to long-term projections over a 20-year time horizon. So I suppose the projections and the analysis points to significant policy implications. So we need to significantly increase domestic supply of healthcare workers. So a big part of our work in the department is working with the higher education sector to increase the student pipeline across all the disciplines. We need an intersectoral cross-government approach to planning is required. So this should include health, the higher education sector, and disability and education, because they have requirements for healthcare workers as well. But as I said there earlier, that work is ongoing, and we spend a lot of time, we engage a lot with DFARISH and that, and the universities regarding expansion of student places. We need to improve the quality of the data. Improved data is needed to improve the understanding and expand the model outputs. So we have really good data on nurses and doctors and in the acute sector, but it's a big challenge for the health and social care professionals. We really found with our modelling work, it was very difficult to get data across the professions and the HSCP professions, and also in the community and in the primary care sector. So we're working with CORU now to improve that data collection, and CORU have a new database, so which we're very thankful for the work and the engagement and the partnership. The partnership actually we have with all the regulators, like we work with the Medical Council, the NMBI and CORU in relation to data collection. So in terms of workforce reform, as I suppose the earlier speakers were all touching on this, we need new ways of working through redefining teams and skill mix to optimise performance. So in terms of integrated care, so the department in collaboration with the HSE is undertaking a technical support instrument project, and this is funded by the European Union and delivered by the OECD. So the project is titled Towards Person-Centred Integrated Care, and it's about aligning the health service workforce in Ireland with the needs of the person and population. The project aims to support Ireland in its efforts to implement healthcare reform. So specifically, the project aims to assist in the design, implementation and evaluation of the multidisciplinary workforce model for integrated care, and improve coordination then between acute and community-based care, and to learn from best practices from other jurisdictions. And I think the earlier speakers all touched on that. And it is a key challenge to develop this work, really. So in terms of progress to date, we have two reports. The first report was Good Practices in Delivering Integrated Care, and that draws on examples from the Netherlands, Denmark, France, Ontario. And we had a study visit to the Netherlands as well, and another number of people across the integrated care programmes joined us on that study visit. And then the second report is Getting Health Professionals Ready for Integrated Care. So both of these reports are up on the OECD website. So in terms of stakeholder engagement, so as part of the project, the OECD have engaged with the clinical teams working to deliver integrated care in older persons, chronic diseases and children and young people in two HSE health regions, so the Dublin and Midlands region and the West and Northwest region. So these service areas were selected for their geographical spread and their urban and rural divide, and the different levels of integration maturity across the health system, so that good practices could be identified and challenges. So a situation analysis report was developed as part of this project, and that looks at a limited number of existing examples of the integrated care pathways across the hospital and community services, across the three integrated programmes I mentioned, the IFIC, the Chronic Disease Management Programme and the Children and Young People. It describes the Irish healthcare system and the delivery of integrated care. The report does not seek to give an exhaustive account of the whole of the health system, but rather it highlights, or integrated care, but rather it highlights key information that is specifically relevant to the objectives of this project. And really, this project is about looking about the team, the multidisciplinary team, and how that operates on the ground. So that situation analysis is complete, and that will be available on the OECD website shortly. So just in terms of our preliminary findings from the situation analysis, the information gathered highlights areas of strength in the current approaches in the delivery of integrated care, but also some challenges. So having a shared vision and a goal for the team, delivering integrated care, frequent communication and informal interactions with the team and outside of the team are key factors to support delivery of integrated care. Shared physical space, co-location was pointed to as contributing to both improved team coherence and vision and improved communication. Patients and carers have positive responses to existing programmes, and the integrated team members report being able to deliver better care closer to patients' homes. In terms of the challenges, to the effective delivery of integrated care include the lack of a single information sharing platform, staff shortages, and the lack of co-located physical space for some teams, as well as the existence of multiple lines of governance. Some of these challenges are already being addressed by policy and reform efforts already underway. But while the results of this information gathered were from a limited number of teams, the identified strengths and challenges are likely relevant for integrated care design and delivery in the Irish healthcare system more broadly. So, building on the situation analysis and the review of the international best practice, the evidence suggests that a workforce model for integrated care needs to focus on giving health professionals strong integrated governance structures, the right skills and competencies, and building effective working practices, including workforce tools. To fully deliver care in an integrated way will require a shift in workforce skills, knowledge and competency, governance and effective tools and working practices. There isn't, I suppose what we have found is there isn't a one-shot model or a team structure that can be pursued. Rather, it's a shift in perspective, organisation and resource use that needs to bring along the entire workforce. And I think the other contributors would have highlighted that as well. So in terms of the model we're seeking to develop for the teams, to work effectively in an integrated way, health professionals need integrated governance lines, the right skills and competencies, and effective working practices. So to deliver these objectives, the HSC needs to map operational clinic and clinical governance lines in existing multidisciplinary teams, embed knowledge of integrated care throughout professional training, and provide IT supports and develop resources, guidance frameworks for effective practice in integrated multidisciplinary teams. So I think as Deirdre and others were outlining there earlier, education is key to delivering on these objectives, the education around integrated care. So there's a need to, and I think Bernard spoke about this, there's a need to ensure that all professionals working in the health service have a common understanding and a knowledge of integrated care in the context of the Irish healthcare system. So, I mean, there seems to be, like from our working in this area, there are many understandings of what it actually means, and I think the other speakers would have pointed to that. So we really need to have a common understanding across all the health and care professionals. So to embed the knowledge of integrated care throughout professional training, the next phase of the project will develop and test a short pilot introductory training on integrated care for professionals working in integrated care teams, which could eventually be expanded more broadly across the entire health and care workforce. We feel this is a positive step. This is a positive step, improving the knowledge and understanding of integrated care amongst health and care professionals. While there is a good level of knowledge and skills within the integrated care teams, it's not the same level of common understanding and knowledge across the entire workforce. So in terms of my concluding remarks, I suppose considering the population demographics, there are limits to the growth and expansionary policies that can be pursued. And it's not really sustainable to rely solely on increasing the number of healthcare workers in the longer term. Like, it's not affordable. And this is a conversation. I mean, we work a lot with the WHO and with other EU member states in the area of workforce planning. And this is a conversation that's taken place across all EU member states, that it's just, you know, we can't just continually be pursuing expansionary policies. We need to look at new ways of working. So it's essential to consider new innovative solutions to enhance productivity and efficiency of healthcare delivery while maintaining worker satisfaction. And I think Niamh touched on that earlier. I mean, the retention issue is a key thing as well. We need to, you know, ensure we have policies to retain our workforce. Building staff knowledge of integrated care needs to be supported by digital and governance structures that foster integrated working and the right tools and practices. Like, for example, digital infrastructure and information sharing capacity to make it possible to work across care settings. And finally, and I know there's a lot of work underway in relation to that with the digital strategy. So finally, I would like to thank colleagues in the HSE, the integrated care teams who have given up their time and contributed to this project and assisted with the outputs. In particular, Dr. Siobhan Nivreen and her team, and the Health Regions Implementation Team, and clinical leads and teams across the integrated care programmes. Your contributions to and assistance with this project is greatly appreciated, and we couldn't really deliver the project without the cooperation and help we are getting from the teams on the ground. So that has been really valuable in progressing this work. So thank you. And my contact details. So my contact details are there, and if anyone wants to contact me either today or later, happy to engage.
Thanks to Breda and Niamh for those insightful presentations. I'm not going to stand up on that stool, or I'll be about 7 foot like an American basketball player or something like that on it. So very insightful. We got an international and a local context. You'll be glad to know our panel are going to have all the answers to all those questions, not to put any pressure on them before they come on the stage at all. The first thing I should say, I'm really glad that the CEO's number of people employed in the health service at 146,000 was exactly the same as the Department of Health. I can assure you that's not always the case, so that's a good starter for the day, at least when the numbers add up, it whets our appetite. So I'm going to introduce our panel, and joking aside, I think you'll see that the panel actually reflect, I think, Niamh's point about the stereotype images you get when you draw off the system in relation to the images of the workforce. One is we're far more diverse probably than what you see, and the second thing is it goes way beyond those employed in that 146,000, and hopefully you'll see that in our panel, that healthcare is much more than just those of us that work in the system. So without further ado, I'm going to call our panel up. So first up, Mary Bridget Collins, Primary Healthcare Coordinator in Pavey Point. And you can clap at the end, I should add, just as the hands were about to get going there, Mary Bridget. Next is Professor Martha Curley, co-founder of the Innovation Value Institute in Maynooth University. And Jennifer Glansford, who's our volunteer coordinator locally here in the National Rehabilitation Hospital.
And then we have Jackie Brown, who is board member of the International Foundation for Integrated Care, and Tony Canavan, Regional Executive Officer, West and Northwest.
So they're all very welcome. Someone told me years ago when I was nervous going up on a panel, just imagine you're sitting here, folks, like you're in a bar stool in a pub chatting about workforce, and it'll hopefully relax everyone around it. So we have about 30 minutes, and we will have time for some questions if people want. There'll be a roving mic here at the end as well. So just to give people that option if they want it.
And also, Tony, I've been reminded about the Slido question. So if you would please engage with that, we'd be very happy. Thank you. So what needs to change to ensure we have a vibrant care force in the future? Slido.com. Yeah, join it at slido.com, hashtag AICIC25. Thank you very much.
Okay, over to you first.
Thank you very much, Tony. Could I start by just clarifying something? So my name is Anne Lawler and I'm unpaid. And I've always thought that the people with the problems have the solutions. And I have two passions when it comes to health and social care. One is integrated care and the other is patient partnership. So I'm really happy to be here today to talk about that. And I'm delighted to have Joe Ryan here with us, who's the National Lead for Patient Partnership, and the support of Bernard, because I think this leadership and vision for working with, I don't work for the HSE, but I certainly work with them. And I think without that leadership and guidance and support from the top, what we have achieved to date in patient partnership would not have been achieved. So I'm delighted to have this panel here, and I'm going to start with Mary Bridget. Mary, you know, we've heard some stuff about the healthcare workforce. So if we were to reimagine that, because you're a little like me, you're also an informal carer. How would we see it with more involvement from us? What would you see that could might make that change happen?
Well, I know for myself, I looked after my own mother for years before she went into full-time care, and it was difficult work, and it was a full-time job, and as you say, not being rewarded for it. If you were working at the same time, you had to work a certain amount of hours, even though you're looking after them 24/7. But I am involved in a primary healthcare project, where there's about 27 primary healthcare projects through the whole country, and we live and we work in our own community as primary healthcare workers. I suppose the importance of the primary healthcare projects is giving information to the community in a culturally appropriate way as well. And I suppose we're a little bit different to health professionals, is that we work in the community and we're on call 24/7. So the work is very important to us, because sometimes the communities might get their information but get it in a very different way and mightn't understand it. So we as a primary healthcare project, we want to make sure that people get the information in a way that they do understand it. So it could be about doing resources, it could be about doing videos, again, in a way culturally appropriate, again, for travellers and for Roma out there. So I think that's very important for us as a primary healthcare project. I think the changes that we would like to see, I suppose, for primary healthcare workers, and this is something we've been pushing, and we know we have the National Traveller Health Action Plan, and I know there's probably people here for the Department of Health, but it's paying conditions for primary healthcare workers, which is huge for us, and this is something we've constantly bring up a number of times. And also then we have the medal cards, where people are losing the medal cards because they might be just €1 or €2 over the limit. So if you look at the huge health inequalities the travellers face, and therefore you would be more times up at the GP, and therefore you would use more GP services. But yet if you've no medal card and you have to hand out €60 of €140 that you might be getting as a primary healthcare worker. So we've always kind of fought for the medal cards for primary healthcare workers, but also for paying conditions that would be in line with people that would be within the HSC as well. And I suppose it's the importance of the work, because we wouldn't be able to do it on our own, but also the HSC wouldn't be able to engage with travellers on their own. I think the partnership is very important as well, and that's crucial for primary healthcare workers, so it is out there, yeah.
Thank you very much, Mary Bridget. Could I ask you one other question? You're working in this space for quite a while now, aren't you? Did it take you long for yourself to value the work that you've done?
I think, again, I came in a community development scheme at a very early stage, and I suppose when I came in, in, I think it was 2005, I think it was, we were getting this money from the Department of Health to do a huge All-Ireland health study. And I really like research, and we were very much involved in the All-Ireland health study. Now again, all the primary healthcare projects through the whole country would have been, but it shows the huge health inequalities that travellers are facing within Irish society. They were dying much younger than the general population. Out of 40,000 travellers, we only got 8 travellers over the age of 85 years of age. Life expectancy for travellers is 64 years of age. Education levels, and we're talking about the app, and we're talking about all these digital things that will come in. And I would have seen during COVID that we really need to be careful. It's quite dangerous that if you're looking at people with low literacy levels, older people that can't use stuff like this, we need to be careful because we don't want to lead people back any further than what they've already been left back. But I do value the work. I'm very, very interested and always have been, and always been pushing the issues of travellers around traveller health and stuff like that, but particularly for the primary healthcare projects as well. But I do love the work and I'm very passionate about it, and I think that's why I'm so long there. But also I think when you look at health, and a lot of health professionals might not look at the social determinants of health, and that's really important for us. Like I didn't hear it in any of the slides there. So if you look at people within the homeless crisis, and we've nearly 40% of travellers are homeless. So in the long run, you're looking at children who can't eat healthy meals, no cooking facilities. So therefore, obesity is going to set in at a very early age. The workforce, we won't have anybody for the workforce. If you look at the discrimination and racism that travellers and Roma face, like the main source of employment is primary healthcare projects for travellers, traveller groups and traveller organisations. Of course, we would like to be looking further in as GPs and nurses and midwives, and we do have them. We've people within the police force as well. But at the same time, there's a huge fear of them coming out and let people know who they are because of experience of racism and discrimination. But I think the social determinants is so crucial when you come to anybody's health, but particularly to travellers' health. Accommodation is huge out there. There's a huge accommodation crisis. No proper facilities out there. Maybe one tap between 2 or 3 families. Overcrowding is a huge problem. And again, we would have highlighted it very much during COVID, where social distance was huge, washing your hands. Washing your hands might be very simple for lots of us. I had a 4-bedroom house. I found it difficult to distance myself from 8 people. So could you imagine living in a trailer with maybe 3 or 4 children, maybe a young baby out there? And that was a really difficult time for travellers out there. And then when you look at the frontline workers and you look at the frontline payment, primary healthcare projects didn't qualify for the frontline payment, and it was real insult for the work that they done during COVID. Now they qualified all right for the vaccination, but it was a bit of a contradiction. Well, if they qualified for the vaccination, why did they not qualify for the frontline payment? So that was huge, and it was a huge insult to the primary healthcare projects out there. But I do love my work, and I'm very passionate about my work.
Thank you so much. Thank you.
And Mary Bridget, one of the things you mentioned earlier is how can we attract more travellers into the actual workforce alongside the primary health set. Any thoughts on that about what we could be doing in the HSE? And I might come to Tony then just for some thoughts within the HSE. How could we attract more people in? What do we need to do? And I know there's work in Youth University and Dublin South East on this.
Yeah, and I know we've worked with Youth University as well by getting travellers in and doing a course out there in youth and community work as well. And I think there is lots of way, and I think the way it's working with the traveller groups and the traveller organisations and making the link with them and kind of making contact with them, that there is ways that travellers can be brought in and can be encouraged to be doctors, to be nurses, but also come out at the same time and being proud who they are. But I think there is a huge piece of work to be done there to encourage more travellers to take up these, and particularly within the HSE. Like if you look at all the jobs within the HSC, is to open them out and give information out to the traveller groups as well. But I think it's about encouraging them as well, that jobs are out there, yeah.
Tony, any other thoughts on that, just from our perspective?
It's not easy, to be honest with you. I mean, I suppose ideally what we would want within the West and the Northwest is a workforce that represents the population that we're serving, and I think that would help us in terms of the appropriateness of the care that we're providing, the effectiveness of the care that we're providing, but also the sustainability of it over the longer term. But we know that it's not easy to achieve that. There are some groups that that the system is set up and geared towards attracting them in terms of education and career development, and then progressing into employment within the HSE. So you do have to go. You have to go that extra yard to be able to make sure that that there are groups that are marginalised and for lots of different reasons, maybe are outside of that kind of steady, easy stream, and that. So we have worked with the University of Galway particularly to try and develop that a bit further. But we've got an awful lot of work to do still on it. So.
Just I might stay with you, Tony, then, just in terms of you're one of our regional CEOs and REOs looking at a big region with a big workforce. From a leadership perspective, what do you think we can do to drive and achieve some of the things that were set out earlier for integrated care within your region, say, as an example?
So I think first of all, it's important to remember that we have to deliver today. So we don't have the luxury of being able to say that we're going to think about it and put a strategy in place, and that we know that we're confident that if we do all this, that in 3, 4, 5 years' time everything will be fine. We don't have that luxury. We provide care every single day, so we have to focus on that and make sure that we continue to deliver on that. And that means that in Galway today there's a CNM that's worried about a gap on her roster to be able to provide safe care, maybe in the emergency department and similarly in community public health nurse gaps and so on. So we can't ignore today. We have to stay focused on that. But if we only stay focused on that, then I think we're going to miss out on an opportunity that comes with the reforms that we're implementing right now. So I mentioned the sustainability piece earlier on. I think that's really important. I think that we have. We haven't, I suppose, maybe maximised all the opportunities that exist within the region to attract people that are living and making their lives and being part of communities within our region to become part of our workforce, either our formal workforce or informal workforce in delivering healthcare. So we certainly need to work on that further for sure. I think as well, though, that we need to, I suppose we need to, a little bit like what was being said earlier on, we need to be very clear about what we're trying to achieve. And I'm not sure that we're there yet with our workforce. So some things we're very clear about. We're pretty clear on what we want to achieve day by day. And, we talked about, getting people through the system and the processes and the numbers. But I think the bit that we're less clear on about is the outcomes that we want to achieve. And unfortunately, tend to be defined over longer periods. And so I think that's really organisationally where we need to shift in order to be able to develop a workforce that's focused on the outcomes and is shaped to be able to deliver them.
Just anything in terms of the teams, we're seeing more and more multidisciplinary teams in areas like mental health, in areas like disability. Just how do you see that developing, or what stage we're at in terms of those teams and developing those interprofessional teams with other stakeholders, volunteers, community workers and so on? Yeah,
I mean, I think there's been some really, really good work, and certainly there's the basis for a lot of further progress that can still be made. So a couple of the programs that we've developed over the last while, the integrated care program for older people, which is combining hospital and community-based services, and that has developed well, particularly in our own region. It has developed very well. Chronic disease management programs, they also have developed very, very well. I think the next challenge then for us will be to I suppose, first of all, to make sure that we have them spread in a systematic way across all of the region and providing consistent care, but then that they're reaching out and becoming part of the greater part of the communities that they're serving. So they're still very much part of the formalised health service and the health system. That's fine, but I think there are huge opportunities for those teams then to reach out to voluntary groups and informal carers and a host of others as well, in order to be able to extend the care that we're providing on a truly partnership basis, and not just on the basis of people using our services. Yeah.
Thanks, Tony. Jackie, I'm going to come to you next, and you're another person who's interested in patient partnership and doing things with us rather than to us.
Absolutely.
So can you see any practical steps that can be taken to truly embed patient partnership into the system?
I think there's lots of practical steps you can take, but I think one of the first things we have to do is include the patient voice, include the diversity of voices around the table, just like Bridget you've spoken to, and I'd be representing the voice of disabled people. And too often, too long, organisations, including voluntary organisations, have spoken for us and about us, but it hasn't been our voice. And that needs to change rapidly. It's beginning to change, and the people you need to talk to, it's very similar to travel, you talk to disabled people themselves. We now have national disabled persons organisations, and they're the people that need to be at the table in those conversations, to be embedded, to even get into spaces like primary care and that. One of the things that I've really struck by this morning, really great stuff, and I've really struck by and pleased to hear, we have to think long outside of structures and just workforce planning and population projections and things like that, because we haven't even really identified or spoken about other things apart from geopolitics or future pandemics, God forbid, but things like AI, the future technologies, assistive technology, how they can change our lives for the better and for worse, and how they might be to replace or do different tasks or jobs that we currently identify and put 3 or 4 years of third level education planning into. So we need to be a bit more flexible in that way. And the other thing that I think that we haven't really spoken about, it's been referenced for sure, but what do we mean by culture? That culture as a practical step. And that culture is about, yes, we have to deliver a service, and you are under that fire brigade pressure of delivering a service this hour, this minute, every minute of every 24 hours of the day. But there has to be space and time to allow people to communicate, to allow people to have a dialogue, to allow people to look at not just developing strategies and about a lovely glossy brochure, but actually developing conversations about what could we do differently, or how could we work together, and why, or should we include or talk to the people who are the patients or the people at the centre of the service? Because I'm not getting that sense still. I mean, we talk in Sláintecare, right care, right place, right time. What is that? What does it look like? How does it feel for me as a patient, as a recipient of a service, and how does it feel for somebody delivering the service? Two very different things, but I don't think we've had those dialogues yet. And I think, just finally, to finish just for now, and I'll tell you why we have a long way to go. If they carried out, as it always does, annual surveys, and it did an annual survey last year, 2024, and in that survey of nearly 600 people that answered the question on integrated care, and I've only pulled out just one literally slide, and I'm not even putting it up there, to what extent do you think that people-centred care is being delivered today, based on our needs, preferences and the values of people at central care? So 3 different groupings answered, and to my horror and real surprise, only 21% of people recipients of care feel that there is integrated care being delivered. That's a shocking low number. And yes, more than double of the health workforce thought they were delivering integrated care. There's a mismatch going on there that we need to address if we really want to talk about integrated care.
Yes, Jackie. I suppose my other hat is my 22Q hat. So, and I'd be remiss of me really not to talk about rare diseases in this context, because people would be surprised to know that 1 in 17 people has a rare disease, and also generally they are multi-system conditions. So in the personal sense and the lived experience, and this is why I really believe we really have to bring in the lived experience on par with everything else that's happening, all the structures, all the clinical stuff. But without that lived experience, you're missing a huge piece of the picture. So, you know, if you talk to one of my parents, I call them now, in our group, who are currently experiencing coordinated care. I'm not sure if it's the same as integrated, but it's coordinated care through the clinic now in Crumlin Hospital. They have nothing but praise for the way it's been conducted. I'm not saying it's perfect, everything is work in progress, but they would have nothing but praise for it. But it was the lived experience of the families who brought this together. And it does make that needed difference. I mean, if you went to my family's, Jackie, I'd say that are experiencing that in the paediatric clinic, all of them would say it wouldn't be 26%, it would be the whole lot of them.
Yeah.
Yeah, yeah.
And clearly that's a big challenge to us in the system, the fact that the public perception is one figure and we in the system feel something else. And as you say, Jackie, it's how do we bridge that gap? One of the points that was made, Breda made it earlier, and indeed yours could be an intro into it, and we didn't stitch it up, was you mentioned the technology and digital side, and Professor Martin Curley is here. So Martin, maybe just to get a take on how can technology support us in terms of some of those workforce challenges and integrated care, just your thoughts on that and some of the points that Jackie and Breda raised earlier.
Great, Damon, thanks, and congrats to Anya and Niamh and Fiona. Great conference. I think in life, Damon, there are very few silver bullets, but I actually think digital is the silver bullet for healthcare. So I want to give 3 examples, not the 2 from Michael Lowry yesterday, but the first is this shift from, and Niamh, you talked about it, the workforce to a care force. And I talk a lot about stay left, shift left 10x, which is proactive health mindset using digital technology to give transformational outcomes. But increasingly, one of the Copernican shifts is a shift from paternalism to partnership, and Dr. James Mountford talks about that, or from passive patients to participation. And increasingly there are things that doctors and nurses do today, the patients are going to do for themselves. So, for example, at our UN Digital Health Symposium, one of the doctors there saying they're now prescribing to their patients AI-powered stethoscopes so the patients can do all the analysis in their home, and the doctor only gets alerted, when there's an issue. So today, we all, we used to have to go to a check-in desk at the airport, and that was done. We all do it at home, it's on our phone. So that trend is going to happen. So the workforce is going to dramatically expand. There's going to be a shift to the patient away from the clinicians, and digital is really democratizing information. And this shift is going to happen because there's always been a power imbalance between the clinician and the patients. The patients have been ignorant, they've never been empowered. But now often we have patients going to see consultants that actually know more and have more data than the doctor. So I think that's the first piece. So the workforce is going to dramatically expand, and it's going to include the patients. And our focus won't be actually on fixing illness, it'll be on keeping wellness. I think the second challenge is, in Stay Left, Shift Left 10X, we identified 10 major problems, but the biggest problem is actually productivity. So if we can fix productivity, we may even have too many people in our workforce. That might be scary to imagine. So last November, the Innovation Value Institute with the Drucker Forum in Vienna, we announced the Next Management Initiative for healthcare. And just to explain the basis of that, Peter Drucker, one of the the leading management thinkers, what happened during the Industrial Revolution is the productivity of manual labor improved by 50-fold, 50x. So the challenge, the Next Management Initiative is, if we could improve the productivity of knowledge workers, and particularly clinicians, by 50-fold, that would be dramatically transformational. And we actually already have the evidence that that's happening. So using AI scribes, and we'll be demonstrating at our summer school on May 12 at Maynooth, Damien, a set of tools that will actually demonstrate these 10x interventions. And just one very practical example, which is about demand, reducing demand. Early diagnosis tests for cancer using circulating tumor cells. We can now, we're working with Rare Cells in France, we can 1 to 4 years in advance we can detect cancer. So we can intervene at stage 1 rather than stage 4, and that's a 20x reduction in costs, it's a 20x reduction in clinical care force. So that's another example. So the first one was the patient as part of the workforce. Second piece is massive productivity changes, and really we're moving to augmented intelligence, so the clinician augmented by AI and other tools. And then the last point, I think a few people is education. So for the last 5 years, and Tony was a great supporter of this, we've run a national masters in digital health transformation, and we now have about 220, 230 leaders actually trained in digital health. Now, if you have 5, that's not critical mass, but we now have the critical mass of leaders, and we have all the critical connections. So I think we're poised in Ireland to leapfrog it. So I think it's a really exciting time.
I think we have the person here somewhere that's responsible for that as well, so we'll try and catch him later. Just one of the things Jackie mentioned, and Mary Bridget mentioned it earlier though, and it's an important point, is, and I remember being here at a different conference and the same question was asked, there will be people who won't necessarily be as digitally friendly or inability to use it. Just your thoughts on that. So I think a lot of the things are within the system, as Martin said, the system itself has to do to support patients. But your thoughts in terms of how we can do more to support people perhaps through that journey as more and more things that we need to do in life are digitised.
Do you want to?
There's a vast opportunity in assistive technologies. There's some really innovative, intuitive type of technologies out there, and it's ever growing. Martin's probably even closer to it than I am. But I think people will need support. But it's like you show people how to do something, and people will learn naturally. And so many, not everyone, but a lot of people might be around younger children or younger grandchildren or whatever, relatives. So it's like, you know, when I got a mobile phone first, I didn't know how to use it. But now it's second nature to us, you know what I mean? So I think some things will become second. There will always be people who will never be accessible to. I mean, like, we have to be honest, and that's fine too. But we can still support people and give people their autonomy, their dignity and their voice by supporting people and doing it with them rather than for them.
And Mary Bridget, just you mentioned it earlier as well in terms of the traveller community and in the experience in COVID. Just any thoughts on what we can do as digitisation becomes more and more common?
I think we're looking at two different types of generation. Like if you look at 35-year-olds to 55-year-olds in the All Ireland Health Study had only primary school education. And when we asked them did they have difficulty in reading, over 29% of travellers said they had difficulty in reading. But when we asked them could they read a medication, over 50% of travellers have difficulty reading. So there's a different age group. Of course, we family who's been brought up with the mobile phones, who stayed longer in school and has much better education than what we would have. Because we came through an education system that wasn't very good to us in the early 80s. And a lot of women of my age and men wouldn't have a great education. I'm learning as I go along. I'm involved in work, so therefore I'm learning more. Of course, we have phones and it takes time to learn. But I think also people will need to be supported, and I don't think nobody should be left behind. But also the thing that we're pushing for as well around digital health is the ethnic identifier. And then again, we've seen that during COVID, where everything was a shift online. And if I hear online one more time, it's a turn off for me and for lots of other people. If I hear online and we know we don't have any numbers. We don't know who accessed online. So there could be 500 people, but how many of them was travellers in Roma? And we don't have that information. And I think it's going to be the same with the digital health. The support needs to be there. And I know we are working, and we had somebody out about digital health. We've been at a number of different events. But it's about getting that information then out through the primary healthcare projects and for the primary healthcare projects to bring it out on the ground. But we certainly don't want anybody to be left behind. But I think when it comes to the Department of Health, I do think we have a long way to go, because you do see the workforce where you have lots of nurses that leave in the country. They're going out to different because of pay and conditions also. We do know that we have glossy, all these strategies and all these plans, but implementation can be a huge problem. Like if you look at the health service and you look at the length you have to wait for an appointment, access to services, and as a patient, you have waiting months for it. And I think there's a lot of work to be done on that. And I think the workforce can only do what they can do. But I think it's much higher up. More beds, more spaces in hospital, less waiting times. And we need to see a huge change in that. So I think the health service really has a long way to go. So when it's so difficult for the general population, it's even more difficult than for people from marginalised groups to access services, well, like mental health services and stuff like that. So I think we do have a really long way to go. But I think it's engaging with traveller groups and traveller organisations. Like if a service is getting set up, that people don't just run away with, we set the service up because this is going to be good. But not one shoe fits all. There's lots of different people going to be using it. Things will have to meet the needs of the people to where they're at. And I think we really need to look at that and engage with them. Yeah.
Well done.
Do you know, Damien, I think the discussion so far and even this morning, it really shows that we need to bring all the elements together. And if we don't, we're missing significant bits. I had the pleasure of meeting Jennifer online recently, and I'm amazed at how she's coordinating volunteers. So, Jennifer, would you have any thoughts on how I think volunteers are an untapped resource? And I think when we're thinking about workforce planning, this valuable untapped resource, and see how they might be brought into all of this. So could you give us your thoughts on that? How many volunteers do you have that you're...
I'm currently on my own managing 130 volunteers. Yeah, with no support, but we won't go there because it's a positive thing.
We might.
So thank you very much for your kind words. And if you ask me about volunteers, I mean, of all of the conversations and of all of the speakers that started the conference today, my head's going, okay, volunteers could do that. Oh, volunteers could do that. Volunteers could do this. And I think the first step is, and thank you to Dr. Anya for actually including this in the conversation today. That is the first step, and at least we're on the ladder. Thank you. I mean, really, it has made, that's a massive difference. I've worked in the not-for-profit sector for 20-something years, and actually with the digitisation volunteers with Digital Champions, there's a whole swarm of that. I used to run a national program for an organisation called Age Action for 10 years. If you can have the topic of conversation of volunteers within your psyche, I think if you just include that part, then at least there will be some of the questions answered. I work at the NRH. I'm there nearly 4 years. I absolutely adore the NRH, and I adore the people that I work with. And they, you know, we were talking about ageing populations earlier on. If, you know, as ageing populations, there's a huge group of the NRH volunteers that are actually retired. They are nurses, they are doctors, they are bankers, they are physios, they are health professionals, and they bring all of their skills. And we have volunteers up to their mid-80s coming in every week, even to, we have one retired GP who comes in to feed a patient on our spinal unit. And that's not just about the act of feeding somebody, that's actually the act of engaging with that person on a very intimate level and giving that person the time. And so you get right back to patient-centred care and actually having all of your planning around what, you know, going back to what Jackie was saying, around from a patient perspective. I could wax lyrical about volunteers for a long, long time, but they are an untapped resource. And not only are they an untapped resource, but the resource that's actually put into, I suppose, engaging our coordination of such volunteers, so is very under-resourced, to the point where I've set up a networking group with other volunteer coordinators and managers in other healthcare settings, such as hospices, hospitals, dementia care centres, etc. And that's purely because we're all so stretched that we need to share our resources. So if somebody is kind of like saying, asking a question about Garda vetting or whatever it is, that at least we come together every couple of months and share that resource, because we need to. We have to do that. Cork University Hospital just has had its first 6 volunteers start 2 weeks ago, and that was as a result of the networking discussion group that we had set up. But like that, the resource of coordination is that Elaine in Cork University Hospital is actually the patient liaison service person, and this is like a tag-on, so it's not considered as a full programme, and actually given the resources to match that. And finally, I really would like to say that the most, I suppose, authentic, all of our volunteers are authentic, but the most authentic volunteers are our past patient volunteers. Those patients that want to come back, we ask them to leave a break between them being a patient in their H and coming back as a volunteer. They bring that underused, Anne and myself have connected on this, that underused terminology of lived experience. So we have ex-brain injury, past patient brain injury patients, spinal patients, limb absence patients. stroke patients, all coming back to support our services, and really key work that they work alongside all our healthcare professionals. It's not fluffy volunteering, baking cakes and sports. This is genuine care. And the part that frustrates me then is about measuring that impact. Again, it's down to that resource thing. There is not one study that's actually been done on the impact of volunteers in healthcare settings, which is really unfortunate.
There's a challenge. Would someone like to do a study?
A job coming for someone. We're in the right place in university, so I see Anya Carroll's put her hand up. There's leadership. I'm conscious of our time because we're coming up close to the end. We may not get to questions from the audience, but we'll pick the Slidos up maybe and see if there's anything there. I do want to give the panel, myself and Anne, maybe a chance just of any final observations. If you think about, I'd say if anyone came into the room today and they were asked about workforce, then think about doctors, nurses, therapists and so on. And you can see today now we've talked about patient partnership, we've talked about primary healthcare workers working with communities perhaps that are more disadvantaged, we've talked about volunteers, we've talked about the impact potentially digital will have in terms of changing the nature of workforce and the reality of trying to run. I don't know how many people, Tony, are in the West, Northwest now. There's
23,000.
This isn't the Department of Health asking, so you're okay.
23,000 people.
So it's a huge number of people in terms of what's there. So hopefully people, you've seen the breadth of that. And if you take nothing else away, I think it reflects the fact that the workforce of tomorrow is much broader than probably any of us thought coming into the room here today. So maybe between myself and Anne, we might ask each of the panelists if they just want to make a short final comment, and just in the interest of time and your coffee, we'll park the questions because I think we've got as much stimulation from the group here today. So maybe starting on the other end to let Jennifer have a breath again and come back round.
Thank you.
Jackie?
Yeah, I think it's clear from the conversation since the get-go this morning, we have to be very flexible in our thinking about the workforce. The workforce is ever changing and should be and evolving, because what might be a role today may not be a role in 20 years' time. But we still need the people, but they just might be doing a different role. So, and I think that's really important from a point of view of planning and future planning, flexibility. Education is critical, but it needs to be education that can be transferable. So that we're looking to transferable skills that can be utilised. And I think the power of communication from the local level right through regional, national level, really, really important.
Thanks, Jackie.
I think for ourselves, I think there's so much different people within Ireland now, and I think there's a bit of extra support that needs to be given to different people from different communities. So it's just about the workforce being aware of travellers and Roma and other people as well. And I think also working in partnership as well is very important. I don't think one of us can do it on his own. There's a need for us to be working together and nobody to be left behind. But also do it once and do it right. I think it's like the online and where we introduce the ethnic identifier. That doesn't come true. Go back in 20 years' time, it's going to cost a huge amount of money. So as I said, you do it once and do it right, and that's it. Yeah.
I'm actually very optimistic. I think this is a great panel. It's very representative, you know, it's all working together, and just see the two chairs on, you're sort of representing the patient perspective, Damien, as you're responsible for digital transformation, but you're also the deputy CEO, and it shows the HSE is really taking that seriously. I would say just not to go on, stay left, shift left, 10x. Let's use digital, make it so easy for people who's like nobody uses, you don't get a manual with your iPhone if you're lucky to have one. It just becomes so easy and intuitive. So let's make the digital really easy and actually empower people to look at first after their wellness, and then they get sick. We can partner with clinicians and look for these 10x interventions, and there's so many. There's this Cambrian explosion of fantastic solutions, whether it's early cancer diagnosis or reductions on heart failure admissions, respiratory admissions. So I'm really optimistic, looking forward. I think this panel was fantastic because we got such a cross section from patients and underrepresented and frankly underserved in the past. And we have you here, Damon, and Tony doing an amazing job out in the West, where there are lots of issues where geography can be overcome by digital. So very optimistic.
I suppose from my point of view, I think organisationally, I think for where we're at, what we really, really need to get to is being really clear about the health outcomes we want to achieve. There's absolutely no doubt that we won't achieve them just with the workforce that we have currently or the way we think about our current workforce, but the very first thing is to be really clear, what are the health outcomes that we want to achieve over the longer term, and then I think it becomes easier for us to engage and to communicate and to bring people into that task and to join people together in that task. Yeah.
For me, Anne, I think it's just to have that conversation about volunteers, have that within your psyche, have that on the table as a possible portion of integrated care, and remembering that volunteers aren't people that you just drag in off the street. They go through a whole onboarding process akin to a staff member, and so there's a whole process involved. So you're getting a really amazing quality person to augment staff's work and to support patients from within. 8,500 hours at the NRH last year were donated, and that's not to be sniffed at.
That is phenomenal, Jennifer. Yeah, I think one thing that's I'm hearing, and it would be from the patient partners really, is that we all want to make things better for those coming behind us, and I think that's a great common kind of force to be involved with. Yeah.
And that's probably a good way to end, Dan. So just we'd ask you to put all your hands together for our panel for their inputs this morning. And as they say, coffee is now served. Thank you.
and I have had a good opportunity to start networking. I don't know whether to stand up on this or not. I'm wearing my wedges. What do you think? Anyway, I know that you weren't expecting to hear from me until the very end, but I'm sorry, you're going to hear very quickly from me just at the moment. So I'm Anya Carroll. I'm Professor of Integrated Care and Improvement at UCD, a consultant in neurological rehabilitation at the National Rehabilitation Hospital, Chair of the International Foundation and Co-Director of IFIC Ireland. But what I wanted to do, there's been fantastic feedback through Slido. Thank you so much. We will very carefully analyse the outputs of the whole conference, but also the outputs of Slido. So what I wanted to pick up, we've clearly cheesed off the specialists in the audience. And you're not happy. And I think that's really interesting, and it's one of the reasons why we want to have this discussion today. So I would be really curious about what was said that cheesed you off. But the key thing is that you were. And what I would like to say is when we're talking about workforce and integrated care, it is not a case of either or. It is both and. So do we need access to specialists? Of course we do. It is not a question of this being either or. And there is, when I look back at discussions that have been happening over the last period of time, and I'm thinking in particular of the comments of my friend and colleague Ronan Collins, making this as if it is a dichotomy of either or, hospitals or community. It is not either or, it is both and. So I wanted to say to the specialists in the audience, you are important, you are valuable, you do fantastic work, and keep doing what you're doing. But this is a conversation about you, but also the broader perspective on what integrated means within our communities. So you're very special, you're very important, and you matter, and thank you. And now I'm very happy to hand over to the expert hands of Joan and Andy.
Help if I bring my notes with me. I feel exceptionally tall up here. So thank you so much, Anya. Really appreciate the clarity on that. And welcome to this next plenary session. So we did have unfortunately, somebody dropped out. Sandra Broderick, our REO from the Midwest, was unable to attend late last night, but luckily we have a super sub REO. So you should always have at least one REO and one in your back pocket just in case they can't make it, because they are very busy and important. So Andy's going to step into that little role on our panel today, which is great. And I'm going to try not to say Oreo too often, because every time I say the word, I think of milk and cookies and it makes me hungry. So without further ado, I'm going to ask Deirdre to introduce herself and to start off the presentation. So this plenary is Future Skills for Integrated Care. What do we need to teach and learn? And I'm really looking forward to hearing from Deirdre. And then once Deirdre's presentation is finished, I'm going to get the panel to introduce themselves, and we're going to have a really interesting discussion about this. So thank you very much.
So thank you very much for inviting me to speak to you today. And I'm going to speak to you about the Eclectic study, which is seeking to understand how to promote interprofessional collaboration within community-based care teams who are integrating care for older people. Before I begin, I would like to acknowledge the funders for this project. So this was a two-phase study. The first phase was funded by the HRB and the HSE through an Applied Partnership Award in 2019. And the second phase is ongoing and funded through the HRB through an investigator-led award in 2022. So the presentation today, I'm going to just focus on the key outputs or the findings from both of these study phases rather than the methodology. And we'll present some kind of early preliminary findings from our realist evaluation of interprofessional collaboration, which is using case study evaluation of 4 ICPOP community specialist teams in Ireland. So just to emphasize the research team that I'm representing today. So both phases of the study have involved a research policy partnership between interdisciplinary academic researchers located in the UCD IRIS Centre, which is the Centre for Interdisciplinary Research, Education and Innovation in Health Systems, as well as knowledge user partners from the NCPOP, the HSE National Clinical Programme for Older People. Both phases have also had a very strong user-driven approach with the emphasis on meaningful inclusion of public and patient partners who are family carers and older people who are involved in the research design, in the co-design of the competency framework, and as well as in the interpretation of the realist evidence. So, interprofessional collaboration and team working are widely accepted as important to enable quality, safe care integration for older people. And we know that team working has lots of positive outcomes for the health workforce and for people engaging in team working, including reduction in bullying, increasing in staff retention, increasing in job satisfaction and work engagement. But we also know that not all teams in healthcare are enabled to collaborate effectively. And evidence has highlighted that there are practical barriers to efficacy of team working. And these include differences among team members in how they might approach an issue or a problem, differences in their disciplinary training, differences in values perhaps. There's also systemic challenges associated with interprofessional silos and hierarchies, and there's also maybe potentially power differentials between different disciplines. Amy Edmondson has coined the concept of teaming, and this suggests that it's not sufficient to put a group of people together, call them a team, sorry, this is rolling on at me, call them a team and assume that they'll know how to work in this way. It's necessary to actively build and develop teams and to support members to develop knowledge and skills that's necessary for their way of working. So that's what our focus in this project was looking at developing professional competence for interprofessional team working. So I'm going to skip to the results of the first phase of the project, which is this interdisciplinary and interprofessional framework. And we know that, as I said, the interprofessional working is at the core of the HSE's older person service model, particularly as older people are transitioned across service boundaries and supported to live well at home through interdisciplinary teams. It is a relatively new way of working in healthcare, particularly in the community or primary settings. And implementation of the older person service model provides the context for, in this study and the context for what Amy Edmondson described as teaming. In other words, the intention and effort that is required to actively build and develop workforce capacity for collaboration. So the first phase of the project really focused on describing the knowledge and skills that are required by healthcare professionals to collaborate in interdisciplinary teams in the context of older persons care integration. To move on. So the project, which was completed in 2021, resulted in this framework, which depicts 3 domains of competencies. There are 6 core competencies for interprofessional collaboration. The first competency refers to knowledge of the team, which involves knowledge and skills and behaviours related to understanding roles within the team, making referrals within the team and across the team or outside the team. The second domain refers to communication, which again is broken down into sharing information and communicating effectively. And then the third domain relates to decision making. Sharing decision making. And again, that relates to supporting the decision making of older people and family carers, as well as collective clinical decision making. So this framework is supported by a step-by-step toolkit and resource guide, which is freely available and accessible through the NCPOP website, the HSE website. And the toolkit provides practical resources to support teams to develop knowledge and skills for interprofessional working, linking to that can be used within continuing professional development and team building exercises. We also provide direction and guidance on how to use the framework within teams to help develop their competence. So the framework and the toolkit were adopted by the National Clinical Programme in 2022 to underpin their national scale-up of the integrated care teams for older people nationwide. And also that framework is used quite well in collaboration with the HSE's Knowledge and Skills Framework for Older People, which I know my colleague Niamh McMahon will be presenting later on today, so definitely worth looking out for that. So the two resources work hand in hand, as I said, freely accessible through the websites, and important for describing the competence, but also providing practical resources. So now that we had a sense of what teams needed to know and how they what skills they needed to have to work effectively or collaborate across professions, I guess the next phase of the project was really more interested in the how. So how are they going to do it? So we wanted to know, what are the contexts that teams are working in that enable them? What are the resources that enable them to actually collaborate? So this led to the follow-on phase of the eclectic study, which was a realist process evaluation of the framework within the context of the ICPOP community specialist teams. So we wanted to know what works to support the development of interprofessional collaborations in these teams, what doesn't work, who does it work for, and why. So I'm going to skip again to findings again, but from the first phase of this realist evaluation, we completed a realist synthesis of the literature. And from that, I identified 7 program theory domains, which are essentially, I guess you could describe as pillars for successful interprofessional collaboration or the implementation of interprofessional collaboration in the context of community-based care teams. So in each of these domains, which is forthcoming in a publication, it's just in press with BMC systematic reviews, but the domains detail the resources, the context, but also the resources and tries that enable this way of working, but also tries critically to understand the why. So what is it about these resources that are driving potentially positive outcomes, both within the team, within the workforce, and also for older people and family carers? So key elements of the program theory is that they describe strong professional identity within interprofessional teams, coupled with supportive learning cultures and active engagement and quality improvement. And those elements are featured in program theories 1, 4, and 5. Collective leadership and participatory team involvement, fostering trust, and staff retention and staff satisfaction are described in program theories 7 and 3. Positive inclusion of older adults and caregivers in care planning, and really we envisioned older adults and family carers as part of the teams, as members of these teams, relevant for collaboration, and that's very much described in Program Theory 5. And then we have our seamless information sharing and care coordination, which is facilitated by a robust data sharing infrastructure, again described in Program Theory 2. So these domains highlight the specific resource requirements that are needed to support interprofessional working. They emphasize the need of in investment in areas like professional development, electronic data sharing systems, and ICT technology. They also emphasize patient-centered care that creates favorable contexts for effective interprofessional collaboration. And critically, they identify some of the outcomes that may be associated with this way of working. And I know the literature is probably not as strong at identifying cause and effect for particular outcomes, but we're starting to pull from that literature some tentative outcomes that we think might be associated with interprofessional working. So we're currently undertaking a realist evaluation of this program theory within 4 case study sites. These are 4 community specialist teams for older people across 4 different regional health areas in Ireland. We've completed wave 1 of the data collection and are in the process of analysing that. And we're anticipating a second wave of data collection this summer. So I just want to present some reflections on what we've learned so far, and to also give you an overview of a resource pack that's just very newly disseminated to the case teams. It was just disseminated 3 weeks ago. And we're in advance of our second wave of data collection, where we'll start to appraise some of those resources. So just a quick reflections on what we have found so far in our study, in our teams. So we did identify key strengths within the 4 case study sites, and we tried to position these strengths at the kind of macro, meso, and micro levels. So starting with the macro level, we observed there's very strong confidence in both the operational and the clinical leadership within these teams, and this coupled by very valuable opportunities for professional development. So we could see that professional development as being a really critical resource there. At the meso level, we saw that a significant strength of these teams was their really strong and robust intra-professional networks. So this is the nurse to nurse or the physio to physio within the team, outside of the team. And that really helped the team to connect to the wider health system. And I think that might be something we could discuss at the panel in terms of how to sustain that. So that was often built in, at the micro level, a resource that these teams are highly specialised, highly experienced clinicians who are really with loads of experience of working across the system, and they brought that social capital into the teams. How do we sustain that and create that as an asset for future workforce is something that I think would be worth discussing. Crucially, the teams exhibited very high levels of psychological safety. There was a lot of open communication, risk-taking, strong work engagement that was associated with dedication, absorption, and vigour in their work. Sorry. And then looking now at what we identified as potential areas for optimising collaboration within these teams. Again, at the macro level, recruitment gaps are hugely impinging the way that they're working and collaborative working, particularly at clinical and operational lead level. Standardising contracts with common working hours was established as important. Addressing coherence in the clinical governance across the ECC, that's the Enhanced Community Care Network, was also vital. So how these teams fitted in with the existing community infrastructure was highlighted. And also, finally, metrics was important and came up quite a lot. So metrics, in particular, their ability or inability to effectively capture interprofessional working. This was in terms of allowing better tracking and monitoring of progress and how this was being established within the teams. At the meso level, it was some of the issues that were highlighted was, one that would probably resonate quite a lot here is access to hospital data and integration of information sharing systems across community, primary and hospital settings was seen as essential. Supervision gaps were also identified within the teams, and then that I think relates to how the teams fit within the broader ECC infrastructure. And then at the micro level, we had highlighted a need to focus on information flow into and out of the team and within the team, developing shared vision, mission and goal statements and value statements, as well as standardising mechanisms that might capture their impact. So just before I conclude, just to show you this resource pack that we have now disseminated to the teams. We're hoping that they will use some of the tools and mechanisms identified in this pack to continue their development of interprofessional working. So this resource pack has really tried to respond to some of those, particularly the micro issues that we identified for optimising interprofessional working. So we hope the team will be a valuable resource for, the resource will be a valuable resource for the teams. We intend to have, we're going to evaluate in the second wave of data collection, and we would intend for it to have transferability beyond the older person service model. Once it's been evaluated and we have some reforms to that, we will intend to publish it on the HRB open platform to support open access to some of the resources that we've identified, maybe to see how they might feed into continuing professional development as well as existing curriculum development for professional programs. So both the resource kit and the eclectic competency framework can be used to, and I should also point out the HSC knowledge and skills framework can be used to develop curriculum development for continuing professional education programs, as well as our undergraduate and talk graduate professional education programs. The final phase of the Eclectic project will involve the establishment of a working group to develop a learning outcomes framework to support IPC curriculum development. And so more on that, I hope, soon. And then just, I guess, to conclude, the Eclectic study, through its 2 phases, has provided critical insights into fostering interprofessional collaboration within community-based care teams for older people in Ireland. By developing a competency framework and a practical capabilities toolkit, the project has addressed, we think, the teaming challenge that Amy Edmondson identified by emphasising the need for active development of IPC skills. The realist evaluation, which is currently underway, further refines our understanding of the contextual factors that influence effective IPC and highlights both the strengths and areas for optimisation at the micro, meso and macro levels. The dissemination of the resource kit and the resource packs and the development of a learning outcomes framework underscores the project's commitment to translating research into actionable tools, ultimately aiming to enhance service delivery and improve the quality of care for older people and family carers who living in their homes. So thank you.
Okay, thanks so much, Deirdre. That was really interesting. So to start, I actually just realised I forgot to introduce myself. So we might do introductions, and what we might do with the introduction is just a quick 1 minute reaction to Deirdre's presentation and just what that might mean for you from your perspective and anything that you can take away from that in your day-to-day practice. So just to start, my name is Joan Johnston. I am General Manager of COPD Support Ireland. That's my half-time paid job. I am Chairperson of the Board of IPOSIA Patient Organisation, and I am also mum to a 7-year-old boy with a rare neurogenetic condition, so I'm also a carer. So I have a wide range of expertise in looking at health care and health systems, but for me, the thing that resonated about your presentation was around that care coordination piece and measuring impact. I think those are the two things that most parents and most of people who support people within the system would value highly, is that coordinated care and that measuring of the impact. So, Deirdre, you've obviously already just introduced yourself and done your presentation, so I might move on to Ed if you want to start.
Sure. So my name's Ed McCone, and I'm a respiratory physician, so I'm a specialist. In fact, I'm a subspecialist. And in fact, I was a bit late this morning coming because I had a subspeciality clinic, so I missed the bashing of the specialists went on. But my other role, though, I'm Dean of the Institute of Medicine, and also I'm Chair of the Forum, a postgraduate training body. So really, our job is to look at how we integrate integrated care into the training of postgraduate medical doctors. So that's something that we'll be talking about. I think what I got from the talk, and I think which will be very helpful in how we move forward, is we're looking to try and see how we can embed a curriculum that is going to be cross-speciality. It's going to be speciality agnostic, because it's going to be involving surgeons, GPs, physicians, and so forth. And we need guidance as to what are the competencies that are going to be required. And you've given us a good example of how that's going to start. And then with that information, then we can look at how we can embed that in what we're currently doing, and then how we can improve what we're currently doing to make sure that people are being trained adequately for a future in integrated care.
Great, thanks so much, Ed. Oh.
Hi, I'm Mo Flynn, and I'm here as the chairperson of CORU, which is the Health and Social Care Professionals Regulator. We currently regulate 17 professions within Ireland. We're the only multi-professional regulator. I've run into so many people here this morning from my many past lives, which include gerontology, palliative care and disability services across acute and community. So I've been battering away at this for 40 years. I suppose what really resonated for me from Deirdre was really the necessity for the trust in each other's professionals' competence to actually make assessments, make decisions, and also, but ultimately, the placing of older people at the centre of that decision making, because that's really important in terms of empowering older people to take risks and supporting them to take risks in their lives. Sometimes from a professional basis, we move towards protecting people constantly, and yet for older people, they need to be enabled to actually make decisions that may be life-limiting, may be life-changing, but it's their rights making those decisions. So one of the key things of developing interprofessional practice will be about enabling and empowering professionals who have the competence within those areas to be heard, and for others to respect that decision making that they make with an older person, as an example.
Thanks, Mo. Ghazi.
Thank you very much. So, hello, my name is Ghazi Ofaya. I'm Associate Professor of Surgery and the Director of Curriculum at AICIC25. the University of Medicine and Health Sciences. So I'm here today really talking about undergraduate medical education. Our CSI is unique in the sense that we're a health sciences institution, so it's great. When you talk about interprofessional learning, that's really where we are at our best, because it's all about interprofessional working together in that learning. So I think really looking forward to the discussion around that education and starting quite early to start that interprofessional learning. I think for me what really resonated at the presentation is really the need for evidence around what we do. How do we embed it within our curriculum? What is the framework we use? What is the competency framework that we use around that? And I think the work that you've done, Deirdre, around that kind of gives us that evidence of embedding it throughout that. So that was really good. Thank you.
Thanks, Guzzy. Lynn.
Hi, my name is Lynn Dennehy. I'm a support manager with Family Carers Ireland. So I suppose I'm here today really to talk about the fact that family carers need to be part of this whole topic. And I think credit to IFIC Ireland in the last few years. I feel like they really have pushed this topic, and that's why I'm here today, I suppose, really. And it's lovely actually with Deirdre's presentation there, because family carers is mentioned throughout the whole lot of the presentation, and not just as a collaborative piece, but as an actual team member, as that bigger workforce, because they're often the invisible workforce, I suppose. So it is about acknowledging them and valuing them, and actually using it as one of the main drivers, in developing care planning going forward, So yeah, it's great to be here, yeah.
Thanks, Lynn. Auntie.
Well, I was going to say I'm Sandra Broderick, but I'm obviously not.
Looking fantastic, Sandra.
So, yeah, I'm the REO HC Southwest. I'm also a clinical scientist. We are very proud to be seeking to be the first age-friendly health system in Ireland, I think, and using the 4Ms framework to do that. So very interested in that work. Really struck by the need, following a brief conversation with them earlier, to have really good clinical governance systems to enable all of this is something we need to put in place. Thank you.
Great, Andy. Thanks a million. So we might start by thinking about education and training first, and bringing that theory into practice. And I suppose when we talk about interdisciplinary working and integrated care, oftentimes it's like, that's a lovely thing. We should definitely do that, but. And I suppose what I'm wondering is, what are the barriers to us bringing it from the classroom, from the concept, into the everyday? And what are the things that are going to help us overcome those barriers? So I thought perhaps we might start, Ghazi, with you with the undergraduate, and then we might talk to Ed afterwards.
Yeah, absolutely. Thank you very much. You're right. I think everybody believes that that's the right thing to do. In concept, absolutely. Theoretically, when it's written down, absolutely, everybody agrees that that is the right thing to do. However, I think the biggest barrier is in implementation around the curriculum. So, as I said, with our CSI, even though we are a very health sciences institution where it would be easy, I think one of the biggest challenges is scheduling. How do you have a really busy curriculum? How do you schedule to have the physios, the pharmacists, the medicine, the PAs all at the same time learning together? It's not impossible, but it requires resources, it requires flexibility in your scheduling to be able to do that. And I think for us, while we have achieved it, that was one of the biggest barriers that we actually had in actually making sure that you had people at the same time to do it. In the last session, we talked about digital, transformation, and for us, that has really significantly supported the ability to be able to deliver interprofessional learning using digital, using online, using virtual patients, and trying to create that. And that's how we've significantly moved on from that barrier of actually having scheduling as a big challenge. I think one of the other things that was a big barrier for us when we started is that because we've already talked about how we are quite siloed in how we train, the nurses train this way, the medics train this way, the physio train this way, there was no framework as to how do we actually deliver this across the board. And back again to that evidence. So one of the things that we did in our CSI to help get over that was really creating an IPL framework. So what is that framework of that you want everybody aligned to? And that really helped to kind of define, this is what we need to do. That framework was created with patients and with students at the center. And patient-centered care was the center of that, with the domains actually very similar to what Deirdre presented there, the domains of teamwork, communication, ethics, values, but more importantly, role and responsibilities. So what is each other's role and responsibilities? So starting quite early on to embed into the students what roles and responsibilities are for each of the healthcare professions that they're going to be working with. So that was one of the key things that really helped to drive that. And I think another barrier around that is really, how do we evaluate what we do to ensure that we are getting benefit and that it's working? So you've implemented it, you've got a framework, you've put it in. How do you evaluate that? So I think really getting involved in research projects like that, I think is really key. One of the things that we're doing is looking at whole system training or whole team training. And that's one of the projects that our CSI is involved in. It's a European-wide project, but that's where you bring in collaborators to start looking, okay, this has been a barrier. How do we overcome it? How do we evaluate it? And this European project is looking at how do we train the whole system, the whole team, and how do we measure things like behavior and see how it's working and re-embed that into the curriculum to actually make it work. So I think those are kind of some of the key things that we've kind of had. We've had faculty buy-in. As you do that, we've talked about governance. You need to make sure that there is buy-in at that high level to be able to embed that through. But just kind of, just off the stop, that's one of the key ones that I would think are the major barriers for us, you know.
Thanks, Gazi. Ed.
So, as you might imagine, the barriers that Gazi mentioned are also the barriers of postgraduate medical education. I mean, I think a busy and a full curriculum, I think that the silo issue is a major issue, that most of the programs are developing their curricula thinking only about their own speciality. There's very little cross-disciplinary sharing of information about in general. And of course, the curriculum tend to be looking at what is the goal of the curriculum is to get to people to specialist level at CS, EST. And so it tends to be very focused on getting into that subspeciality area towards the end of training. So it's more drawn away from the community than necessarily and more hospital focused towards the end of it. The other thing that Gazi mentioned is buy-in. And I think that that's a really key barrier and also a reason that something can succeed. You know, we see this with general internal medicine, we see this with other programs that we have, is that you need a champion. You need people who will champion it within the postgraduate training bodies. Because if you identify those people, then they can bring it forward and they'll do, work will be involved, but they can bring it forward and get us to incorporate that. I think the other things that we find is that it's what are you trying to train people to do? So are you going to incorporate it in the curriculum just to give people some exposure to it so that when they're in practice, they're familiar with what it involves and so they can work with people who are trained in it? Or are we training people to be the leaders who are going to come out of, certainly from the hospital side of things, that would be trained in their area of medicine, but that they would take on the role as being a leader in integrated care to run programs and be involved in the running of programs. So I suppose we need to think about what the goals of the curriculum changes might be. Now, that being said, the barriers that we've identified, I think we face those barriers in other areas as well. So fortunately, we have some experience as to how you can look at programs that, as I mentioned already earlier, are specialty agnostic, so that you can't go to a respiratory training body and say, we want you to train respiratory people in integrated care. This is cross-body. And we have two areas that have been developed in the last few years. One that we're developing this year. One is in global health, where we developed a global health curriculum, which was across the training bodies. And then each training body took that curriculum to their training body and tried to map it out to see what are we already doing that actually falls under this. It may not be called it, but when you look at it, you see, actually, we are already doing it. And for the gaps that we've identified in our curriculum, how do we fill those? And I think that's a potential area that it could be used. The second one is in inclusion medicine as well, and that's working well. So what I would hope, and I think that there's a lot of opportunity, is that if we have a curriculum that would be specialty agnostic that's related to integrated care, similar to what was been presented, then we could develop that as cross-body, and we could then look at trying to map that to what we currently do and identify gaps. And I think in the College of Physicians, we have had a few examples where we've identified areas that we want people to be experts in, but they're not that subspeciality, very rare disease or transplantation or something. And I give you 2 examples. Medical education, so we want people to be medical educators, and we also want people that will have some familiarity with, say, quality improvement. And what we've done is that we expose people to some of that in BST. In HST, though, we've developed programs where people step out of their training, and it doesn't matter whether they're respiratory, whether they're psychiatry, whether they're anesthesia. We're trying to develop an educational 2-year program where they become medical educator. And it's largely driven by education that's not related to their speciality. It's just that the principles of how this works. And I think that a program like that in integrated care would work very well in our specialist training programs, with a view that the people who do that would then go on to become specialists in that area. And just finally, just one other option is that it was mentioned earlier that may take 5 or 10 years to develop.
Mm-hmm.
If you're thinking about if we need to be doing this more rapidly and getting people trained more rapidly to take on those roles, we have post-CSESD fellowships which are 1 year, and I think that it would lend itself extremely well for people who are coming near to graduating as a specialist, but haven't got the skills, to be honest, to be able to take on the role in integrated care that we've heard about, that we could train them up in a 1-year post-CSESD program to potentially get those skills.
Thanks, Ed. And I will have a follow-up question afterwards, but Mo, I suppose you would have a unique insight coming from the Corú perspective on this. And what are your thoughts around this?
Yeah, I think people may not be aware that one of the roles of Corú as a regulator is actually the approval of all education and training programs for those people who register with Corú. So all the university, colleges, programs, etc., must be approved by Corú before anybody. So for somebody to become a registrant, they must have come off an approved program. So that's an important point, because, of course, then we can influence and our registration boards influence the content. And one of the key things that we require is that integrated care is principles are embedded within the curricula and the programs run by our universities and colleges. So that's really important in doing that. But where else we obviously determining that the standards of proficiency for somebody, the threshold standards for somebody to be registered, obviously includes the opportunities where they've had to actually develop integrated working skills, working in multidisciplinary teams, etc. So we're building from the bottom in a sense of requiring that's what we will see our registrants graduate out of their training programs with. We also, I think, include in our CPD, because again, we monitor the CPD of our registrants, that they are beginning to demonstrate proficiencies within interdisciplinary working, and we're increasingly providing them with exemplars of what that would look like, and what sort of training programs or engagements or experiences that they can participate in that will develop their skills within that area. So we have a key role in enabling that. And just finally, one of the things we're doing and moving on a great deal, and this arises from our learning, I think particularly from fitness to practice, where we've seen where interdisciplinary working or integrated working has perhaps not worked, is we are now moving towards creating guidance for registrants on particular aspects of integrated working, so that particularly in working within teams with different professional groupings, recognition of roles, etc. Now, while much of that is required in the Code of Conduct, currently we increasingly see that guidance will be very helpful in people recognising what the expectations are for them as practising professionals.
Thanks so much. And I suppose my thoughts on it are, is it something that we teach, or is it something that this is how we do it? Is it culture or is it structure? And Deirdre, I don't know if you have a thought on that, just a final thought on that little sort of discussion point.
It's probably both, I would say. So yes, I think we do need to be teaching it, and I think it is happening to a certain extent, but it needs to be better. And there's certainly knowledge and skills that can be taught and can be experienced. And then, of course, yes, there's culture. And you do so much with students in the university setting, but they have to then go out into the real world practice. And they sometimes what they learn in the university settings gets unlearned in practice, or sometimes if you have a critical mass that was mentioned earlier on, you can improve culture, change culture over time. I'm interested though in the roles bit, because I feel like that's quite cultural, and I think we're observing there's quite, in these, when you've got these specialist, particularly highly experienced teams coming together, there is this dynamics around scope of practice and role boundaries, etc., that play out. And there's lots of socio-cultural factors happening there. And obviously there's huge influence around regulators, of course, on that in terms of defining scope and regulating for that scope. But I think where integrated care and these specialist teams can be great disruptors in a positive way to try and really change what we understand by scope of practice and how we can support safe, I guess, expansions of scope.
Thanks, Deirdre. So I'm going to move on now to thinking about, I'm going to take up that culture, and I think I'm going to go down the route of the culture. And we often talk about integrated care as a value, but what's stopping us from working this way in practice? And I suppose linked into the idea of culture, I'm curious to know your thoughts around when the services move on and evolve and are delivered differently, but the systemic processes or the bureaucratic processes behind it don't move along with them. You can end up with these roadblocks in the system. And I suppose, is there something around a culture of having the agency to be able to change something that's not working for you on the ground? And I suppose with regards to organisational culture, it's one of the roles of the RHAs, it's one of the greatest opportunities of the regional health areas, I feel, to break down those bureaucratic processes, because there isn't the need for the silos as much anymore in theory. And is it going to play out in practice? And I suppose I'm going to come to you, Andy, and ask you about that.
Yeah, and just to say, I was interested in actually how you say the word Karoo, because I spent a long time in New Zealand, and the Koru is a very important symbol there. And I'm really pleased that Stella Ward, and maybe colleagues are here from New Zealand today. It's great to see Stella here, particularly because I learned a huge amount about integrated care and building a culture for integrated care from the work that Stella and Dave Mates and colleagues did in Canterbury, New Zealand. There's a really good King's Fund description of that. And I've absolutely pinched with pride, Stella, just about everything that you and your colleagues did. And one of the things that you did, which we're doing now with our team, is first to work on the culture of the regional executive team to make sure that we understand what we're about in terms of the way we do things around here. And I'm disappointed not to be at the cultural sessions for our staff. We're bringing together 300 or so of our staff to work on the culture of the organisation. And part of that is we've made 8 commitments. And again, pinching shamelessly from Stella and colleagues, 8 commitments to 4 to the people we serve, 4 to our staff. One of those commitments is that we're one system, one team, one budget. The other thing I stole shamelessly from David Mates is we'll be giving them out a number of cards which contain those pledges, and also permission from me to integrate. So there'll be a statement to the extent that you have permission to go out and do these integration type activities. One of the other things that we're going to need to do is, I think, get people to understand their main job is building a relationship with the people that they serve. And that's what they should concentrate on first, not getting straight into the clinical technical stuff, but starting to build a relationship with people. And that's what I'm going to be making sure happens, at least in my RHA.
Thanks, Andy. And actually, I really like what you're saying about building relationships with people. And I suppose, Lynn, I'm thinking as a family carer and being that member of the historical multidisciplinary team and now the interdisciplinary team in the care for my son, I suppose myself and so many other carers one of the biggest things would resonate with us is around that care coordination. And I suppose what do you perceive are the opportunities for us now to embed ourselves as carers and that informal care force into how we are delivering care in Ireland today?
Yeah, I think it's interesting, and you hit it as well there. I think it actually is really basic and it comes down to relationship building. I think it's not to be afraid that you can check in on that family care to see where they're at and meeting them where they're at as well, I think, because they do become the care coordinator, you know, automatically. It happens all the time because of there being so many different silos of different services and stuff. Who is the person that connects them dots together? And it is often the family care that does that. So I think if you're looking at opportunities going forward, I think as professionals we need to strip it back to just basic relationship building and build a relationship with that family carer so that you can learn from that family care, but also that family carer feels that they can share their concerns around the care planning for the person that they're caring for as well. You know, it's a wraparound system really, and it's interesting. You can overcomplicate it, but I actually do think you should strip it back to just the basics. And I'm sure many people are doing it, and they're probably thinking I'm doing that already. But and it is being done in Ireland. But I as a worker for Family Carers Ireland, are constantly trying to promote this. You know, because it is something that if you do that, then I've seen it work. Like I've seen it work really well, where the person doesn't become overwhelmed, overburdened. They feel supported by the system. They feel supported by the people around them. And I think it is about just actually bringing it back to just the basics of that, you know.
That's brilliant, Lynn. And a lot of what you just said resonated with me because I've been that person and that carer. And honestly, care coordination takes up a significant amount of my day. And the fact that I have different appointments on different days in different venues with the same child who has to be taken out of school again, and then we just sit and wait for an hour or two. So, and I think that there's also something there around, you know, are we including our service users enough in planning of our services, and how are we doing that? And I suppose it's maybe a little off topic here, but it makes me think about, are we listening to what the needs are as much? And Mo, do you want to come in there?
Yeah, I do, and I think, you know, I think we would all readily acknowledge that we have moved on a great deal in putting the people who are using our services at the centre of our planning and decision making and engagement, and I think that's reflected in many areas. And just from Carew's perspective, we recently reviewed the standards of proficiency for all our registrant, and part of that process was we ran a series of focus groups and engagements with family carers, with the public, to actually determine what they want to see their professionals to be skilled in. What are the things that are the requirements that are critical to them? And they strongly influenced the revised standards of proficiency that we've produced. So very much trying to close the loop on that and begin to reflect those needs back into those standards that we expect all our registrants to meet at the outset of their careers.
Thanks, Mo. And I suppose anybody else want to come in on that about, is it bringing it back to basics? Is that how we're going to actually achieve this in day-to-day practice, that we focus on the relationship, the person in front of us, and rather than saying that bit of that person is my responsibility and that bit of that person is somebody else's responsibility, do we sit there and take ownership of the person as a whole and that holistic interdisciplinary approach to caring for that person? Andy?
I mean, that's certainly how we're organising ourselves in terms of the structure and what we're calling the ISDs below the IHAs. So yes, all the teams that currently exist that have specialist requirements, they will come together to provide a service around a population. And there will be coordination across the regions, but certainly that's the way we're intending to organise ourselves. That's the way we're moving. There's a very different way of practicing, and some of the things that we need to put in there, like really good IT systems, governance, training, we're going to need to do those. It's not as simple as from day one saying, right, off you go. But it's really what we need to do, because we're there to serve people. We're there to serve our communities, and we need to do that much more intentionally, taking on board how they need to be served. You know, as a service user, I don't want to hear really about primary and community and secondary and tertiary care. I just want to get the care. And I anticipate I don't have to talk to people people about the same thing time after time after time and wait. We're, again, something I used, a couple of things I borrowed from Stella and colleagues. One would be the work that Stella's done on health pathways, so streamliners, and you might want to talk about that. So that's a really helpful way of describing the type of services that people may get. And that's really going to be critical to us in our efforts to do exactly the things that you're talking about.
Thanks, Andy. Gazi, you want to come in there?
Yeah, no, I think for us, we really believe that it starts from day one. You have to train them from day one. And I think previously when you start clinical placement, that's when you start looking at integrated care. It's starting from day one. So the minute you walk in, the minute you go into admission and you decide this is where you want to go, this is the path you want to go, you need to start thinking about it at that stage. So for us, one of the things we did as we designed our curriculum was to bring in that perspective as part of the design. So that co-creation of all aspects of the curriculum. So we had case scenarios, we've had Pivot Point come in and feed into that. We have the patients, the public, the carers feed into that curriculum to make sure that it's fully representative of what we want the students to know as they go out. So that was really key for us, that co-design was really important to have that true. I think another key thing for us is classroom is great. We give you the theoretical aspect in the classroom, but we've moved away from that. It's really in the workplace. It's really that authentic experience of actually interacting with people. And hence the reason why communication and teamwork are really important pillars of what we need to do as part of that integrated care. So once you have all those toolkits for them, then obviously it makes it much easier as they progress through their career. So I think that's really important.
Yeah, that's great, Gazi. Thanks. And Ed, you wanted to come in?
Well, I was just going to add that, I suppose our experience with our inclusion health curriculum would probably apply very well here, because that is very much driven by the person in front of us. We've got clinicians, we've got multidisciplinary team members, interdisciplinary professionals, all of whom are contributing to the developing of that curriculum, which will be one that would be rolled out with a view towards it being very much centric, very much around what the patient requires, what the person requires, that's being looked after. So I think that model would apply very well for integrated care. But as I said before, we have a blank sheet here, because integrated care came out very rapidly, and the postgraduate training bodies have been a little bit behind in terms of us developing a curriculum. So we do have an opportunity here to try and design something from scratch that includes all of what you've just said.
Thanks, Ed. Did you want to say something, Mo? And literally just 30 seconds.
Right. Just, I think fundamental to delivering this within the context of the patient or public experience is the leadership at all levels that's required. Yeah. The leadership within teams to actually take risks, and the leadership more broadly in addressing some of both the institutional and other barriers that actually stop integrated working happening. So people have to take on those challenges because, if we don't address those barriers, it's become very difficult to actually deliver real integrated care, no matter how willing the professionals themselves may be to do it.
That's brilliant, Mo. Thank you so much. So I think I'm conscious that we're kind of coming towards the end of the conversation, and I did want to give everybody an opportunity to share, I suppose, their key takeaways, but also the one thing, if you had a magic wand, what's the one key enabler, the one thing you would change to mean that we would, with 100% certainty, achieve integrated care delivered by interdisciplinary approach to that care?
I was hoping you wouldn't come to me.
Do you want me to go somewhere else first? Okay, Andy.
Well, look, I'm an REO, so I do have a magic wand, don't I? So the magic wands that I'm thinking about are, again, something I've been using. It's called healthcare systems engineering, so intentionally designing systems that are integrated. And the second thing I think is going to be a game changer is artificial intelligence and getting AI into our systems really quickly. Look, as a clinician, I spent nearly 40 years as a clinical scientist, so I've got 40 years of knowledge and I keep up to date. But just think about all the hundreds of thousands of people who do what I do, and I could get all that knowledge and all of the integrated care understanding there is from people with different types of knowledge that I can use in the service of the patient. So We need to use AI effectively in integrated care.
Thanks, Andy. Lynn?
Yeah, I think a magic wand would be that I wouldn't be here at all because they would just integrate it into the system and that'd be it. But look,
I love that.
I think we're a bit far away from that. But I do think just actually just acknowledging them. You know, I think it's going to hit every one of us in this room. Probably at some stage that we may be caring for somebody. At the moment, there's one in 8 people in Ireland are caring for somebody, and 1 in 9 of them are trying to juggle maybe their own paid work with caring. And I do think by 2030 they estimate that it'll be 1 in 5. So I do think if you learn anything about integrated care, I feel like that they have to become the normal thing is to have them integrated into the system, into the care planning, that they are a team player in it. It is inedible because that is the way that we're going, and I think that is the main thing with integrated care is that they are integrated, you know.
Thanks, Lynn. So 30 seconds for the rest. Ghazi.
So for me, integrated care into the curriculum from day one. I think it's not a standalone module where it's tokenistic. It's embedded into everything we do, and I think that's really important.
Brilliant. Mo?
I would make a plea to recognise that it's not only the HSE that delivers services, but that we have huge numbers of people in private practice and multidisciplinary teams, particularly working in children's services and assessment right around the country. And yet everything I hear about is talking about systems and actually not talking about how the whole wider ecosystem of health and social care is actually delivered. So I think we need to look at what integration means on that much wider basis and not exclusively within statutory services.
Thanks, Mo. Ed?
I think what would be very valuable for us would be a speciality agnostic cross-faculty curriculum for the progressive training of people from internship up until CSESD in the area of integrated care, with a view towards people who will work with people in integrated care and those that ultimately will be the people who will help deliver integrated care. And I think that if we could come up with that curriculum, we could incorporate that into the training across all the training bodies. It will vary from speciality to speciality because some will have more involvement than others, but I think including it certainly at different levels of standards across the curriculum would be important.
Thanks, Ed. Now, Deirdre, how are you feeling? Are you ready to answer?
Well, in the interest of time, with my magic wand, I'm going to grant all of their wishes come true.
Well done.
That was amazing. Well, listen, I just want to say thank you so much to everybody. It's been a great pleasure talking to you, and thank you so much to you all for listening. And yes, I'm not sure what comes next. Lunch. Lunch. Enjoy lunch.
Now, good afternoon. I invite you to come in and take a seat, and hopefully you are well fed and watered and ready for another cracking afternoon. So my name is Professor Anya Carroll. I am Professor of Integrated Care and Improvement at UCD and a consultant in rehabilitation at the National Rehabilitation Hospital. It's also my very great privilege to chair the International Foundation, and together with Fiona Lyne, we are co-directors of IFIC Ireland. And I'm absolutely delighted to be co-chairing this Sláintecare session. And I think it's important for us to reflect on the relationship that IFIC Ireland have had with Sláintecare. So the Sláintecare office have been really important partners to the work of IFIC Ireland, and we have worked really well in partnership for the last 5 years. And really, we couldn't do the work that we do without the work of and support of Sláintecare. So firstly, I would like to say my sincere thanks to the Sláintecare office for all the support that they have given to the work of IFIC Ireland and indeed IFIC in advancing the knowledge and adoption of integrated care in policy and practice throughout Ireland. So the work that we do in IFIC Ireland supports the work of Sláintecare, and vice versa. Sláintecare supports the work of IFIC Ireland. So I think it's a really nice synergistic relationship that we've had over the last number of years. So for this session, we're going to be looking at teams of the future. And I think we got quite a bit of feedback from participants from previous conferences, and we listen and we act on the feedback that we get. So you'll have noticed at this conference that there's much less in the way of didactic lectures and much more discussion and much more about the practical application. So this session is about living integrated care, and it's the living integrated care that exists in Ireland. And I'm writing a piece at the moment, nearly finished it, on reflecting on 5 years of IFIC Ireland and what we have observed in participation at conferences, in submissions to the International Journal for Integrated Care, in the submissions for the different conferences, in the participation in the different educational offerings, is basically that Ireland is going from strength to strength. And rather than just being, if you like, a passive recipient of these knowledge offerings, that actually Ireland has stepped front and centre of integrated care knowledge creation and adoption, which is just absolutely fantastic. So I would like to take the opportunity to thank each and every one of you for the work that you do on a daily basis. It's really important, it matters, and it makes a difference. So it is my very great pleasure to open this session on living integrated care and to introduce you to Muriel Farrell, who is from the Sláintecare Programme Office. Thank you, Muriel.
Thank you, Anya. And it's always a great pleasure to be here on these days. And I think Risha Smith said we always manage to bring sun to UCD, so we'll take the credit for that one as well today. I hope you're all enjoying the conference and you got an opportunity to catch up with your colleagues over lunch. As Anya mentioned, I work in the Sláintecare Programme Management Office in the Department of Health, and I lead on the Sláintecare Integration Innovation Fund programme, which is one of the key projects in the overall health reform programme. Many of you have probably seen this slide before, but just in case there's anybody out there who hasn't, the department, in collaboration with the HSC, are fostering a culture of innovation among the healthcare workforce to support the delivery of health service reform through the Sláintecare Integration Innovation Fund, which is supporting frontline healthcare workers through financial investment to test new care pathways and technologies and new ways of working, with a view to mainstreaming and scaling if successful. The SIF, as we call it, is a ring-fenced multi-annual fund allocated in the annual health budget, first in 2019, and it supports projects with a focus to deliver the right care in the right place, at the right time, and by the right team. And since 2020, 47 million euro was committed to 143 projects through 3 rounds of funding, and we are currently prioritising projects for funding through SIF Round 4 in collaboration with the HSC and also with PUBL. Once again, it's a great pleasure to be here and introducing you to a dedicated group of frontline healthcare leaders who we've been working with over the last 2 years through the fund. They identified where improvements could be made in their services that they work in. They deliver and are demonstrating their leadership in innovative skills to design, develop, and most importantly, to implement alternative ways of meeting their patients' needs, with the patient at the centre and adapting when they are presented with challenges along the way. And indeed, there are many challenges, and they'll speak to you about those. They are building on what works well in the health system, leveraging technology where possible and adapting new ways of working. They have measurable outcomes and outputs. They are providing insight into how teams will work in the future. They are demonstrating real-life examples of what delivering the right care in the right place, at the right time, by the right team, with the patient at the centre, and how that all looks like in action. And we know these are the key elements of an integrated care system. I know you will enjoy hearing from our colleagues. First of all, from the LIN team, we have Dr. Tinta Deasy, Dr. Deirdre Cleary, and Colette Goonan. From the Lecaila Child and Adolescent Primary Care Project, we have Ailish Daignan and Rosemary Kavanagh. And our colleagues here in the UCD Diploma in Primary Care Nursing Practice, Regina Lennon and Dr. Walter Cullen. And from the Smile to supporting multi-morbidity self-care through integration, learning and e-health, we have Mary Burke. And panel members will also include Dr. Ciara Martin. She's the National Clinical Advisor and Group Lead for Children and Young People in the HSE, Aidan Byrne, Data Analytics Lead with CareDoc, and Aisling White, the Lecaila Project Lead. I will hand you over now to the LIN team, and the LIN team have come from the West today, and I know you will look forward to hearing from all our speakers. Thank you.
Good afternoon. It's a great privilege to be here to talk today briefly about our project. I'm sure we could talk for much longer than 10 minutes, but we'll try to give you the essence of it as quickly as possible. Now, if I can get the technology to work. So the LIN team is a multidisciplinary, interdisciplinary team based within primary care in Galway. So we are made up of the traditional clinicians you'd expect to find in primary care. So senior clinical psychologist here beside me, Deirdre Cleary, speech and language therapist, occupational therapist, dietitian, and then I suppose disciplines that you'd find more likely in the acute setting from general paediatrics. So myself as a children's nurse, Dr. Tinta Deasy is a paediatrician, and we have a social worker with us. And I suppose what we are trying to do is to provide care for children that previously would have been seen as too complex to be managed in primary care. They require more care than primary care would previously have given, and they benefit from the use of a biopsychosocial model. So, sorry, I'm getting confused because I keep saying, okay, so we're based in Galway City, and I suppose it's an area of the country that's got some very, very beautiful and very expensive properties, but it's also got a very diverse population and quite a lot of disadvantage within that. You can see there from the slide, you know, the various mixture that is there. I suppose combined with that, there's the reality that, you know, the caseload, the children there are becoming more complex. So whether it's through the increased prevalence of neurodiversity, or whether it's through, I suppose, mental health difficulties with children, with parents, it's much more complex than it once would have been. So this slide here, I suppose, with the use of COGS, we're trying to show that working, that integrated working. I'm not sure that our IT skills fully showed it as well as we'd like it to, but the LIN team is there in the middle. And I suppose we were one of the groups when they spoke about the OECD study this morning. We were one of the groups they spoke to. And one of the things they asked us was, you know, were we finding it difficult to work as part of a team? And I think we probably looked at them baffled for a couple of minutes, and then we said, well, no, this is why we chose to come forward and to apply to work as part of this project, because that's absolutely the way we think and the way we want to be. And I suppose we're trying to model that multidisciplinary, interdisciplinary way of working that is intrinsic, I think, to all of us, to the wider team in primary care. And I suppose we all know that previously in the way services were set up, there was an element of them being set up in silos. There was a practice of maybe people working in a more unidisciplinary way, and asking people to move away from that is something I suppose that can instill fear. I suppose whether people are afraid of, you know, being exposed in their ability to work in a different way, or whether they're afraid they're going to be overwhelmed. Maybe the walls of those silos are giving them very clear criteria of who they can and can't see, and if those come down, you know, they're never going to get on top of it all. And I suppose the way of working, that diagram, I suppose, shows all the other organisations that there are within the HSE, within healthcare, disabilities, community, that all work together. But often they don't work in a way that provides a really patient-centred, holistic method of care. So then I suppose, how do we do it? So if we look at the first side where we've got referrals, I suppose that's really why do children come to the LIN team? And it's because really, I suppose, that people recognise they need a little bit more advice. They need a different way of being managed. So if we start at the top, I suppose the referrals for general paediatrics generally comes through the health links, and those would come largely through the emergency department, GPs and the community medical doctors. Then if we look at the others, I think it's often where people recognise that a child is a little bit more complex. They're going to need a very integrated way of managing them, and they're wondering how is the best way to do that? What's the best way to practically arrange that around the child? So the middle section there, I suppose, is how we discuss and how we decide what way a child is best and their family is best looked after. So they come to the general paediatric clinic. I suppose I came out expecting, general peds is generally seen as high volume, low acuity. I thought maybe that's what we were going to see. I didn't realise that the line on the top of the referral that looked relatively simple, whatever was wrong with the child, was really just the tip of an iceberg when we often got those children into clinic. We also offer, as well as a straightforward Gen Peds clinic, we offer a Gen Peds and dietetics clinic as well. We have a LIN MDT consult clinic, which Deirdre leads, and that has been great just for that first, I suppose, look at a child and family, a very open discussion, and just getting a feel for and an idea for what their needs are, what they see as their priorities, and how we go around that. And then at the bottom, and actually I probably should have put that one first, we have an MDT discussion at our primary care team meeting once a month. And I suppose to give an indication of how that's going, a year and a half ago, the cut-off was 20 children that could be brought to that for discussion. And it was generally, I think if anybody was overwhelmed, it was probably us. We think this child should go to the LIN team. We think this child should go to the LIN team. And over time, I think the other clinicians within primary care have seen, no, there's other ways of doing this. And actually at our last meeting this month, there was only 4 children on the new patient list, which was kind of amazing. So then what sort of care, what sort of arrangements might happen for these children? So sometimes with the benefit of discussion, talking to other clinicians, it just continues with unidisciplinary work. They're happy, having spoken to others, they know what they're doing, where they can get the bit of support they need. A short episode of multidisciplinary care with the existing primary care technician. So where before they might have worked very individually, one wouldn't have known that somebody else was necessarily seeing the child or was on their waiting list, they can now come together to meet with the child and family. Then where I suppose there's something in primary care, they'd appreciate the expertise of one member of the team or 2 members of the team. We'll work with them for a period of time with that child. They may be taken wholly into the LIN team. And of course, there are always children, unfortunately, who need to be referred elsewhere, that their needs really can't be met within the team. So I have a case study here that I'm not really going to go into in depth, but I suppose it's just to give you a brief idea, I suppose, of how things can happen. So this was a young teenager with gender incongruence who was on a waiting list for an assessment of need, got their assessment of need privately from a psychologist, got their diagnosis, but then there was nothing else for them afterwards. They were, I suppose, let loose from that. They were attending their GP, and the child's needs, I suppose, were becoming more and more difficult, becoming more anxious, missing school, etc. It was on the 3rd referral to CAMS that the child was deemed to actually meet the criteria. So in the meanwhile, the GP was trying to manage them, and in the process, the child needed a referral to the general peds clinic. And when they came to us again, it was menorrhagia was on the top of that referral, and the first thing tend to ask the child and mum was, what's actually your biggest priority, what's bothering you? And it was a whole list of other things. So I suppose they went to the consult clinic, they had the benefit of the MDT meeting with them and getting an idea of what might help. A diagnosis of DCD was kind of wandering around, that was confirmed. Then that opened up, I suppose, the window for people to go talk to the school, put in sports in school, and have that contact for them to come back to. And I suppose I have an asterisk on the OT there on that, and that's because in actual fact, because the child was under CAMS, the way services are set up, they weren't allowed to be seen by OT in the community. We had to get special permission for that to happen. So it's just when you find things like that, you really wonder. And you can see just a comment there from that family. So then, I suppose information comes in all different ways and everybody likes the numbers. So we run a general paediatric clinic, a combined paediatric and dietetics clinic, and a DCD clinic where we confirm the diagnosis of DCD. So prior to this starting, there was a 17-month waiting list for a child to have their first general paediatric appointment in University Hospital Galway. That is now down to the very acceptable level of sort of 3 to 4 months. Then the dietetic waiting list in the community was very, very long, and often the children that we would be seeing wouldn't have been triaged very high on that list. We can now see them almost immediately if needed. The children waiting for a diagnosis of DCD would be 2 years waiting to see an OT, and then would have to go on a waiting list for paediatrics in the hospital, which would be another possibly a year. So we're able to get all of those through much more quickly and much more efficiently than before. And then just to say, I suppose, since the PEDS clinic was set up last November, 12 months, we have offered 814 appointments, of which 73% were new and 27% were reviews. We've seen 632 patients in total, and our discharge rate, I suppose we were just working it out, is only about 18%, which seems a little bit low, but I think it's because of the complexity of the children we're seeing, and I suppose our intention to really make sure we have made the difference, we have moved on with the problem, as opposed to ticking a box saying they've had their appointment and letting them back out the door without being confident. So that's often why we review them, just to make sure that we have really helped them with what they need. I'm going to hand over now to my colleague, Dr. Deirdre Cleary. Thank you.
Thanks, Colette. So I'm just going to talk a little bit around the allied health strand, I suppose, of the team. As Colette said, I'm the psychologist on the team, so I've come from a 10-year history prior to joining the LIN team of working in that unidisciplinary way. So it's been a real joy to kind of work differently with kids and to work with a more integrated perspective on them. One of the key things that we've looked at, I suppose, with the advent of progressing disabilities was we've had a huge increase in referrals for children for autism diagnostic assessments. And I think that's seen across the board, also in CDNTs. And historically, a lot of those assessments were outsourced at huge cost to the HSE. So what we've tried to do is really develop, along with all primary care clinicians, I suppose, SLT, OT, and other psychologists within our network, a real focus on developing our confidence and competence, because I think they were already there and we were identifying and screening for autism, but we just hadn't progressed maybe to doing those diagnostic assessments. So with the supervision of a lecturer in Galway University, we've been able to get supervision and we've been able to progress those assessments in-house, which for families has been great, because before they were working with clinicians, but then they had to be outsourced. So it was developing new relationships again, a key feature that was mentioned earlier. So that's been a real great initiative, I think, to be able to do that. We've also worked really closely with their colleagues in paediatrics who've joined us with those, and where they've known children or they also feel that a neurodevelopmental diagnosis has indicated that they've shared information and we've been able to support a diagnosis jointly. So far there's been 36 children who've come through that pathway where we've been able to do those diagnostic assessments in-house. I suppose, another piece that, as Colette mentioned, we've been doing a lot of consult or drop-in clinics. We've had 57 of those to date. So it just reduces the times that families are waiting to be seen. We can see them quickly. We can kind of make sure that they're on waiting lists for services, give them some interim support and guidance while they're waiting, and also signpost them to workshops and groups that we may be running, some of which are, sorry, I'm forgetting to go, like the Circle of Security, early bird, for post-diagnostic supports. We run workshops on regulation, transition to primary school, so lots of different kind of workshops in train and hopefully more in the future. We've also ongoing research, so I suppose we do really encourage trainees to come and join us. So we have a number of psychology trainees with us at the minute, and there's ongoing research, I suppose, in terms of profiling the kind of child that we work with. We're also looking at, feedback from the drop-in clinics or the consult clinics, and also from the autism pathway, just to make sure that we get that client and service user voice. I suppose just to mention on that, like even from psychology alone, I think when we first started, waiting lists were in excess of 2 years. Now we only have 5 people in our network who are waiting for psychology for over a year. So really impacting on waiting lists as well. So just some feedback, I suppose, from families. Most importantly, I suppose, looking at the compassionate care that they feel they've received. Communication, I suppose, both with those people who are working with families that were much more open to being able to share information, to avoid families having to repeat the same story over and over again, but also then between professionals and families, much more effective communication. I suppose there's also less duplication in terms of the working, that we can offer appointments together. We're often really mindful if there's 2 children who are linked in with services that we'll pick up the phone to the SLT and say, well, what time are they coming in? Can we join? Can we reduce time out of school? Can we, share school observations? So anything that's kind of very much child and family focused. Again, just a little bit of a word cloud, feedback from our colleagues within primary care in terms of how they've found the LIN support. I suppose it's very much integrated, and we really work very closely with our colleagues throughout primary care. If they know a child, we are very ready to join with them rather than coming in and taking over when those relationships are already embedded. So as you'll see, there's some lovely kind of feedback in terms of how we've been working together so far. And then a little bit more just from staff and also from GPs. And really, I suppose we feel those parallel processes. If staff are working really well together, families are going to experience that as well. So very much kind of driving that, that we're all working in the same way together with really better outcomes then for children and families in the longer term. Future initiatives, and Tintin will touch on this a little bit more as well, but I suppose we're really, I suppose historically when referrers were making referrals into primary care, they have to fill out a separate referral for every discipline. So really time consuming. Again, then we don't know what children are being seen by different disciplines. So we're really eager to progress a single point of entry. It's been quite difficult, I suppose, from an ICT perspective in terms of developing the systems that can support that. But even for now, we're just really trying to come together with heads of discipline involved to share that information in a streamlined way using one referral form across all disciplines. Ongoing research and focus groups, and I suppose the big takeaway, especially for me today listening, the importance of children and families in that. We're really eager to move forward and get more parent and child engagement and form parent panels going forward. We really hope to continue our integration with local services like CDNT, with CAMS, with NEPS, with TUSLA, all real key stakeholders in children's care. So we started that, but we really hope to continue that in coming months. We really hope to extend the workshops and groups that we have on offer, including looking at feeding and obesity together with when we have paediatrics and dietetics on board, and also to run a few more interdisciplinary clinics, I suppose, that we work together and we learn from each other is really, really valued. And then ongoing, I suppose, strategic planning and engagement with the Department of Health to support us. So just one little quote, I suppose, that stood out from GP, that every childhood lasts a lifetime, so time is of the essence. Speedy expert opinion and input in the community is so very necessary. And we're just going to end then on a little clip.
My husband and I first encountered the LIN team to have our son assessed. He's now 13. We had spent years going around in circles trying to get our son assessed, trying to get him seen, trying to connect all the different assessments together into a diagnosis, but we had great difficulty doing that. But when we encountered the LIN team, immediately I knew that we had found the right place, and that just came from our first meeting with Deirdre, who was so compassionate, so professional, and the one thing she said at the end of our meeting with her was, here's my number, here's my email address, if you need to get in touch, get in touch. And that was the first time in our whole experience that somebody had presented themselves as a contact point, as a liaison for, the various different assessments that were going to take place. So I was immediately reassured by that and had great confidence in her and the team, and that proved to be absolutely accurate. Our son very quickly and coherently progressed through assessments, through diagnosis, and then was discharged. And that all happened so professionally. It was so well organised, it was so well run. He was happy to attend the assessments, and that was all, I think, to do with the team and how kind and gentle and caring they were with him. And it gave us also a great understanding of him and of his difficulties, and it gave him a better understanding of himself, I think. The courses that we attended were excellent, far more helpful than I had expected, actually. It was brilliant to meet other parents and listen to their experience and recognise parts of our experience in their experience. That really helped, actually. It was very reassuring to hear and to know that you're not alone in this experience. And I just found it to be an absolutely essential service. For us, it was life-changing. For our son, it was life-changing, and I think it's a brilliant service, very much needed in the community, and it changed everything for us.
Hi, everybody. So my name is Rosemary Kavanagh, and I am from the Lacala project. So I'm working as project coordinator on that project, and I'm a speech and language therapist. And with my colleague Eilish, we're going to present some information about our project. Great, thank you. So we'll outline kind of the main aspects of the Lacala project. And like the LIN project, the Lacala project is a Sláintecare Integration Innovation Fund project. I can see why we shortened that to SIF. Bit of a mouthful. So our project has been kind of, I suppose, operational really in earnest since about May 2023. Okay. Right, so just to put it in context, I suppose, so the original project site was one community healthcare network in Dublin South, so CHN4, as shown on this graphic here. And as you can see, the population is 60,000 with a child population of almost 13,000. And there's a mix of affluent, average, and some areas of social deprivation. So like our colleagues, in Galway, the Lacala project was granted a 12-month extension. And for the extension, which runs until December 2025, we made a local decision to expand the multidisciplinary team aspect of the project to include families living in the two other community healthcare networks in Dublin South. So you can see here on this graphic that for the remainder of the project, so for the rest of the year, we'll operate across CHN 3, 4 and 5. And this is feasible for our site, I suppose, because of the relatively small geographical area that we're covering, and also because of, as a result of the project and other initiatives, the increase in general in joint working and multidisciplinary work in the area. So before I take you through some details of the project, I want to just share a video clip of parents describing their experience of their engagement with the Lacala team, and hopefully that will just help put the rest of the presentation in context.
Later, we got a couple of really good leaflets in the post. One explaining what Lacala was all about to the parents, us, and then another one for our son to be able to read, which is great. So our son is 11. So this was really helpful. It was a great start. And then soon after that, we had an appointment to come down and meet with the team. And so we met with a couple of people on the team. So a psychologist, occupational therapist, and speech and language therapist as well. So, and we had a meeting with them, and they explained more about what they were hoping to do or what the team had been set up to do. And then they began a series of meetings with us and also with Cathal. So we'd go along and Cathal would go and have some kind of fun and play with some of the team in one room, and we would sit down in the other room. And so over time, they got to know us all, and we got to know them. And so that's what I think has been a real kind of strength in this, is that we kind of really feel that the team know our son, and that they know us, and that we've had a really kind of complete, we've had the opportunity to kind of give a very full picture of who he is, and also the team have themselves been able to observe who he is and how he interacts, and what his interests are, etc., etc. So I suppose we would have all had meetings maybe about 3 or 4 times, and then the team then would have made very helpful kind of pathway suggestions for both us as parents. So we're now participating in a program called Teen Life, which is really informative for Fergal and I. Like, we're really finding it excellent, because it's information that we hadn't come across before. And we're there with other parents who have neurodivergent children as well. So everybody's learning together and learning from each other, and it's very positive. And then the other thing is that the team also were able to do some assessments on Cathal, which he hadn't had before. So ADOS and ADIR, and Connor's assessment as well. So that's been really helpful. And it has thrown up kind of a further diagnosis for Cathal. But I think really the thing that's most helpful for us is just that we feel kind of like we're in very safe hands because we feel Cathal is really being seen. The other thing to add is that they've been in the school as well. Some of the team have observed Cathal in school and also
in the wild.
In the wild, and talked to his teachers and SNA. And so they're also being able to get a picture of what his daily school life is like, which we wouldn't obviously have an insight into other than what he tells us. And that's been really great as well. And the school are really open to that, and they're finding it very helpful too, I think.
Okay, so hopefully that just puts the rest of the information that we're going to present today into context, and we'll hear from another little clip later on. Okay, so the overall aim of the project, I suppose, it was designed to address specific service delivery challenges, as Deirdre and Colette have talked about already. So an increase in volume of referrals, increase in complexity of referrals, and the need in primary care to move towards a more integrated type of service to meet those needs. The overall project aim was to test a model of more enhanced integrated MDT working in primary care. And the expected outcomes and benefits were improved clinical function and participation for children and families, an increase in parental confidence, the development of pathways of care for identified clinical presentations, a programme of staff upskilling to meet the clinical need, and the development of universal resources and supports for parents within a stepped care model. And ultimately, I suppose, greater access for children and adolescents awaiting services in primary care. Okay, so just on the slide here, you can see in terms of recruitment, so the project award was for 13.3 whole-time equivalents. Recruitment was challenging. So I suppose currently in post we have 5.2 whole-time equivalent staff on the Lakeela multidisciplinary team. And just breaking that down a little further, the key clinicians, and I think this is very much like what Deirdre spoke about, the key clinicians kind of most not needed for case management are occupational therapy, speech and language therapy, and psychology. So out of our 5.2, we have 2.4 whole-time equivalent of that group. We have a 0.8 of the senior social worker, and social workers increasingly needed to really kind of integrate the care for these families, and it really enhances the work of the rest of the team, although it's slightly different. And then my coordinator post is largely non-clinical, although I do fill the odd gap. And our psychology assistant, who is really essential to the functioning of the project, but that's a post that she works under supervision, I suppose. So just to put it in context. There's been a lot of talk this morning already about partnership, working and relationships, and I think it's something we think is really important, especially considering the relatively small resource we have in terms of staffing, and we're conscious of working closely with a variety of stakeholders to deliver the right care to families and to continue to develop and refine the model as well that's emerging. So at this point, I suppose it's fair to say that the Lakeela MDT itself works in a very integrated way, and there's very much a culture of openness, trust, and there's good psychological safety on the team. Eilish will elaborate later on work with families, but just to note that families are obviously considered a key partner in planning and delivering care for their children and young people. And we're also really fortunate with our working relationships with the rest of our primary care colleagues, and I think that's something that's improving all the time, and we're finding increasing opportunities for joint working outside of just the Lakeela MDT. We also work with local schools, preschools, TUSLA, family support services, community organisations where indicated, and we're kind of linked quite closely with our local SIPSI. We obviously have our sister project in Galway and the Lynn team, so we've met with them quite a few times, and we to reflect on what's working well and what we might change in terms of the model. So it's a great opportunity for us to learn from each other. And then together with local management, I suppose we're starting to forge links with local CAMS teams and local disability services, and that's an aspect that we'd really like to progress a little further as well. So there we are in Dún Laoghaire. We're very lucky to work in Dún Laoghaire. So also just to acknowledge everybody's work, I suppose this is very much a team effort. And Margaret Connolly, who's the network manager in Network 4, is also in this picture, and Aisling White, who's the project lead. So and you'll hear from Aisling later. Okay, and continuing, I suppose, on that theme of team working, the success of the work to date, I think, is due in large part to the way this team functions as very much a cohesive unit, reflected in what Deirdre and Colette said already, while still being able to maintain our specific roles, I suppose, and our specific disciplines.
but it is very much an integrated interdisciplinary process. And I think this quote summarises it really nicely. How teams collaborate, communicate and make decisions is a critical determinant of overall effectiveness. Understanding how individuals perceive their identity within the team and how social dynamics impact cohesion and collaboration is essential. So we kind of have an ongoing focus on that as we go and as we develop. Okay, so this slide is, I suppose, an overview of the stepped care model of paediatric primary care services that's emerging. Sorry. These in. So I will, because of time, I'm not going to go through this in a lot of detail, but the call outs, I suppose, here on the models show how the work of the project has enhanced existing primary care services. So we have a developing programme of universal and targeted supports for parents. We'll talk a little bit more about those later. We have now our MDT parent advice and consultation clinic to aid decision making. So that's a new step we have as well. And obviously the establishment of the Lacala multidisciplinary team offering integrated episodes of care where needed. Okay, and my last bit, it's a very busy slide, but it's just a working, I suppose, flow chart which provides a little more detail on that stepped care approach for children and young people with more complex presentations in primary care. And I suppose for context, we're talking about, similar to what the Lynn team have already said, children who maybe have been referred to multiple services in primary care, so they've had a referral to speech and language therapy, to occupational therapy, to psychology, maybe to dietetics somewhere else as well. Or a child who's attending a unidisciplinary service but needs then are emerging that are greater than or wider than first anticipated. So there's a need for some kind of cohesion or team approach. And this process shown on the slide here involves all of us working in primary care. So not just the Lacala team, but I suppose this work has been accelerated by having the project in our area. So looking from the top down here, you can see that we have a forum for discussing these complex cases, and that's our monthly paediatric meeting, which is open to all clinicians working in Dublin South. And then if a clear plan of action can be agreed following that case discussion, we continue down to the bottom of the model and we have our different options, which is very similar to what has already been presented in terms of the Lynn team. So we might continue with a unidisciplinary approach, but signpost to universal or targeted supports for parents. And that might include webinars, very soon to be released podcasts, which we recorded this week, resource packs, maybe targeted programs of parent support, which are listed on the right-hand side here. So things like Early Bird Plus, Teen Life, Parents Plus ADHD, loads more. Another option is that two primary care clinicians who already know the child might do a joint piece of work. A third option might be that the Lacala team will join the existing clinician and kind of support them to do an integrated assessment or piece of work. Or for some children, they will come to the team for an integrated episode of care. And we're trying now to sort of boundary that a little bit in terms of time period. So we were finding that maybe children were open for quite a long time, but maybe not that much was happening towards the end. So we're trying to think about it in terms of a 12-week episode of care, just to increase efficiency and effectiveness and see more children, acknowledging that these are children probably who have longer term needs and some may need to come back for another episode of care at a different time. But we're trying to set goals that sort of can be fulfilled within that 12-week period. And then stepping back up the model, as I mentioned already, if we can't make a kind of a clear decision about what pathway might be best, we do have that option of our integrated multidisciplinary parent advice clinic where parents can come in and have a detailed chat with a number of clinicians together and try and kind of figure out what might be the best way forward for them. So I'm going to hand over to Eilish now, who will take you through a little bit more detail about the work of the MDT.
Thanks very much, Rosemary. Now let me make sure. I don't know. I probably don't need to look at both, but it's a habit to look behind me. Okay. And I need to put my glasses on. Okay. So I'm going to contrast sequence unidisciplinary team with multidisciplinary teamwork. So in this one, this is showing unidisciplinary teams, our work works really well with children when they just need to meet one discipline, their needs are met by that. But you can see here, each colour represents a different discipline. So in this case, Kate was referred to SLT, who then referred her to occupational therapy, and then after making a school visit, referred her to psychology. And then outside all of that, she was also involved with CHI in Tala. So it meant that for her, there was reduplication. So she had 3 intake meetings. The parents was repeating information 3 times with that. There were also 3 different school visits. And I know from working in an MDT now, the usefulness of having a number of disciplines going to one being at a school at the same time is really, it can make a big difference. So I'm going to contrast that with the way a multidisciplinary team works. So I guess what I'd like to highlight here is I find at the top there, you'll see the MDT intake appointment. And what that involves is parents coming in, meeting with at least 2 disciplines on the team and having a time, an hour or an hour and a half, to talk about their best hopes from coming to Lacala. In other words, what will happen? What can our team do that will make the parents and the child's time with Lacala as useful as possible? And to creating a journey plan with the parents and incorporating goals into that. The goals are really useful because they keep it targeted, the parents' goals. Also, they're very useful outcome measure. We ask the parents to rate those goals at the start and then at the end. And that gives us very nice feedback as to the impact our team is having. And also it makes me think, because this conference is about radical workforce innovation for person-centred integrated care. And I was thinking about this because we notice in the feedback we get from parents that for many parents to have a number of disciplines, sit down, give them the time to listen to them and listen to what they want from a service, that is radical to them because they haven't necessarily experienced that when they're looking for support for their child. So it makes me think radical innovation doesn't always have to be very complicated. Radical innovation can be sitting down with parents and finding out how we can make the service as useful to them as possible, which also leads me back into my slide here, because we have different interventions. You'll see them there. But if you're targeted, if you're listening to parents, you can find out, do I need to make the school visit? Maybe would a targeted parent group work here? So it also informs that it makes a much more efficient service as well. Okay. So it's integrated working, and it's very important that not just the team, that's really important. In a later slide we talk about it. We're not sustainable, things can change. So it's very important that we're working across our 3 networks. It was Network 4, but with all our colleagues across wider Dublin South. So we have universal interventions, such as webinars. An example would be supporting children, supporting your child in managing anxiety or managing big emotions. They were 2 webinars we did. And as Rosemary said, she and some other of our colleagues in the team and from wider primary care recorded 2 podcasts earlier this week. So keep an ear out. They're going to be broadcast in September. And they're also about managing anxiety and big emotions. Isn't that right? Yeah. The other thing we have is, which is a very good innovation, is having MDT pediatric meeting every month where the clinicians across all networks can come if they have a child that they feel actually needs more than one, seems to need the care support of more than one discipline. They can bring that child to be discussed, and even that discussion is useful, and then recommendations can be made. That's one of the ways maybe that a child might be determined actually a child would benefit from the Lacala team. But another recommendation could be the MDT advice, the parent advice clinic, which is where parents are already in the service, but maybe they need, again, the support of more than one discipline. That's another lovely opportunity for parents to meet with usually 3 disciplines, and for that time to listen to the parent, find out what kind of other support would they like. And so it's a kind of intervention in itself, but having done it, I find it can really help parents come with questions. It can clarify the quagmire, if that's the right word to use, that the primary care services can often be, and parents aren't sure where they've been referred. So it's a good opportunity to clarify all of that, and also make sure the referrals in place are the correct ones, and also maybe pathway them into some of the targeted parent groups that we run now, which are actually, Rosemary, you mentioned them already. Ones like, again, it's across the 3 networks. So we're running Early Bird Plus and Teen Life, which are for parents of autistic children and teenagers. We're also running alert groups, Circle of Security, which is to support parents in managing behaviour and their attachment with their child. Also Parents Plus ADHD and Parents Plus groups. And again, making connection, it's all about integrated working. We are making connections with Children and Young People Services Committees, that's also known as CIPSI, CDNT, our local one, and our local John of God's Child and Adolescent Mental Health Service. Outcome and evaluation data is always really important. We have to show that what we're doing is making a difference. So we get qualitative measures and quantitative measures, and something that's not written there, but actually also I should mention, we do collect from children and teenagers as well, because we want to know what difference has coming to the service made to them. And this slide is very, very important to us, also very, very important to Pobble. They always like to have this information. So I'm going to have to read it here, I think. I've got the wrong distance, my glass on. So 117 families have benefited from paediatric MDT consultation, assessment and intervention. So that's with the Lacala team. 72 parents have attended targeted group intervention programs. And there's a range of universal supports, which we mentioned already in webinars and podcasts. Over 500 people have accessed those. And we have our monthly MDT meeting and a interim central point that provides an interim central point of referral. And since 2023, 179 children from CHN4 and 312 children in the total across the 3 networks have been reviewed at monthly MDT case discussions. Okay, now I have just going to play another nice bit from these parents who accessed our locality.
I think it's a really positive way to support a family, has been our experience.
As you say, we've gone from being lost to having a full wraparound support. That's what it feels like, and it's we were floating, in the sea with concern and worry, and
now we're not.
And now we're
really
not. Yeah.
We feel that we're getting equipped ourselves with kind of resources and information and strategies and kind of understanding about what it's about how to, and there's been such an improvement already for Cathal, and it's helpful to be able to discuss it with him on a level as well, to say this is what's going on for you, and we're all on board to try and kind of help you negotiate your way through different things that are difficult and challenging. So
a little bit of feedback from parents around enhanced CHN and MDT working. You get to tell your story once and you don't have to keep repeating yourself. That is a very common theme. I'm not sure if it comes up for you if you've been trying to access service or working in a service. Self-management, which is always what we're aiming towards. So the opportunity to talk through the challenges and to trial possible solutions, to reassess the solutions and then try another approach. And then integrated working, these are from our colleagues we work with across Dublin South, in pulling clinicians and services together to my glasses are not working properly. Sorry. Anyway, you can read it, but it's a very nice one for bringing the importance of clinicians working together. Okay. So just the last couple of slides. What have we learned from so far? So we're learning that psychology, speech and language therapy, and OT disciplines are most often clinically required for joint work, and social work is essential. We have a social worker; she's brilliant, and I've learned so much from her. The staff successfully recruited to the project are competent and experienced with complex case working, and also the importance of working on the team. There was a presentation I watched earlier about that. It's so important. Teams just don't happen. Upskilling and building integrated work practices across the whole community healthcare network is important, because you don't know what's going to happen, and also it's very important that all clinicians are able to deliver the same kind of quality of care. And good communication between the team, between your clinicians in the primary care service, also with referral sources and all the services working, so they're clear about what our role is and how to access it. Challenges, recruitment is always a difficulty, short-term contracts are unattractive. The throughput is slower for complex cases, and also increasing referral rates and other vacancies in the Network 4 can impact. Okay, thank you very much everybody for listening.
Hi everybody, my name is Regina Lennon. I'm Programme Director of the Primary Care Nursing Practice. I want to introduce Dr. Walter Cullen, who is from the School of Medicine, and hiding down there is the Associate Professor Rita Smith, who is instrumental to the success of this. So I suppose what I'm going to look at is what is the ethos of Sláintecare, of stay left, shift left, and primary care. And when we look at that, we're looking at enhancing accessibility, primary care, or coordination, care and coordination, identification and prevention. And I suppose what's key to all of that is that we have primary care specialist nurses who are key for care coordination, continuity of care within that person-centred piece. And what does that do if we have all of those resources put into people who are working on the ground, is that you have more effective, cost-effective for the citizens of Ireland. So I'm just going to introduce Walter, who's going to just talk about the two schools working together.
So I'm Walter Cullen from the UCD School of Medicine. I'm a general practitioner. And just to say that we've been delighted to be involved with our colleagues from the School of Nursing on this really important initiative.
Where the UCD. Anyway, while they're organising that, the testimonials, I just want to highlight one of the key things from this testimonials is the working between two different nursing disciplines, whether it's the general practice nurses and the community RGNs together. And then even when that's Evelyn Kelly speaking, and with John speaking, he's a GP. And just that respect and that building momentum and that relationship with the building between them.
My name is Evelyn Kelly. I'm a community nurse. I completed the primary care nursing practice course in its first year in 2023 to 2024. The course has been invaluable to me in improving my knowledge and my confidence in my practice. One of the most important things I've learned is the importance of empowering patients by imparting evidence-based information and knowledge onto them in a way that they understand, and it allows patients to make an informed decision about their care, about their plans for the future, which is imperative. Through meeting my fellow students, from maybe GP practice nurses, and also some of the GP lecturers, it's been really eye-opening for us. We work alongside each other so much, but yet don't often communicate very much, and the lines of communication can sometimes be quite difficult. So I've seen a need for improved communication between GP practices and primary care, and an opportunity arose for a change project to improve communication. So I felt I had such good insight from the course and from discussing issues fellow community nurses and GP practice nurses had during the course, that I felt I was in a really good position to bring some knowledge and background to the course. So I'm co-chair on a change project to improve communications between the GP practices and the primary care teams, which is progressing quite well. And I don't think, having done the course, that I wouldn't, first of all, I wouldn't have had the insight, but second of all, I don't know if I would have the confidence to put myself forward for such a project. So it has really improved my practice.
My name is Dr. John Brennan. I'm a GP based in County Kilkenny. We work in a rural practice looking after about 2,500 people across an area of 265 square kilometres. Over the last year, we've been incredibly lucky to have 2 of our team members take part in the graduate diploma in primary care nursing practice at UCD. The skills, insights and learning that they've brought back to our practice has been really invaluable. We always strive to provide care that's safe, coordinated, comprehensive, continuous, first contact accessible, and most importantly of all, person-centred. There's no doubt for us that the skills and the learning that our team members have brought back from the programme has been really invaluable in helping us to do a better job for our patients every day.
So to bring that together, what was our objective? So it's to demonstrate a clear proof of concept that an education programme that was aligned with the Sláintecare building capacity for stay left, shift left. So what we're trying to do was a professional workforce that produces primary care specialist nurses. So when I say specialist, I mean expert generalists delivering safe, high quality, person-centred care. So this is our proof of concept. Just an overview of the programme. Who met the criteria was general practice nurses and community RGNs that worked in the public health nursing service. It's a 1-year programme with 60 credits, and it's funded by, the fees are funded by Sláintecare. It's covered under the National Framework for Qualifications and NMBI accredited at level 9. Just hand over to Walter.
And I suppose the key point here is the importance of all of the stakeholders who've contributed to the design and development and delivery of this programme. So as well as the schools of nursing and medicine in terms of developing and delivering the programme, we were very fortunate to have very strong and engaged and committed support from a wide range of stakeholders. The Irish College of General Practitioners, the Irish General Practice Nurse Education Association, PUBL and Sláintecare, of course, and the HSE and the Department of Health. All of these agencies were represented in our steering group. All of these agencies contributed to discussions around what was going to be in the curriculum, how are we going to teach it, how are we going to assess it, and have been very much actively engaged partners in the programme and its development.
So what does the programme look like? This is a visual picture. And when you look at the very start, Rita's module, it's Advanced Health Assessment. So that is the head-to-toe assessment, and that's early recognition and prevention. We look at the contemporary issues in primary care, and that's the competencies, skills and knowledge. We look at the 4 corners, and we look at quality patient safety and quality care. And then we look at the centre, which is the key essence of that patient-centred care, that care coordination, patient-centred care plans, and really focus on those patient outcome measurements, and that's the key. What you see at the very bottom is the application, because it's great seeing a slide, but what's important is the application into everyday practice. And having those competency frameworks that we have with MBI is about implementing what you're learning in everyday in university and putting that into place every day. And you can really see that through the direct codes. So within UCD, we have very strong governance situations, and we've a track record of those quality assurance, and not only through UCD, but we have our NMBI accreditations, and within that framework, we always making sure that we have assured quality. It's gone skipped up there, but Sláintecare, PUBL, and our external evaluation have given us that credibility. Just to see the response rates, so in UCD usually it'd be 15% response rate, so to get those response rates really goes down to that commitment and engagement and having those students reps on our steering groups. So we've had internal evaluation and external evaluation, so I'm just going to focus in on the internal first. So again, you can see the response rates, and what it showed was that there was increased knowledge, confidence, skills, and it had a positive impact. Just to focus on the patient-centred care, that's one of the key things that you can really see is that you go from ticking a box to actually that purposeful reflection and seeing the person and their needs, not the disease, but the actual person. And if you see the direct quotes from the students, I am supporting patients to take ownership of their conditions by giving them more tailored education. That's really focusing on that skill sets and the tools that we give them around our motivational interviewing, making every content count, or teach back systems, all building that confidence in allowing the patient to tell their story. Involving patients in all aspects of planning their care and completing the coordinated integrated care pathways for my patients. Our next one is supervisor employer. So we had one-on-one interviews that the research worked with, and Sheila from the School of Medicine. And what was really key was the valuable knowledge and clinical skills. So whether it's from the School of Medicine, from the contemporary issues, that knowledge they're building, to the advanced health assessment, where that head to toe and learning the systems. But she developed her clinical skills, critical decision making, can carry out assessments, make referrals, see patients earlier, can see a growth and development. So you can really see that feedback that is coming through. Next is the patient feedback internal evaluation. So it's really important to have the voice of the patient. It can be really difficult, but it was so enlightening to sit there and listen to the patients. And what really comes across is that the darkness, where they're just either looking after themselves or looking after a family member, and suddenly a nurse gets involved, and that care coordination, and suddenly all of these services are open to them, so they don't feel so isolated. And we look at Tilda, that's what, like, our national longitudinal study has shown, it attributes with the lack of awareness about available services. So using those grassroots nurses that work on the ground and making sure they're competent. So if we look at what ways do we do that, and we look at the exposure hours. So we have 110 students that have gone through. 110 of those students have done 30 exposure hours, where they've gone out and met different professionals. And the things you hear back is that I met the integrated respiratory nurse. I never even knew I could refer myself, or I refer as a nurse to my patients to that service. You talk about like the alone services and how amazing those services are. So it's like you're building, and because they're sharing from each other, you're building this whole group. So for both me, just to put across what the patients were saying, I wouldn't have known I could get help with my family member. So it's just really positive. So this gives the credibility, and I suppose it really puts across the external evaluation. So an outside body came in and evaluated our program through a mixed method approach. And it gives credibility and objectivity to what we were seeing in our internal reports. And I suppose what's key that really came across is the quality of care and patient safety. And one of the key aspects of our program, and why you're saying not a passive direct post where I will do this, they're actually actively doing it. And that's that student-centered approaches, that collaborative interprofessional teaching that we use. So we have demonstrated a proof of concept to equip students with the knowledge, skills, and competence to enhance primary care specialty nursing, to deliver safe, high-quality, person-centered care. Our outputs and outcomes, the main one is that we've 58 that have completed and 52 that are going to. Our risks are really important because as we did our evaluations, for transparency, we're able to put these on the risk and then feed them back to our steering group. And I suppose that's shared responsibility, and I'll go through them at the end. But one of the key things that came from that external evaluation is that the primary care programme has potential to make a significant national impact of patient care, as evidenced throughout the report. So it's just really significant what was coming up. So yeah, what we have done, the proof of concept have shown that we primary care specialist nurses that have the safe, high quality, person-centered care. We're fostering agile, resilient and future-focused nursing. And I suppose the recommendations is to sustain the primary care nursing programme, to elevate professional recognition and value of community RGNs and GPNs as primary care nurses. So if they've done this programme, what makes them different from other programmes? Where can we recognise who they are? Expand care pathways, and that's, I really want that voice of the students who really wants that recognition and that pathway that goes forwards that you would have in a hospital system in the community. Where are those specialist roles, those A&P roles that look at the expert generalist as a special, and that's the person as a centre, not the disease. And I suppose, like anything, just continue with that research and that feedback from patients. So just going to lastly hand over.
So it's been an absolute privilege to work in this programme with colleagues from the School of Nursing and with the wide range of stakeholders. Regina has shown how we've developed a programme that's evidence-based, that's focused on patient-centredness, and which has been positively evaluated in an independent external evaluation. We look forward to the next phases and the next opportunities and hoping that the work continues in the future. But really, we just wanted to primarily say huge thanks to Pobble and Sláintecare, without whose funding, I guess, this work wouldn't have been possible. And thank you very much.
Good afternoon, everybody. I'm Mary Burke, and I'm Clinical Manager with CareDoc. I know we're under a bit of a time pressure, so I'll quickly go through the slides, and I do have a short video at the end, which is really important because the patient is telling the story of what the service is about in probably a better way than I'll do. So I'm going to talk about the SMILE service, and that stands for Supporting Multimorbidity Self-Care Through Integration, Learning and E-Health. And I suppose it continues on the theme of this morning when Professor Martin Curley mentioned the digitalised stethoscope. But we also have digitalised wearable technology that our patients are self-monitoring and reporting and managing their health, and now able to identify when those vital signs go out of sync, what it might mean. So I'll walk you through what the service is about and how it runs. So it's virtual case management of patients with multimorbidity by experienced triage nurses combined with remote patient monitoring via wearable devices. And you'll see example there in the pictures. You can see the blood pressure monitor, which is Bluetooth its data onto the Samsung tablet. You've got a watch, which looks like a watch, but it actually monitors sleep, steps, and pulse. And all that data then comes back to the triage nurse where she can evaluate it. So we're supporting patients to live more independently, reduce their episodes of illness, and improve their health. So the objectives of the SMILE service are to reduce frequent unscheduled visits and late presentations to hospital and general practitioners. I suppose we're all very aware patients with chronic disease unfortunately spend long periods of time. They attend hospital and then have admitted and spend long periods of time in the hospital. Again, and have frequent attendances with their practice. So we want to look at how we can change that. We want to shift care to the community. I suppose it's providing the right care by the right clinician in the right place. And the right place for those is within the home where we can provide that. We want to integrate the services with the enhanced community care programme. We want to develop pathways and processes that are scalable and empower patients to self-care. That's a really important element. So how does the SMILE service work? So patients with 2 or more chronic diseases are identified by clinicians, and these are their GP, it could be the integrated care team in a hospital, it's nurse specialists, it's the chronic disease hubs in the community, identifying suitable patients. And one of the simple criteria is within that, not alone are they having 2 chronic diseases, but if they have had frequent attendances in hospital or with their GP. Engagement and enrolment takes place between the teams. Suitable monitoring devices are allocated dependent on their health condition. So whether it's diabetic monitoring, whether it's heart failure monitoring. Individualised thresholds then are set on the digital platform. Digital support kits and full training is provided to patient carers in their own home. I'll talk a little bit about that later. So then we talk about the So we talk about the alerts that are triggered when vital signs go out of sync. We set thresholds at the outset. So then once the blood pressure or the blood sugar or maybe the pulse drops, any of these things, or it goes higher than the set threshold, an alert comes back to the triage nurse's screen. So the nurses review the alerts and they contact the patient by telephone and they assess what's happening. So it could be very simply, it could just simply be maybe a diabetic blood sugar has risen. They've had maybe a increased sugar in their diet. Or it could be, for example, maybe a COPD. The steps have reduced. Like she looks at the full picture. She's looking at the step count. Steps have reduced. Maybe the pulse has increased. The oxygen saturation has dropped. Maybe their sleep has got a lot of disturbances shown on her screen. Something's happening here with the COPD patient. You know, they're showing maybe early signs of deterioration that the patient themselves at this stage has not identified because they're not coughing, they don't have a temperature, they're not maybe short of breath, but their sats are dropping, their mobility is reducing. For us as clinicians, we can see that that's an early sign of maybe a deterioration. It's so important that we identify this early, get them to the right care. That could be their GP, or it could be their respiratory specialist in the hospital, or it could be the respiratory nurse in the chronic disease hub. They link very closely with them. What's really important, the hub that we're in partnership with, they can actually see the data also. Or the patient can bring the data to their GP on their tablet. So when they arrive in with the GP, they've got the oxygen saturation monitoring, they've got all the data that's required. So I suppose the nurse works on solving the problem. That could be maybe just advising the patient on how to manage that particular symptom, or it could be onward referral, but it's early onward referral. So as I mentioned, we integrate with GP services, the ECC, the ICP-DCD, and various specialists. I suppose the frequency and the pattern of the patient alerts stabilise over a period of time. And this is something that we saw as our service progressed. And I'll give some interim data that we have for patients 6 months after they've been in, and it's astonishing what the turnaround, with advice, with the right direction, with the right care in the right place, what can happen. I suppose what's really important is we're not a standalone service, and we signpost patients to various support services. We have Alone, the Irish Heart Failure Association. There's numerous services that are there to support patients, and our nurses on the phone will educate and signpost as well. The COPD exercise programs, they've been phenomenal what they've been able to support patients with. I suppose, as I said, we're not a standalone service, and we're fully integrated with the ECC programme. Case management by SMILE nurses in tandem with community specialist staff works really well, and it's the patient that benefits hugely from this. And SMILE is built around the patient and their ongoing health needs. And I suppose I just mentioned there about the visibility of the patient monitoring data, to be able to, for a patient to be able to bring their data and show it to their clinician of what's been happening maybe in the last 24 hours or the last 2 weeks. Like GP, the hub, the team in the hospital, they can have a month or more of data to see what's actually happening. You know, for a lot of people, they attend maybe their GP with blood pressure problems. They're sent home with a 24-hour blood pressure monitor, and then they're started their treatment. With this service, they can bring their tablet into their GP or into the clinician that they're visiting, and they can see that data, and treatment can be commenced much quicker. I suppose this again symbolised for the patient, putting the patient at the centre of the service, and all stakeholders having a knowledge of patient details, what's happening for the patient. You've got your patient, your GP and the practice nurse, the acute services and the hospital integrated chronic disease programs there, and also the ECC community specialist staff. So I suppose there have been many collaborations. So SMILE patients are active participants in their chronic disease management and well-being. They now are educated to understand what a increased blood pressure for their condition, an increased weight if they're a heart failure patient, the increased pillows for the COPD. What does that indicate? Every night of an extra pillow, what's happening here? You know, the swelling, the various things, because the nurse just doesn't talk about the vital signs when she rings that patient. She talks, how are you today? And she'll gather quite a lot of information in that conversation. It's a short conversation, but the patient builds that relationship with the nurse, telling them how their day is going, what's changed for them. And throughout that conversation, she's assessing what's happening with their health, what has changed. We've had phenomenal change. We've type 2 diabetes reduced, blood sugars becoming back to normal, increase in mobility. Like we all watch our steps. These patients do too, and their steps might have been 100 to 200, and they're bringing them up to maybe 1,000 a day. It might only be the walk from the bed to the chair, but that increased mobility is a goal for them. And again, So it's coordination of care around patients with all the various services. We have a team-based approach, which is really important. Identify potential issues early with the patient, allow for proactive measures and interventions to take place earlier, and prevent worsening and worsening of their symptoms and complications occurring later. So I suppose I mentioned about the interim data for patients that were just 6 months in the service. And a lot of, 41, what was established from this was a 41% reduction in ED attendance. So that was just 6 months with support, monitoring, information, healthcare guidance. We saw 41% the reduction of the number of times that they attended ED. 44% reduction in the number of nights that they spent in hospital. That was phenomenal for these patients. They did not want to be. Many of them picked up secondary infections. They went in with an exacerbation of their condition, and unfortunately, their stay lengthened. An 87% reduction in unscheduled visits to their GP. So many of these they're still involved in their chronic disease program. They have those visits to the GP, but outside of this time, where they had acute exacerbations and became unwell, these reduced by 87%. 72% of the patients, 6 months in the project, they're alert stable. This was phenomenal for us. This is something we didn't, I suppose, expect to see. And I talked about the alerts in the beginning. So this is where their vital signs went above the threshold that was set. And that stabilized. That meant they were not triggering. They didn't have, their blood sugars were stable, their blood pressure stabilized. And 93% of the patients reported and they felt better. And that's the best, for a patient to be able to report to you they're actually feeling better. So I've spoken about the service, but I think what's really core today is the involvement of the patient. And one of our patients has agreed to tell his story. Paul Wallace is his name. But we also have included a GP who refers patients to the service, a clinical nurse specialist, Liz Murphy, who works in the integrated care team, who also refers heart failure patients. And we've also included one of our nurses that speaks to the patients on the phone. So it's about 2.5 minutes.
About 5 years ago, I had my first hiccup with my health when I was diagnosed with spinal stenosis and some ruptured discs, and I had emergency surgery in the Mater Hospital. They realised that I only had 10% heart function. They got my heart back up to 40% function. And at the heart failure clinic, they suggested that I take part in SMILE. The SMILE program has changed the way I manage my health condition in that it has given me a regime that I need to check the vitals, blood oxygen, heart rate, blood pressure, exercise and weight. That's done every day.
We encourage them to take their readings on a daily basis, and by the power of the internet it come across to the nurses' screens in Carlow, and we're able to observe their vital signs, their step count, their oxygen saturations, their self-reported mood changes, and obviously if any of these are outside of the normal parameters for the patients, which are individually set for each patient, they get an outbound call from us to address what the problem may be.
SMILE empowers patients to manage their own care because they have access to their own information. For example, if they're diabetic, they know what their sugars are. If they've got chronic obstructive airway disease, they know what their oxygen saturations are. With the help of experienced nurses and the hubs, they can prevent hospital admissions and unwarranted, unscheduled visits to the GP surgeries.
Having access to the live data with the patients that I see, many of them are living with heart failure, and adjustment of their medication or increasing of their medication will give them the best clinical outcomes. Normally that would involve them coming to a face-to-face clinical appointment for up to 30 minutes. Now when they're enrolled in SMILE, they're collecting that data themselves, so I can look at the data, make a clinical decision, confirm with them over the phone that it is accurate, send a prescription to their pharmacy, and I would estimate that that's probably reduced their amount of clinic visits that they require by 80%.
The future of my health has been part of SMILE is I know something will be found before I know it's a problem. So it takes away some of that stress.
Thanks very much, everybody.
I'm very conscious that we are eating into coffee time, so we're going to cut the panel short, and I would like to invite very quickly Tinta and Ciara up, and we'll ask one question each. And I'm going to ask Tinta, I'm really sorry, while you're walking, I'm sure you would agree, colleagues, that we're absolutely seeing integrated care living and breathing in Ireland, which is fantastic. So Tinta, can I ask, what were the key ingredients? What was the magic sauce for your project?
Yeah, so I think a lot of what we've heard already today echoes with what we've experienced, whether it's the really experienced clinicians coming together, having that buy-in with the team around them within the health, the hospital, having those personal networks and using that to advocate and bring it all together. And really, the electronic health record has been so essential for us. We couldn't have done it without it, so that's a really, really big one for us. But I think a lot of it comes together with getting the right people who are willing to try, moving it along. And yeah, I won't go on in the interest of time.
Brilliant. Thanks a million. And Ciara, if I can ask you, so in terms of in your role as the National Clinical Advisor and Group Lead, when it comes to sustainability, how do we sustain these fantastic programmes?
Well, I think through days like today, getting the message out there is really important. I think having the right people in the jobs is really good, and you can see that everybody has a patient-centered goal.
Absolutely.
And you know, there are people who are flexible, they're willing to deal with difficulties as they come along, and I think just getting that story out is really inspiring. It can be done. And the other piece just on the integrated care is just to always think big, think bigger, always think, is there something else we could be doing here, or something else we could be doing for the patients?
Yeah.
And I don't think we can add much more to what was said today.
Exactly.
Really,
We've heard it from the people being served, which is absolutely fantastic. So Connie, in the audience, can I ask you to put your hands together for all the presenters? And I'll invite Muriel. Okay. So thank you very much indeed. And please enjoy your coffee.
Great, thank you. No, not at all.
Not at all.
caffeinated, so I hope that you're up for a really good plenary 3. Just before I hand over to Siobhan and Stacey, what I would like to do is just remind you about the survey. And if you're completing the survey and haven't had a chance to fill in the consent form, David is here and has consent form. So we can't analyse your data without having a consent form. So if you haven't signed one, David is the fella with the consent forms. So please sign those, and thank you very much. Siobhan and Stacey, over to you.
Yeah. And thank you, everyone. I hope you've had a lovely cup of tea. I'm Stacey Grealis. I'm a patient partner at the UCD Centre of Arthritis Research, and I sit here in front of you today. While I stand, I'm usually 5'7". I'm wearing a black dress with pink flowers on it, a black jacket, and black brogue, and I'm wearing glasses. And I identify as she or her, and I have many different titles that I'm not going to go into, but I sometimes call myself me, myself, and I as the best title that's going out there at the moment for me, because you name me and put me with different titles for different projects, and I mightn't be aligned with that at times, but I'm always trying to be my authentic self and bring that to the roles I'm involved in. So I'm going to hand you across to my co-moderator here, Siobhan.
Thank you very much. And Stacey was very keen. We were both very keen that we'd address accessibility as well as everything else. So my name is Siobhan Nivrian. I'm the HC's National Clinical Director for Integrated Care, and I have shoulder-length red hair, which is straight, not by natural means, I have to say, but by modern hair care, and glasses, and I'm wearing a teal-coloured blouse. And I'm delighted to be here today. So we have a fantastic panel of speakers today, and we're going to be inviting 2 more people to our panel at the end. So I'm going to hand back to Stacey now, who's going to introduce our speakers.
Thank you so much, Siobhan. I'm delighted to have here just beside me, our first speaker today is going to be Professor Max Watson, and if you'd like to present.
Thank you very much indeed, and thanks for this opportunity to talk a little bit about Project ECHO and its close allied relationship with integrated care. What I'd like to do is give a little bit of background for those of you who are not aware of ECHO, think a little bit about some of the key parallels with integrated care, and then focus mainly on the key constituents of Project ECHO and those relationship with integrated care, and conclude. And I'm going to do it within 10 minutes. That's the deal. Okay. So in terms of ECHO, ECHO stands for Extension of Community Healthcare Outcomes. It's a worldwide movement of online communities of practice geared to democratizing specialist knowledge, sharing and gathering key information, and co-creating new ways of working together in response to our very rapidly changing world. ECHO is a philosophy built on the understanding that adults work and learn best in an all-teach, all-learn safe space. ECHO provides training. Project ECHO provides training in the use of the methodology, evaluation support, an online library of resources.
Before we get into today's topic.
Thank you very much. From each network, more than 600 articles and peer-reviewed journals from across the world. ECHO is involved in rural India to war-ravaged Ukraine. In Ireland and the UK, we've been about for the last 8 years with more than 500 networks in a wide range of clinical and non-clinical areas, from prison healthcare to care home support, from alcohol addiction services with the HSE to serious adverse incidents, from social prescribing to long COVID patient support. The ECHO vision is not small. It's to impact on the lives of 1 billion people by the end of this year. And even following on Mr. Musk's cutbacks, we're on track. ECHO parallels with integrated care. The key constituents that make for innovative and powerful echo networks are, I suspect, similar to those required for successful integrated care, constituents that we have seen evidence of today in each of the presentations in this celebration of integrated care. With vision, creative leadership, willingness to share power, ECHOs have thrived and built amazing communities of practice. But where leadership is lacking, or there's a hierarchical and formulaic approach to learning, and when operational bandwidth precludes any time or value for strategic thinking, the ECHO methodology can be seen to be just another online educational resource, like myriads of others which have sprung up since COVID. But for integrated care and for ECHO, those who have maybe a very hierarchical model of education and service delivery, they can find us a bit subversive. Are you subversive too? Okay. What are the key constituents and examples that we've learnt during our 7 to 8 years here in Ireland and the UK? Number one, clear and recognized need for belief in integrated working. In the words of Frankl, those who have the why and are committed to the why, we can handle the how if we've got a clear vision. It was through the use of ECHO in our rural ECHO area of Omagh and Fermanagh that the Pathfinder Project ECHO gathered information from the population as to their ideas of how to deliver frailty and care of the elderly service in the context of a health service under multiple pressures with no more money. That is why we now have a consultant training scheme for integrated care consultants, with palliative care and care of the elderly combined. The local population could better identify the sort of healthcare consultants who could sustainably support the care of their rapidly changing demographics. And also out of that ECHO came the beauties of Fermanagh, yeah, but you can fit our population, which is a fifth the size of Northern Ireland, into the Aviva and Croke Park and still have 17,000 free seats. So there's particular challenges in our rural area. And so from that interrogation, co-creation with our community, we've developed preliminarily a project called Co-Creating Hope, based on the desire to link with the huge community assets that exist across our community, with that population of 60 to 80-year-olds that we haven't had before, who've got so much to give and contribute, and the GAA, and the football, and the faith groups, and the hairdressers. I don't use them much, but the hairdressers and the postal services. How do we link these up together? Number two, good leadership with commitment to sharing knowledge and power. Everyone's ECHOs, everyone a teacher, everyone a learner philosophy has been invaluable through COVID, supporting a wide range of services with the sharing and gathering of information. Yeah. Number three, in the midst of operational demands, having some degree of protected time to think, just to think strategically without the pressures of operational delivery is absolutely crucial. This Mind the Gap ECHO is 1 hour a month, linking a rural district general hospital with the primary care teams in the area. 1 hour a month, invaluable to build those relationships and those links and look at the interaction between the services. Number four, commissioner engagement, with the network seeing the value of understanding. So if you're a commissioner and you can see it's valuable to actually connect with those who are delivering and with patient support, ECHO will provide you with invaluable information. Such engagement has allowed for the co-creation of, for example, a cardiology service for GPs to have their patients' heart failure triaged within a couple of weeks instead of an 18-month waiting list. But without that engagement with commissioners, co-creation has been difficult. And then lastly, train facilitation so that the loud voices don't dominate, the big elbows don't take control, and the softer voices are amplified to allow for different views to be heard respectfully. We heard this morning about the importance of thinking about integration, not just as structure, but also as relationship building. And I think there's a third as well, and that is the philosophy of commitment to working together. Our serious adverse incident ECHO networks very much relate to the need of interprofessional working. Some of our incidents we've looked at have involved the police and healthcare workers and social workers and patient representatives, really sensitive stuff. But in that safe environment, invaluable to learn and grow together. So, in conclusion, with autocratic power, algorithms, and many commercial interests retreating so rapidly and so publicly from previous commitments to inclusive working and integrative working, creating spaces where people from different backgrounds, learning and experience can hear and share differing opinions and knowledge in a safe environment is increasingly important. ECHO provides that space online, and that commitment to a fully integrated working and learning together environment, I think, and I may be biased, I think it's never been more needed at this time of fragmentation. Thank you.
Thank you so much, Max. Our next speaker is Margaret Curran. Margaret is the Corporate General Manager from CareDoc. Thank you, Margaret.
Good afternoon. Good afternoon, everybody, and thanks, Fiona, for the invite here to talk to you a little bit about CareDoc and about our experience with integrated care and interdisciplinary team working. 10 minutes is a very short time, and I tried to put this presentation together, and it's much harder when you have only 10 minutes to put a presentation together than if you have a half an hour to talk on a topic. But I did my best, and I certainly will try and keep to the time. CareDoc, for anybody here in the audience that doesn't know about us, we were founded in 1999, so we're 26 years now gathering experience. We were the first GP cooperative in Ireland, and we're a partnership between the GP, HSE and Department of Health, and also Sláintecare and Pobble, especially in our most recent ventures. We have very strong and had very strong clinical and corporate governance from day one. And as I say, 26 years of experience and using, I suppose, now that leadership and skill set that we built up over those years amongst our staff and our doctors to look and implement new services across the regions that we serve. So this is just a little diagram to give you some idea of what we do. We provide GP out of hours services for over 1 million of the population. We have a national and regional telehealth triage service. We have community intervention team services across a population of 700,000. And Mary spoke, my colleague spoke in the last session about SMILE. And I'll talk a little bit about that, and that means supporting patients with chronic disease to look after themselves at home, and that covers a population of 550,000. And the CareDoc model of integrated care was recognised by the WHO and included in their compendium of initiatives in 2016, which we were very proud of. That's just to give you an idea of the counties where we have a footprint. So I suppose sometimes you're asked, what are the keys to successful integration? And I heard a lot of, the phrases earlier on today that I'm going to talk about now being used. And it starts off with strong governance and strong leadership. And that's critical. It's like building a house. If you don't have a strong foundation, your house is going to come apart. So looking back, I think that was one of the very critical initial steps that was taken to put CareDoc on a sound footing. To work in CareDoc, you have to be passionate about providing high quality care. Because, at the end of the day, it's a job for us, but it's the satisfaction of knowing that we're delivering for the population and for the patients that we serve. That's what keeps us all driven and going. We employ skilled and knowledgeable staff, and we share common goals within the organisation, but also externally with our stakeholders. Communications is really important, and over the years, as I get older, I think listening is more important at meetings than talking. And I know the years gone by and I would have been at meetings and I would have been concentrating on what I'm going to say next. And now I try and stop myself and listen actively to what is being said at a meeting. And I think that's a skill we all have to work on, because we all think we're great listeners, but are we really? Building trust is massive. If you're not trusted amongst your colleagues and your patients, and if you're not trusted, patients are not going to have faith in the care that they're receiving from the organisation. So that is something that's very high up there. We very much have a team-based approach, and we respect and understand each member of the team. And everybody has a contribution to make on a team, whether it be a small or a large contribution, but you have to really acknowledge everybody's contribution and navigate problems and challenges. And we've had many of those along the way. It hasn't been all plain sailing in CareDoc. We've had days, when our heads have dropped, and you kind of think, how are we going to pull ourselves back up again? And that's where you kind of rely on your colleagues to say, let's, see, can we do it another way, or can we get around it a different way? So like getting back up when you get the knocks is also really important. And that's just a slide that shows you all of the agencies and services that CareDoc interacts with on a daily basis, if not on a nightly and weekly basis. So like all aspects of the healthcare system interact with CareDoc in one or more services on a regular basis. I have two examples now, because I suppose my theme is integrated, our interdisciplinary team working. So I have two short examples of two services that we run. And the first one is the Community Intervention Service. And this is a team of experienced nurses, physios and OTs that are supported by the CareDoc GPs, the out-of-hours service, administration, management, ICT. And the service is built around the patient, and it runs every day of the year. And it's 24/7. It runs from morning to night, and then the out-of-hours, if there's any problem with any patient in that service, they contact the out-of-hours, and it's managed throughout the night. It's integrated with the acutes, primary, community care, palliative care, public health, elderly and social care services. So our staff interact with all of these services in order to deliver acute care in patients' home and in the community. So our aim is to facilitate early hospital discharge and hospital avoidance and make more efficient use of resources. We deliver acute care in or closer to the patient's home. I know when we were setting up this service initially, we were worried that when the doctor or the nurse in the hospital would approach the patient and say, would you like to go home? We have a service that are going to look after you. You know, there was this fear that patients wouldn't like to leave their hospital bed. Now they're literally jumping out of the beds, delighted to be getting home, and can't believe that just shortly after they arrive home, the nurse is pulling up outside to come in and to give them the support they need and continue their treatment at home. So it was designed around the patient and also around the family, because the anxiety for the family members is often, really, I suppose, sometimes higher than the actual patient themselves, because the patient themselves are sick and they don't really have sometimes that level of fear that the family that are trying to look after the patient are suffering from. So the health professionals coming in have as much work to do with the family, reassuring them and educating them and showing them how better to manage and how to ease their anxieties. So that's really important. Also, the co-designing of patient pathways with our colleagues in the hospital and in the community. We sat around, we have joint governance groups with all of the hospitals in our area, and we sat around with all of the different professionals in the hospital over the years, and we designed pathways that were going to enable patients to be discharged from hospital early. And these would be sometimes never heard of before, but we identify what could facilitate a discharge early and work around how we can put that in place. For example, oncology services, that's a really huge one, that our patients now don't have to go back to hospital to have pre-chemo bloods or to have their chemotherapy disconnected in the hospital. We're now doing that in their local community for the patients, and that avoids journeys into hospital and the stress of all of that, getting parking, and it allows for the hospital to start more patients on chemotherapy. We also have heart failure pathways. We have a myriad of pathways that we've developed over the years, and that was all done by identifying goals and sharing knowledge and making it a win-win for everybody. So establishing, as I said, an interprofessional joint working governance teams and, I suppose becoming recognisable in the hospitals and in the community. And relationship building is so important. And I've met people here today that I worked with in the HSC or in other agencies back 10 years ago. And it was lovely to meet them today. And, they're so friendly, and it's just a testament to, I suppose, how well we worked together in the past. And I always say, our paths will cross again in the future. And even when they cross on a day like today, it's really special. So ensuring consistency and delivery of care is really important for clinicians to trust in us and for patients to trust in us. And we, like it was spoken about earlier, we identified that shared education and learning opportunities was very important. We collaborated with the C2 University in Waterford. Our nurses did the preceptorship training course there, and we have the academic undergraduate nursing students that come out and do secondments with our CIT team in the community, and the feedback to that is just fantastic. Now, Mary, my colleague, spoke about SMILE, and for those of you who were here for Mary's presentation, you will know all about it, but for those who were at some of the other sessions, I'm just going to talk a little bit about our service that looks after our chronic disease patients. And these are high users of the acutes. They're quite unwell patients that have 2 or more chronic diseases. And it was a joint initiative between the Enhanced Community Care Programme and CareDoc, along with Sláintecare and Pobble and the Department of Health. And it's integrated virtual case management of patients with 2 or more chronic diseases. And we get referrals from the ECC hubs, the integrated chronic disease teams, GPs, consultants, and we collaborate to improve patient outcomes. And the service, we heard a lot today about building the service around the patient. This genuinely is built around the patient. And again, we in the beginning thought, oh gosh, will the technology put patients off, coming into this service? But I think after COVID, nobody has a fear of technology anymore. And elderly patients, a lot of our patients would be 80 plus, and they have no problem with iPads and with apps. And their grandchildren certainly love the iPads as well, because I think they download the odd old game or two on the sly when granny or granddad are not looking. But we have all ages in our service. And gaining the trust again of patients and of carers and the health professionals, and facilitating the training on the digital devices for the patients. And then having the nurse as the educator and the person who is going to make regular contact with the patient in a very holistic way, remotely over the phone, building up a therapeutic relationship with the patient. And Mary had these up earlier, I'm not going to call them out, but we've had fantastic results. The results far exceeded our expectations. And that's after 6 months of being enrolled in SMILE. And I said, these are high-end users of health services. So just to round up, what were the keys to successful integration for people-centred health services? So I would say a clear vision of what you want to achieve. Believe in your ability to make a difference. You need to be robust, strong, and have a passionate team around you. Listen to patients' experiences and feedback. Be determined and persistent. Get up when you get knocked down. Be confident in the workforce to deliver and gain the trust of stakeholders. And agility also is something that comes to mind. And we've had lots of times over the last 26 years where we've had to change and adapt. More recently, during the pandemic, during the Red Crisis, weather warnings, no matter what, I don't think there's anything out there that can stop us achieving what we want to achieve. And I think that's it from me. Thank you.
Thank you so much, Margaret. Our next speaker is Lisa McLean. She's the CEO of Footprints Women's Centre. Thank you, Lisa. Fantastic.
Hi everyone, thank you very much for having me here today. It's an absolute privilege, and I hope everyone is okay, because I realise this is a difficult time in the afternoon. You may be thinking about what you're making for dinner or how you're getting through rush hour traffic to get home. So I definitely won't take too long. Most of my presentation is photos, because I thought at this time of day maybe that would be helpful and nice to have diagrams and photos. So Footprints Women's Centre was established in 1991. And over the past 30 plus years has sought to build capacity by offering wraparound services which seek to nurture and build upon the confidence and resilience of women and girls, so that they feel supported and empowered and taking their place as leaders in their family, within their communities and within employment settings. Footprints is based in West Belfast in the Cullen area. The area has a population of around 30,000 people, and it's made up of 4 major housing areas: Twinbrook, Poleglass, Lagmore and Kilwee. The facility has been acknowledged as a valuable asset within the community, often referred to as an anchor organisation. We've developed a diverse range of services in the neighbourhood, operating within a community development context. We are a registered charity and operate as a social enterprise. So a registered charity and also a company limited by guarantee. So we've got Footprints trading as well. But all of our services are directly to benefit the women and children within the area. And the area is one of multiple deprivation. So you can see in the photo here, I think it's just important to show so that you get a real flavour of what Footprints is like. And I'll talk a little about some of the services that you can see in some of the photos, but this is many of our wonderful women and children. And there's one that I'm very proud of as well, there of myself and our chair when we got to provide evidence last year at Stormont around the Ending Violence Against Women and Girls strategy. That was a really critical and important meeting for us as well, and one that we've been able to move forward lots of work on over the last year. So as I said, we provide a lot of services. We employ 28 members of staff, mostly from the local community. We've got a committed and engaged volunteer board of directors and a dedicated team of volunteers as well. Footprints has established a very strong track record over the past 30 odd years. We enjoy excellent relationships with many different organisations, including a whole network of women's centres that covers most of the north of Ireland. We seek to provide services that meet women's needs to be able to serve their families as well and potentially transform lives. And one of our very key projects is our social supermarket. This is Footprints, so you can get a flavour of what we're like, and we really are right in the middle of the housing estate. It's right in the heart of the community. So we opened the first social supermarket in Northern Ireland, and the model has been used by a range of different organisations across the region. So the supermarket offers heavily discounted retail environment for everyday essentials, and a different shopping experience, obviously, compared to maybe what a food bank would offer. So it's really around giving women agency and dignity and being able to meet their families' needs. And this is something that we hope to be able to roll out much further across a number of organisations over the coming years. We offer a fully inclusive childcare service as well. We offer 64 spaces within our centre and have a contracted service with our regional trust to provide services and support to the families that we work with. We also have a sustainable living stream, and that's something that we are very proud of as well. It's something that we were working on before many others. I feel we were offering different services around climate change and that, trying to really ensure that women understood that agenda so that they could transform spaces within the community, maybe anti-social hotspots and transforming green spaces so that there was more for play and recreation for children and just more in the area for people to do. Food is a huge part of that as well. We seek to improve access to healthy and affordable food through our social supermarket, but also through offering training within our community kitchen, whereby we bring women together to be able to work with our in-house nutritionist and our in-house educational chef to be able to deliver how to source and cook low-cost nutritious meals for their families. Another element of what we do is our training and education. We've got a very diverse range of accredited and non-accredited training programs on site, and that's all supported with childcare places as well. We have a young girls and children support and development program as well. So we really are engaging from zero right up to 18, and then women can access all of the services that are opened through the Women's Centre as well. I should say as well that in 2024 we opened a new social enterprise because we're always trying to diversify our income streams to allow us to be able to deliver in the gaps where funding can't support us to do so. So we bought a food truck, you know, the little horse box type ones. It's a nice little posh one of those. And we are going to hopefully take that to some corporate events this year to allow us to have an income stream to do some of the things that we're really, really keen to do that we haven't got funding for. Some more of our work is around crisis intervention support and advocacy. We have advice and support pathways to women experience domestic and sexual violence, financial management, debt advice, maternal advocacy, peer support to mums and their babies through activities such as baby massage, parenting support, walking groups, day trips and so on as well. And we've got a health and wellbeing community peer support as well, where we have a range of services within our safe space, all to facilitate and enhance the well-being of women in the area and reduce the effects of perhaps social isolation. And we offer very many complementary therapies as well, walking groups, mindfulness, emotional balance, and so on. And here you'll see our Syrian women's peer group as well. We have sewing groups, repair cafes as well. So the range is huge, and it is hard to squeeze it all into 10 minutes. So this really is a canter through. So as I said, Footprints is based in the heart of the community, a safe space, and our approach, as everyone else has spoken about today, is person-centred. We continue to build relationships with other organisations to improve the journeys and outcomes for the women and girls that we serve. So how do we go about driving the change that we need to see? First of all, I feel that we start by ensuring we have a culture and an environment that allows our team to thrive. We can't ask our team to pour from an empty cup, so we have to have an environment where they're able to thrive. We have a committed, flexible, values-based approach to how we work, and our team very much seeks to embody our values with every single interaction from someone engaging with us. We've got a new strategic plan that we've just put in place. As an organisation, we do have an adaptive culture, but we seek to foster innovation, encourage new ideas, and as someone else has already said before me, we value the contribution of every single person, and that includes those who we collaborate with as well. We are often considered small, and we are, and that often provides us with various opportunities, and we can be agile and take advantage as those opportunities present themselves in an effort to drive change. But just like any other organisation, we have to consider and manage our risks. We have to maintain excellent governance, manage our resources, and achieve best value too. I do hear it pretty frequently, particularly from larger organisations, but you're so small that you can transform and change really easily. And that is so true, but surely it's much more than just being able to do so. It's all relative in my experience, and transformational change is much more about mindset than it is about processes. We have a purpose-driven culture of change to ensure positive impact, and we can't have anything less than that, or we would simply become irrelevant, and the community that we serve would be very quick to let us know that as well. After months of consultation, we developed a new strategic plan. You can see our priorities here, and I'm not going to read them all out to you. You can see them for yourself. But our process was considering our strengths and how we believe we can operate to access people and the places and work with others, because we have that trust built up with the community where we can access people where maybe some of the other organisations can't. So we want to be able to work in collaboration to do so and ensure that services are brought to the community. And the plan really helps us to ensure that there's a solid plan in place that means that there's no drift from that, and also helps us to not just chase funding, because I think it's so important that we remain true to our own agenda rather than and the evidence-based needs of the community that we serve, rather than chasing funding and it becoming someone else's agenda. So again, just to give you a little bit of an overview, and I'm not going to read it again, but these are some of the actions that we seek to take underneath each one of those priorities. And we've aligned, rightly or wrongly, I don't know, but we have decided that we are going to align our strategic plan to the UN Sustainable Development Goals. We believe this creates real value for us, but also for our stakeholders, because we believe we are contributing to a global agenda, but this alignment enables us to identify and address risks and opportunities, and also ensures that it's a language that others can understand and can see where our work is creating impact. And when I speak of language as well, I think it's so important, and someone else has mentioned what's important whenever you're dealing with, when it comes to partnership working and co-production, collaboration, and I think language is just so important, and we're so quick to add acronyms to things and jargon and so on, and I think that is just of critical importance that we don't do that. We certainly try not to do it with those that we engage with, and we would always ask that people don't do that with us either. So something that we've, over the course of the beginning of this strategic plan, we've brought into place and revised our education and training programme. And under the new strategic plan, we're calling it our Radical Living programme, because we operate with radical compassion. So therefore, we feel that everything that we are doing is radical. And we really, really want to enforce within our staff team and our volunteer board that it's okay to be radical, that it's a safe place, that we understand the innovation and creativity within our staff team to look at services and revise services and change what we're doing in order to get the outcomes and the outputs that we need, that you can be radical and have no fear of the repercussions of that. Of course, that's within boundaries and parameters, but equally it's about ripping it up if it doesn't work and start again, and it's okay to do that. We work with various partners in the delivery of our programmes as well. We sit on the Community Safety Forum for the area, the Community Health Forum, which is alongside GPs, some healthcare professionals as well. We sit on the Neighbourhood Partnership, Women's Aid. We have various wellbeing services forums that we sit on, Family Hub, Sure Start. We work closely with the health visitors, and we have corporate partnerships with organisations as well, one being PricewaterhouseCoopers. I think one nice example of our work along with our GPs was through our health forum, was where we were advised that there was a low uptake with childhood immunisation. And we worked along with the GPs to be able to provide information to the women coming into our centres, and saw the immediate impact of that. I mean, I can't say that it radically changed things, but it just shows that just having that open communication and the very real examples of how things can be changed with that engagement. We also try to work with anyone else that comes into the area. We try and see where we can work with them to be able to offer their services to the community. So one that we're hoping over coming months is to work with the breast screening bus to bring that into the community as well, because quite often the area is 6 miles out of Belfast, so a lot of people just won't really go into town too often. They will stick around the immediate area because there are services in the area, so we just want to make sure that we're not missing anyone through that. Here you can see our vision statement, mission statement, and our values, and you can read those quickly for yourselves or look on our website if you really feel that you would want to do that. But really, I just wanted to speak about our values. Our values are not just a series of words. We have a series of behaviours around these, and we talk about these on an ongoing basis. You know, what does it mean to welcome with joy? And that is a really important part of our day because of where we are based and the various issues, the complex issues that we're dealing with at the coalface. It's really important that we understand what joy looks like and be able to leave a lot of our own burdens behind, like I'm sure many of you do in front-facing organisations. But everything we do is ethical, person-centred and built on mutual respect, and our values are a very important part of that. So our approach to moving forward and growing and creating impact is around trust. It's been spoken about a lot today. We want to build relationships and engagements. We have to build that trust in order to do that. It's essential for healthy reciprocal relationships, creating safe environments and engaging in transparent interactions, successfully negotiating those power differentials that's been mentioned today as well, and supporting equity, putting trauma-informed, evidence-based approaches into practice. We also authentically embody those core values, again, focusing on trustworthiness, shared decision-making as well, that access the barriers to trust. We very much have an eye on the global agenda, a hand in the national agenda, and our heart lies firmly with the local agenda, and that's very much about maintaining that trust at every level. Trust that's been placed in us for over 30 years, a trusted anchor organisation that brings solutions to the heart of the community. We travel with our service users, and that, in my view, is what makes the difference to the individuals and the communities that we serve.
Thank you so much, Lisa. Last but no means least, we have Joe Ryan, the National Director of Public Involvement, Culture and Risk Management at the Health Service Executive. Thank you, Joe.
Thank you, and thank you, Anya, for asking me to come along today. It's a pleasure. It's good that I only have 10 minutes because you've been talking about culture and patient participation all day long. So that should make my job easy, I hope. And I do want to thank IFIC for actually making that one of the really core elements of getting the message around integrated care across, that patient participation and culture are so important to underpinning it. This is the desired culture of the HSE. It's our culture statement that we have in our documents now. It's a bit different now to what it was because we've identified some gaps perhaps that were there before. And those gaps were primarily around our patient and service user. It was very staff-centric, and there's nothing wrong with having a staff-centric culture. But we are in the business of serving. We've heard that word right from this morning when Bernard stood up. We are servants to the people that we care for. So it was important to have them front and centre in that. But also a culture of responsibility and accountability. For accountability for ourselves, how I turn up every day and how I do my job, and how I work with the patients and service users I interact with and with my colleagues. So we put a bit of focus around that. I'm not going to read it. It is in all of our documents, and I'm happy to share it with anybody who wants to see it.
but we felt it was important that it needed to be more embracing around the various different aspects of culture. Our values in the health service of care, compassion, trust and learning have been around now for probably well over 10 years, and we had a look at that too and said, do we need to change that? And we said, no. It has actually stood the test of time. We do care and compassion really well. I think perhaps we need to work a little bit around trust and learning as an organisation. So I'm going to talk a little bit about that. And so I suppose it starts with being partners in our own health. So anytime I have partner discussions with our patient and service users, we invariably get into a conversation about, I'm partnering in my own health. It's not the design of the health service or patient pathways. It's actually keeping myself healthy. And I think there's a lot of parallels between that and between the broader idea of partnership in designing and running our health services. So we've been partners in our health for many years. We show up to a clinician when we're not well. The clinician examine us and do some tests, and they formulate a plan and they tell us, here's what you need to do. And then we either follow that and take all of our tablets when we're supposed to take them, or do all of our exercise when we're supposed to do it, or we don't. And to some extent, you co-produce the outcome there. Okay? So we've had years and years and years of that experience. I suppose the evidence does suggest that if we do that engagement, that partnership better, we get better health outcomes. Okay? And I suppose one big parallel, and it's probably the thing I'm going to focus on in this 10 minutes that I have, which is that idea that for any of those partnerships to succeed, there has to be a good balance of psychologically safe space for both people in that relationship and an accountability for that relationship. So partnering in our health services and design, it's interesting, and listening to Lisa, that radical approach. Wouldn't it be wonderful if we could just all be radical and have the freedom to be radical? It was great to hear Andy saying, I'm giving people permission to focus on integration. So some of that is going to come from leadership, some of that is going to come from ourselves, and some of that is going to come from a kind of a whole system change. Okay? When I look at some of the constraints that we have around changing how we do things, we talk about regulation, and but actually when we look at regulation, part of my job is compliance. Okay? And we've looked recently at the number of compliance obligations we have in the HSE. There's 1,250 compliance obligations that have been identified. Okay, 80% of those are self-imposed. Not from HICWA, not from government, not from Mental Health Commission, not from the unfortunately acronymed FEC. It's ourselves. We come up with this, okay? And we can change that. It doesn't mean that we go laissez-faire. It just means that we can identify what we really need by way of boundaries and to allow space for the right thing to be done. Patients and service users must be involved, not just consulted. I took responsibility for the whole, for the HSE's side of the relationship with patients and service users a couple of years ago. And probably the most prevalent thing I heard at the time was, it's tick box, okay? And we have to change that. I think we are changing it. Anne made reference, which was very kind earlier on, in making reference to that earlier on, but we are making progress, but there's a long way to go. And I guess part of building that relationship, Donnie, you mentioned this listen, hear, and I guess respond or act. The answer isn't always yes or I agree, but there has to be an answer. And when there's no answer, that's when trust breaks down. It's you're not really listening to me. And I guess then the patient service users and our social care professionals, we need to support people. We need to support everybody to operate in a psychologically safe environment. We've heard that today a number of times. That's balanced with being accountable for the outcome. So back to that balance of that psychological safety and accountability. And you're nothing if you don't have a two-plane chart to talk about. But And I took out the colours deliberately because I got sage advice from one of my colleagues around accessibility. So, so look, if all you have is low psychological safety, you're disengaged. People will just be disengaged. They won't want to know. Okay? It's not a safe place to make change, so I'm not going to. If you have high levels of psychological safety, it's a nice, safe place. And it's lovely, and it's nice to work there. But are you really making change? If you have low accountability, you can have, with a low high accountability with a low psychological safety, that's a very, very perilous place to be. And probably when I meet people who are maybe having a tough time at work, that's what they say their culture is. And that, whether it is or whether it isn't, or whether it's just what they're experiencing right now, we can't ignore that. But that's probably the toughest thing we need to fix. We have a lot of jobs where we are highly accountable, but we're not operating in a psychologically safe space. And we have to change that. Because when you change that, what you get to is a high-performing place, a place that learns. And when you learn and you demonstrate you learn, you build trust. And then we close that loop of having care, compassion, trust, and learning. This year it's a work in progress. Anybody who had familiarity with values in action over the last number of years, the cultural program within the HSE, would recognize the top left, the 9 boxes in the top left. They're the 9 behaviors we would have had before. When we looked at, and I said to you, when we looked at our culture and we saw the gap in terms of the patient and service user, we also saw that gap in accountability and responsibility. And we saw a gap in our behaviors that was not really being too helpful to leaders and managers in knowing what their behaviors should be in order for the right culture to prevail in our services. I won't go through them all. It is a document I'm going to socialize quite a bit. But if everybody brings this type of, and whether it's, by the way, staff and leadership within the health service, or indeed our patients and service users, we've heard today many times that they should be and will be part of the team. Okay? So we all have to bring these behaviors and these accountabilities and making psychologically safe spaces to work together. When we don't do that, when either one of those sides lets us down on that, that's when the whole thing starts to fall apart. So we can build and make the change around integrated care in a place of trust and a place that's psychologically safe, that encourages high performance and change. And thank you.
Thank you so much, Joe. I'd like to welcome to the stage our panel discussion members. We have Martina Quilly, the Regional Health Officer for HSE Dublin and South East. And I'm forever going to be thinking of Oreos because of what Joan said earlier today. I'll be thinking of milk and cookies for life after Joan. And Damien Mulch, the CEO of Independent Living Movement Ireland. Thank you so much for being with us today. And Siobhan, would you like to lead out on the questions?
So folks, I'm very conscious of time and that people need to get away. So Stacey and I are going to ask our 2 new panellists a question each, but I'm going to ask you both the same question, and I'd like you to answer maybe from a different context. One of the themes that's come through today very strongly for me in every talk that we've listened to is the importance of building relationships. And Martina, I'm going to go to yourself first, and just your thoughts on that. In your experiences in this massive transformation that the health service is undergoing, and as a regional executive officer, how and why do you see building relationships as being important?
Well, I think it's kind of mission critical, really, to be perfectly honest. And I guess the last number of presentations, but it's been a thread throughout the day, is that core value that binds us all together. And when we were talking, your trust came out very strongly in the presentations that we've just heard. But that's been a thread right throughout the day today. That reliance on trust, whether it's the interdisciplinary team that rely and trust on each other, whether it's the
the culture you build around disadvantaged communities. We had a member of the traveller community, our recent presentation in terms of footprints. All of these relationships are built and rely on trust. So it is absolutely fundamental that those relationships are honest, that we deal with each other with integrity and respect. And most implicit in all of it is the relationship between service users and providers. So whether it's that contractual organisation that Margaret talked about, where you have a lot of stakeholders, whether it's the relationship with our service users, whether it's really trying to engage with a subset of the population that we know suffer extreme disadvantage, then all of the time we have to operate from a basis of trust and respect.
So, Martina, I think that's a great answer, the importance of relationships in building trust. Absolutely. Damien, from your perspective, how would you see the importance of building relationships? And maybe even an example, as the CEO of Independent Living Ireland.
Sure. Just as an introduction, ILMI is a national cross-impairment disabled persons organisation. So our vision is in Ireland where disabled people have choice and control to participate in an inclusive society as equals. So the relationship piece, I think, has two elements for us as a disabled persons organisation. One is the relationship between disabled people as peers. I know Jennifer from the NRH spoke about that. The connection around lived experience is absolutely vital. How people navigate systems, how they support each other individually and collectively. But also, when we take an understanding of disability in Irish context, most of us live and breathe without consciously or unconsciously a medicalised view of disability, as in the impairment is the issue that needs to be treated. As a disabled persons organisation, we take a social model view, and it's the systems and structures that disable people. So by creating that relationship space, much like the work that you do, Lisa, is connecting people and going, there are things that are not to do with us. There are systems and structures that do disempower us. Not like what Mary Bridget spoke about in terms of the traveller community as well. So really importantly, because of the impairment basis of it, to connect people collectively, that relationship piece, to actually get a sense of, I'm not the only one. Okay, I've got an understanding. I've got a community who understand, regardless of impairment, what it feels like to be othered, to be treated less than, to be denied my rights. Then the external piece is really critical for us, is then to bring that collective lived experience, not the individual one, that we create that space to tease out what are the issues people are facing and make decisions about what systems change would look like. Now, if I can get a quick analogy, we had almost 300 people here at the start. If we had used Slido to say, what's your favourite food? And everyone put in there, and in the human condition, we'd have about 250 different things. We then go to the caterers in O'Reilly Hall and go, right, provide lunch. Chaos ensues. It's not going to happen. We get a very angry cohort of staff going, we don't have the resources, the ingredients, the time, none of this is going to happen. And we arrive out to lunch and go, are our needs not met? Were we not consulted? Where's my chicken tikka? Where's my tiramisu? So on a very basic level, that level of consultation does not work for anyone. It does not work for people trying to access a service. It certainly doesn't work for the workforce who are now in a conflictual state going, don't ask them what they want. They don't understand the pressure we're under. But we heard a lot in this space about co-creation. And the difference in that is we as the 300 people have a sense of what's the staffing level out there, how much time do they have, what access do they have to the kitchens, what ingredients are there. And better yet still, we have a chance to collectively debate. Some of us have dietary requirements, some of our allergies, there's religious differences here. What does a menu look like at the moment that meets our needs the best? We're not all going to get what we want, but we're doing that thing that Bernard Gloucester talked about at the start, an iterative approach. We're changing things gradually. So I think when people spoke about co-creation, that's what we want to be at, is that we bring our collective lived experience to the table. And a really good one, I want to give that, we're doing work at a local level, funded by HSE and Genio. And we're supporting a local disabled persons organisation, lots of different parts, but in Sligo. So disabled people are given time, and some of that was catharsis, the kind of people let down by the system. We're going, what does change look like for us? And people talked about an individual experience, but moved into the systems piece. And there was only 2 people with vision impairments there, but they spoke about all their information came in printed, letters, appointments, and said, we've no independence now. So we have to ask friends or family to read this. So the group said, we're going to bring that to a forum with the HSE and say, okay, we want to see this to change. Now, individuals had tried to do that within a system with 144,000 staff who didn't necessarily have the power, but within that bilateral collective space, There's what the relationship piece was. There's now a collective that needs to be responded to, and it could be saying, okay, we will now send out an email that will go about appointment, about results. So there's the relationship piece. You go from the individual of, I need this, to we are asking for the system to meet our needs, and we can do it on that iterative basis.
Okay, I think that's a fantastic answer, Damien. I love the food analogy. It makes it really real of how complex these things can be, and the fact that it takes time to take those small steps to get to the goal we want to achieve. Stacey's going to ask the next couple of questions.
I suppose I've heard a lot here today about the importance of leadership and strong governance structures and the decentralization of power from hierarchical structures. Both of you are very different structures. And I suppose I'm sitting here thinking about the structure that you're in, Martina, and the structure that Damien's in. And I'm very privileged to know Damien, open disclosure. And Damien, you are the only person in your organisation that's not living with a disability. And I'd love to hear both of you how you would like to move forward within governance and leadership to ensure greater partnership and collaboration.
Do I go first?
Whichever.
Okay. Well, I do think, all our members are disabled, all the board are disabled. I'm one of the non-disabled staff members, and that's really important. But what we're doing is we're attracting people on the basis of values, going back to what Lisa spoke about. That really resonated with me. And even around the ECHO project, there's collective experience and knowledge that can be there. I was in one of the spaces around the reciprocity of bring co-creation. It's not just tokenistic, what do you want? You're bringing in real understanding of how systems can change, but also it's given us an opportunity collectively to learn about how those systems work. So we can go back to our communities again and say, okay, we need to be a bit more nuanced here about what that change would look like. But I think the values base that Lisa spoke about, there are a lot of consistencies around much larger entities around the culture that Joe spoke about there, about having that approach about the individual. And I think there's a piece that Professor Cullen spoke about, the democratization of digital care will put a lot of more power into people accessing the services. That's great. But it's a big ask for everyone to have that confidence to do that. So I think that for us and around the governance piece is creating those systems and structures to create more empowerment, much like Mary Bridget spoke about for the traveller community, are 20, 30 years ahead of that, self-organising, resourced, to be the point of contact around when we're discussing issues around traveller health, there's a go-to point to, who can do the work to engage with the community and can come back with very strong strategic asks. And I think that's enormously, what we need to think about is precise that, like the ECHO project, where does the power reside? There's lots and lots of power in there. Lisa spoke about that, where you can create those conditions for people to have their voices heard on a strong value base. That's what DPOs are about. One of the really strong things, though, and I'll finish here, is we ratified the UN Convention on the Rights of Persons with Disability in 2018, and there are specific measures relating to the work of disabled persons organisations that are ran, led and controlled by disabled people. So we're at a point now with the Department of Equality, Children, Disability, Integration, Youth, and many of the departments that recognise that role. And I think that's quite exciting, because we're going to shift from what Jackie mentioned earlier on, I thought was really instructive, a historical system whereby disabled people were spoken about by non-disabled people. They weren't asked about what they wanted and they didn't have the power. We're seeing that emergence now of that collective power, Stacey, that I think is quite exciting. And then it should be seen as quite exciting from the people who are providing healthcare and also from workforces. Going back to Niamh's point at the start, content and animated workforces comes from the fact that they're not in attrition with people accessing their services. It's better for everybody if we have that sense of co-creation. Joe, you spoke of that as well. We're actually recognizing that this is a more efficient use of resources because the people that are accessing them tend to have the best view of what would work better. But rather than asking us all individually and having to go back to the chefs with those 300 asks, give us time and space to strategize about what we can see as that iterative, this is what inclusion is going to look like, and it's going to take 2 years to get to that point, and another year to get to that point. But we're part of that process because we're sitting at the table. We're also going back to our communities as well within that.
Martina.
So I think, I agree with everything that has been said. I feel strongly from where I'm sitting, I suppose as an REO, just 1 year in the job, that it's an inflection point for the Irish health system in many ways, both from a cultural perspective in relation to how we see health services being provided, but also in terms of innovation and technology. So I do think there are things that are radical that aren't actually that difficult. And we've heard lots of examples today. I don't think it's one size fits all, so I think we need to be really careful. We heard earlier today concerns about digitalisation and some of the challenges that can bring. So we do need to be careful and to mind the gap. So I think but to me, we're standing on the point of really kind of a critical juncture in the Irish Health Service. And I often say this, that I think we're small enough to make it happen and big enough to make it count. We have a wonderful kind of complex tapestry of partners in the Irish health system, whether they're community development projects or social partners. And that makes for a much more successful solution, I think, in terms of that partnership, because I completely agree with you, you're correct. If you are finding it hard to articulate your voice, you do need support of a collective group, and we have had lovely examples of that. During the whole course of today. So I suppose from my perspective, I feel we're all on the same side. I think we can work in a really, I suppose, that whole idea of radical cooperation and interdependence strikes me as one that IFIC as an organisation has helped us frame in terms of the principles of integrated care, and find a base we can come back to, all of us, around some of those core values and principles.
I'm loving how you put that, and the importance that we don't forget anyone. Done seen, done heard, done voiced, done resourced, and no one should fall through the gap. I think that's been very clear across the board today, that doesn't happen no matter what road we go down. And I do agree with you that we have such a lovely journey ahead of us. We have a lot done and a lot more to do. And I'm really conscious we have a lot of key decision makers here on the stage, and we have some speakers here, and we have Siobhan here, and I'm asking you for 30 seconds if you had a wish, or a piece of advice for Siobhan, what would it be moving forward in the next year till we sit here? Don't all speak at once.
I guess I'll kick off, right?
Fire ahead, Joe.
Everyone's looking at you, Joe, anyway.
Oh, God. Look, back to the involving patients, Damien, you absolutely hit the nail on the head. That the idea that a patient is sitting on the opposite side of the bank from you, and it's a battle of trying to find a balance. When you allow the patient to understand your own limitations, it's amazing what the revelation you get from that is, oh, they get it, they understand this, and so that together you can solve the problem. Standing on the opposite banks, as to some extent we have been over years, but we've made huge progress in some areas in that. I think if we're willing and genuine about involving our patients and service users as a collective, as a safe collective, I really think that can make huge change.
Could I make a point? Just, obviously I'm from the north, so but my concern is that I see the big need actually in people like you. I think I don't see a need across society. I see society working in a much more integrated way but I see a real struggle for people who have power in this system and have been trained in a certain way. How do you divest that power? How do you be genuine? And how do you share the uncertainties of having to deal with unprecedented health need with limited financial resources and be genuine? So I guess it's back to your cooks out in the backs. The cooks need support as well as the punters. And how do you share vulnerability in your role of senior?
So I think I've worked for a long time, both as a clinician and as a manager, and I've worked with a lot of disadvantaged populations. Mary Bridget talked today about her experience as a primary healthcare project worker with the traveller community. So let me give you an example. Recently we did a big programme in this country called ECC, Enhanced Community Care, and it targeted cardiology, respiratory disease and diabetes. And a really fine project. The clinical leaders had designed it really well. But we were looking at one of our star projects in the area I managed, and we were saying, there's no travellers coming to this great project we've developed. So we went out to the primary healthcare project workers in the area, like Mary Bridget, and we said, the cardiologist is going to run a special clinic for the travellers. You want to come along? And now, I have to say, only that we had the peer educators, nobody would have shown up, right? And this is back to my principle of trust. People were really fearful. They didn't trust it. And the primary healthcare projects workers went out and they cajoled and coaxed and went with the people that attended the clinic. And all but one of the men, and they were quite young, who attended that cardiology clinic, needed to be seen, which was quite stark, given they were just a random population that were invited in. They weren't referred by GPs. So it struck us that we have to be very careful about targeted and mainstream approaches. I have to say the clinician in question was amazing in terms of his personal leadership, because he was shocked that there was such low levels of trust. And he went out and reached out to the community and went into their community to not just to invite them into the clinic, but to show that he did care, that he was concerned. But it takes that reach across to say, we are with you. We are here for you. And also, it's not one size fits all. We have to make sure that we don't just say, there's a clinic, it's great, come in. You know, sometimes we have to be really conscious and aware that that's not easy for some groups in our population. And so we have to make an extra effort. We have to have a targeted approach so that we mind the gap. A lovely project by the National Maternity Hospital with the traveller women, who again, they said weren't accessing antenatal care. And then it's about really turning that on its head and saying why. So it's the reasons for the reasons, actually. You know, it's not good enough to say they just don't access care. We have to find out what are the reasons behind the reasons.
I love that. Reasons for reasons.
I just want to say, I suppose, being outside of the HSC, I think it's a testament, you know, that over the 26 years that we've worked together, that we've built so much together. And what I spoke about today wouldn't have been possible without the trust of the likes of Martina and her colleagues. And I think the future of healthcare in Ireland is everybody working together, not just HSC and everybody else outside. The patient doesn't care who rocks up at the door to give the care that they need, as long as the care is the appropriate care in the appropriate place. So I think we shouldn't really differentiate as much as we do in regards to who we work for or who our paymaster is. We should all start, you know, working really closely together. And, you know, you maybe, Martina, opened something up in my mind there just now. You know, I'm starting to ask myself, have we done enough for the traveller community? You know, and they do access our services, you know, quite a bit, but I think there's more we can do for the more deprived areas going forward. And that's what I'll take from today.
Thank you. Lisa and Damien, 30 seconds.
All I would, I guess I would have to say is, like, just don't forget us. I feel like quite often we're sort of rolled out as an example of best practice, and we get lots of people come to visit us, but then we get quickly forgotten. And I think it's really, really and truly, things have to not be done to communities, but with them. And we've heard it so much today, but I think that's just so important in ensuring that that relationship doesn't end in divorce.
Martina said we're at a crossroads in terms of delivery of healthcare, and with that comes uncertainty. I think there's always this onus that people who are medical or health professionals have to have all the answers. So can we introduce a bit of honesty? Joe, you were saying about that piece of we need to respond. The OECD called it closing the feedback loop. So within those collective spaces, to be honest, is that we don't have the resources, or actually we don't know what that's going to look like. I think that's that embracing the fact that we're on a journey together. We're making the path by journeying down together. So we're going to get things wrong, but that's okay. That is part of trying to build systems that will work. I think moving away from the expert and the consultation and the community are going to be asked, and we go off and do things somewhere else, Wizard of Oz style, pull the curtain back. Let's get together and let's be honest about none of us really knows for certain how exactly this is going to work. But there is expertise in bringing disabled people together to their collective. There's expertise in terms of the workforce. But if there's a shared set of values around going, this will work much better for staff, it will much better in terms of effective, but it will really, really work much better because disabled people will direct you to what accessible, inclusive healthcare will look like, because they really, really know.
And I'd echo that as a disabled woman that's sitting here on the panel. If we build for people with disabilities, we're building for all for the future. And cost savings will be unbelievable. And I'd like to thank each of our panellists today for their hard work and putting in their presentations. Absolute amazing work you're doing, and look forward to seeing where the projects go from forward.
So thank you all very much, Gurmila Mahogov, for that fantastic advice. I've taken a lot of notes. I just think in a world where we see the disintegration of the Western Alliance and really good relationships through destruction, disruption, and lack of trust and lack of respect, it's fantastic to see people at the level of leadership here we've had here all day, and we have on the panel talking about safe spaces, about trust, and about the importance of respect and training and education. So I think a lot for us to take away, and I want to thank all our panellists here. Thank you very much this afternoon. Thank you.
There's still people in the audience. That's fantastic. Fair play to you for hanging in there to the bitter end. So it's really, can you believe it? Here we are, we're concluding the All-Ireland Conference for Integrated Care 25. I can't believe it. But I'd just like to, before I start, I do think I'd like to pick up on what Siobhan was saying, because I think it's very easy to be losing heart and to be losing hope at this point in time with what's happening around the world. But I hope that we have heard today about the importance of values and living values, and we must not accept the unacceptable. So now that you're all part of the family of IFIC, I think that we must sign up and show about how we live our lives, that we do not accept what's happening elsewhere in the world, and that actually we all live with a set of values, which is that we value everyone, we value everyone's voice and contribution. So let's live that as we leave here today. So my friends and colleagues, and indeed my kindred spirits in integrated care, I think it's important to say that we're concluding today, but this is not the end. It is just a continuation of our journey, which is a celebration of integrated care. And I invite you to reflect on what has been a fantastic day and the profound insights and the shared commitment that have emerged from our time together. I think today has been a real testament to our collective dedication to transforming integrated care across the island of Ireland, ensuring that it is both person-centred and indeed person-driven. So our theme was building a better future, workforce innovations for person-centred integrated care, and that has been at the heart of all our discussions. We have explored how to equip and support our workforce in all its riches with the necessary skills and tools to navigate the evolving landscape of primary, community-based and integrated care. And that includes addressing the global challenges of an ageing workforce and increasing demands. And that necessitates bold steps, such as shifting how we think about our workforce models. We need to think about expanded roles and indeed fostering strong interprofessional teams that include the person, the families, informal caregivers, and a broader view about what constitutes the workforce. And I think we've heard some really, really nice examples of that. We heard Bernard touching on what to me resonated with the concept of learning health systems. And Damien, you've talked about the importance of feedback loops. That's about a learning system. And Martin talked about democratising care through digital means. But I think we've talked a lot about democratization here in all its forms, not just digital. So I thought that was really nice to hear. And we've also delved into evidence-based strategies, and we've shared best practices. You've heard about living integrated care models that will shape the future of integrated care. And I think our discussions have really underscored the importance of co-producing services or co-designing services. And Damien, you touched on that on this session very strongly. And co-producing services with local populations, not just the chosen few, but actually with our neighbourhoods and our populations, so that we make sure that integrated care reflects the unique needs of our communities. And I think it's really important. The words I've heard today are about the importance of that relational, paying attention and intentional relational aspects and reciprocity. I think that's really important. So the other words that I picked up today were trust, the importance of safe spaces, the importance of living our values and culture, the importance of hope and the importance of co-creation. And I'm going away with the 1,250 compliance requirements, Joe. That was a bit, that really was a bit self-imposed trauma, really. But we've also been reminded that the future of health and care is at an inflection point or at a critical junction, or you said crossroads. So to deliver sustainable, person-centred and increasingly person and community-driven care, we must reimagine the broader, what constitutes the broader workforce. So whether that's volunteers, postmen, hairdressers, and our specialists. I'm not forgetting about you, and our specialists. So as we move forward with intent, let us carry with us not only the knowledge gained today, but also the momentum to implement these innovations. Because the work of integrated care continues beyond this conference. And in our hospitals, primary care centres, our communities, our policy discussions, and indeed in our homes and neighbourhoods. It continues in the relationships that we have strengthened today and in our unwavering commitment to drive meaningful change. So to all our speakers, panellists, and workshop leaders, thank you for sharing your expertise and passion. And to our partners and our sponsors, thank you very much for your help, because without you, this wouldn't have happened. To our hosts and to Abby in particular, sincere thanks for all the work that you did in making today possible. And thank each and every one of you for your energy, insights, and determination to build a healthier and more connected future for all. For those of you that this is your first All-Ireland conference, welcome to the IFIC family. And for those of you that have attended lots of our events, welcome back. And really good to see you again. And let's forge more stronger relationships and become even more connected. So let's leave here today inspired, recharged, and ready to take action, because integrated care is not just an aspiration, it is our responsibility. So, Gurmila Mahagiv Galer, safe travels, and in IFIC, we look forward to continuing this journey with you. Thank you very much.